wanna stay young. It's so hard to get old without a ghost. I don't wanna perish like a fading horse. Youth like diamonds in the sun, and diamonds are forever. Forever young, I wanna be forever young. Do you really wanna live forever, forever and ever? Forever young, I wanna be forever young. Do you really wanna live forever, forever, forever young? So many adventures keeping up to date. So many songs we forgot to play. So many dreams swinging out of the blue. I'll let it come true. La 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 la. Hush, don't speak. When you spit your venom, keep it shut. I hate it when you hiss and preach about your new messiah, 'cause your theories catch fire. I'm covering my ears like a kid. When your words mean nothing, I go la la la. I'm turning up the volume when you speak, 'cause in my heart can't stop it. I find a way to fuck it. I go la 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 la. I find a way to fuck it. I go la 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 la. I'm covering my ears like a kid. When your words mean nothing, I go la la la. I'm turning up the volume when you speak, 'cause in my heart can't stop it. I find a way to fuck it. I go la 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 la. If our love is running out of time, I won't count the hours. Rather be a coward when our worlds collide. I'm gonna drown you out before I lose my mind. I can't find your silver lining. I don't mean to judge, but when you read your speech, it's tiring. Enough is enough. I find a way to fuck it. I go I find a way to fuck it. I go la 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 la. I find a way to fuck it. I go la 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 la. Fuck it. I go la 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 la. I'm covering my ears like a kid. When your words mean nothing, I go la la la. I'm turning up the volume when you speak, 'cause in my heart can't stop it. I find a way to fuck it. I go. Your little brother never tells you, but he loves you so. You said your mother only smiled on her TV show. You're only happy when your sorry head is filled with dope. I hope you make it to the day you're 28 years old. You're dripping like a saturated sunrise. You're feeling like an overflowing sink. You're ripped at every edge, but you're a masterpiece. And now you're tearing through the pages and the ink. Everything is blue. His pearls, his hands, his jeans. And now I'm covered in the colors, pulled apart at the seams. And it's blue, and it's blue. Everything is gray. His hair is smoke, doing just fine before I met you. I drink too much and that's an issue, but I'm okay. Hey, you tell your friends it was nice to meet them, but I hope I never see them again. I know it breaks your heart. Moved to the city and I broke down car. And 4 years no calls. Now you're looking pretty in a hotel bar. And I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Buy that tattoo on your shoulder. Pull the sheets right out the corner of that mattress that you stole from your roommate back in Boulder. We ain't ever getting older.
이제 포럼을 시작하겠습니다. 자리에 착석해 주시기 바라겠습니다. Good morning, ladies and gentlemen. Welcome to the second day of our forums. I trust you had pleasant evenings. Yesterday, we shared inspiring lectures and meaningful discussions, and today we continue this journey with another series and distinguished session. Okay, we will now begin in today's program. The first session is Innovation in Tricuspid Regurgitation Surgery Intervention. This session will be chaired by Professor Satsuki Fukushima and Professor Jaewon Lee.
Yeah. Good morning, everyone. It is my great honor to moderate this important session this morning with Dr. Jaewon Lee. And let's get it started quickly. So the first talk is the state-of-the-art technique in tricuspid valve repair by Dr. Stephen Bowling. Thank you. So we have a distinguished panelists, 5 panelists here. Let's have a good discussion.
Once again, thank you very much for having me here in Seoul at the Heart Valve Forum. And I think many people are still in bed because had too much makgeolli last night. Right. So I'm going to talk about state-of-the-art tricuspid valve repair, and we really learned all these things yesterday. We made very much learning yesterday. So what to do about tricuspid regurgitation? First of all, we have to ask ourselves, and we have to think about what the state of art is. Is FTR important? Because mostly what we deal with is functional regurgitation. Yes, it is very important. It's the quality of life. FTR patients feel terrible. They feel terrible. What am I doing wrong? And they die. So mortality is caused by both severe and moderate tricuspid regurgitation. We must remember that this is not a benign lesion. Again, in this study by Topilsky, very importantly, severe and moderate FTR decreases survival. It hurts both the quality and quantity of life. TR is not good for people. We know that if we leave tricuspid regurgitation after surgery on the aortic valve or the mitral valve and so on like that, survival is worse if we leave TR. And even mild or moderate TR has a mortality injury to patients. TR is not benign to our patients. My ventricle is designed to have 0 tricuspid. So if I had my choice of having torrential, massive, severe, moderate, mild, trivial, or 0, we should all pick 0. We should remember this. Even after percutaneous intervention on the mitral side, leaving tricuspid regurgitation, the outcome is worse. I am a simple man from a small town in the Midwest of the United States, so I think of things in very small bits. TR is bad. So this is the state of the art. TR is bad. We used to maybe think that, TR is okay, we'll treat it with some Lasix, things are fine. But no, TR is bad. That is the most important thing to remember from this. The second thing, is there a lot of TR out there? Well, the answer is probably 25 or 35% of our patients who have mitral regurgitation have significant tricuspid regurgitation. There's lots of tricuspid regurgitation out there. Why is that? It's the interrelated anatomy of the left ventricle and the right ventricle. When you get mitral regurgitation, of course, your left ventricle enlarges to compensate for the increased stroke volume. Your right ventricle does not stay the same. It is connected to the left ventricle, and of course, it starts to enlarge, and this is the situation we end up with, a very large right ventricle, only because we have left-sided mitral disease. And in fact, 75% of patients with mitral regurgitation will have annular dilatation and flattening of the saddle of the tricuspid valve. 75% of patients with MR already have changes of their tricuspid valve. Well, let's step back and think, how does the tricuspid valve really work? Well, it is really functionally a bicuspid valve. It coacts the exact same as the mitral valve. The septal and posterior leaflets work together to catch the anterior leaflet in a Roman arch. They lock together to form a zone of coaptation. And that is a very stable architectural phenomenon. If you drop a keystone into a Roman arch, it is stable. This arch has been there over 2,000 years. The problem with the tricuspid valve is it doesn't have to be just formed once. How many times does your heart beat in your lifetime? 3 billion times that Roman arch has to catch itself over and over again. That Roman arch, of course, is based on the anterior septal width. As that opens up with the dilation of the LV and the dilation of the RV, we lose our keystone, and if we have no keystone, we obligatorily have tricuspid regurgitation start to occur. And in fact, if you look at this, as we talked about yesterday, the average size of the human tricuspid valve is 2.8 centimeters across. And you can see here in this very nice paper, if you have an annulus of 30, no one basically has tricuspid regurgitation. If you have an annulus of 40, everyone has tricuspid regurgitation. It's just math. So the math should work on TR annular reduction. And remember that when you and I look at it at the surgeon, where the annulus dilates is up and to the right-hand side. It cannot dilate to the left, that's where the aortic root is. It cannot dilate down, that's where the septum is. All the dilation occurs up and to the right. We must remember that thinking of our therapies. If you think of it, all the dilation is up and to the right on the clock face between 12 o'clock and maybe 5 o'clock. That's the only place. And therefore, when we put an annular ring in, we're really reducing the anterior septal distance, locking that Roman arch up, making that keystone come together. We reestablish the normal coaptation. So, does tricuspid valve repair, does annuloplasty work? The math says it should. Well, it does. This is the very first big paper in the literature, Gilles Dreyfus. 300 patients received TVR, half of them when they were doing mitrals. Now, none of these patients had severe, only very few had moderate. Most of the patients just had annular dilatation or mild. And you can see that it works great for TR. If you did not have a tricuspid annuloplasty, 50% of the patients moved on with their tricuspid regurgitation, where a tricuspid ring stabilizes that. We saw that all day yesterday. Even though maybe we couldn't see a mortality, all the groups in every paper, including the LVAD one, if you fix the tricuspid, you have less TR long term. We know that eventually TR will give you a mortality punishment. This is Jim Gammey's first paper. He said undersizing the tricuspid repair. In this paper, every single patient got a 28. So he wasn't really undersizing the valve. He was actually re-normal sizing the valve. And you can see these patients did extremely well. The mathematics of this would predict that these patients will do well. So, should you size an FTR? No, don't size. Don't size. Either put a 26 or a 28 ring in there, and that's what the tricuspid valve wants to be. We worry, will I get tricuspid stenosis? No, the mathematics of a 28 ring, the half of the radius is 1.4 times pi, 3.14. That is a 5 square centimeter annulus. There has never been a case of tricuspid stenosis reported with a 28 ring in the literature. It has never been reported. It cannot occur. So look at these other studies. This is David Adams of 400 patients with all 28 rings in there. The patients did extremely well. The pacemaker rate, 2% in this series. you can see that there is a beginning of a mortality separation between the patients who had an annuloplasty and who did not have an annuloplasty. Remember, the absence of proof is not the proof of absence. Just because we can't show it yet, if you ask a patient which group they would like to be in, they would like to be in the group with the tricuspid and annuloplasty. So what do the guidelines currently say? What is the state of art right now for the guidelines? Severe tricuspid, of course do that, both the American and European. Moderate or dilated, of course do that. This is what the guidelines tell us to do. So, this is our study exactly by the American guidelines. 262 consecutive patients with moderate or severe, or less than moderate and dilated. We had 1% progression of TR, and we had a 2% pacemaker rate. And this is our follow-up study of almost 500 patients at Michigan with tricuspid. Our recurrence rate is 4%. Yesterday, people talked about a recurrence rate of, 25 or 30% in TR. Maybe we shouldn't do it. Maybe it's not worth it. No. This is our series, all small rings, a 4% recurrence rate at 5 years. Even if we look at just the patients who had severe MR, there's only a 4% recurrence rate in the patients that started with severe TR. You can fix tricuspid regurgitation with a small annuloplasty ring. And in fact, surgeons know that. In the United States, when we take the patients to the operating room, we have a choice of replacing, or we can pour cement into the heart. It doesn't matter. We do anything we want. What do we do? 90% of the time, we do an annuloplasty. So, I'm a simple man. TR is bad. Tricuspid annuloplasty is good. So do we do tricuspid annuloplasty? No. No, we do not. Tricuspid annuloplasty is grossly underutilized in the United States. The average number of tricuspid annuloplasty per surgeon in the United States is 1 per year. 1 per surgeon per year. That is ridiculous. Just ridiculous. And in fact, if you look at the latest STS reporting, a class 2 indication, if you have moderate, only 40% of the time. And a class 1 indication, severe TR, you're there to do a left-sided lesion, only 80% of the time. 1 surgeon out of 5 does not do it even though they're severe. I asked the question to an audience of surgeons, how many of you would do severe TR? And everyone, of course, raises their hand. And I say to them, 20% of you are lying. So why don't we do it? Well, we used to think that the TR would go away by itself. If we fix the mitral, it would go away by itself. No. No. 60% of these patients in the Cleveland Clinic had residual disease. It does not go away by itself. And in fact, in these series, you are betting against your patient. 30, 40, 50, 60% of the time, it will not get better. You have hurt your patient. Why? Because it's like a rubber band that's stretched so much that it's then broken. And it continues to go. And we know there's nothing more vexing to be in the operating room a second time, 5 years later, when you were there doing the mitral and you did not do the tricuspid. Well, maybe we thought taking a single valve and making it a double valve procedure would add risk. No, in this nice Italian study, it actually makes the risk lower because the patients don't have TR in the intensive care unit and they are more stable hemodynamically. And in fact, this nice paper from Dr. Bodwar says, adding a tricuspid valve repair to a mitral valve repair does not add risk. So we were afraid of that as surgeons. It is just not true. We didn't know how to do it. Should we use a stitch? Should we use a ring? What kind of ring? I'll show you a lot of data. Use a ring. Less recurrent TR and better survival. Less recurrent TR and better survival. Cleveland's Clinic study, less recurrent TR, better survival. Jose Navia, less recurrent TR, better survival. Canadian one, less recurrent repair, better survival. I just showed you data on almost 4,000 cases. Use a rigid ring. We know how to do this operation now. Well, we thought, well, maybe if we fix the TR, the right ventricle will die. No, the right ventricle would get better. The right ventricle is built to put about 60 cc's forward and 0 backwards. So there is no pop-off effect. The right ventricle is not built to do 60 forward and 100 backwards. The right ventricle in all these studies get better. So what are we afraid of? We're afraid of the AV node. And this is the classic way, when I look at the clock, what time is it? If we put a stitch down at 8 o'clock, it is time to injure the AV node. So we do not do it that way anymore. And if you look at this study, the New England Journal study, concomitant TVR during mitral repair, you can see that there was much less progression of tricuspid regurgitation if we did a tricuspid aneuplasty. There's 10 times less recurrent TR. And in fact, 1,000 improvement in TR in this group. But in that study, there was a 14% pacemaker rate. That is amazingly awful. How did that happen? Because the surgeons came down and hit the AV node. Even despite that, you can see that in the group at 24 months, there is a separation, not significant yet, but there is a separation in survival between the group that had tricuspid and aneuplasty. And again, if you ask the patients, which line would you want to be on if you were a patient, you would say tricuspid aneuplasty. So this is the new rule, the rule of 10 that we all use. 10 o'clock to 6 o'clock, 10 stitches, 10 minutes. Do it with a cross clamp, do it with a heart beating, doesn't matter, but the rule of 10. Stay away from the triangle of Koch, stay away from the AV node. Every single manufacturer, Edwards, Medtronic, Abbott, Blabbit, Schmabbit, they all say this is how you should do it. Do not go anywhere near the AV node. So, TR is bad, aneuplasty is good, TVR is underutilized, and it should be used more. One other thing I want to talk about briefly is pacemaker lead, because this is something that's coming to us, and we need to know that. This is the state of the art. This is something we are going to have to deal with more and more. In fact, 10% of all leads, and we saw a very nice lecture yesterday about CIED-related pacemaker lead, 10% of all leads, and it's probably higher, have significant TR. And in fact, the problem with it is the average time from pacemaker implant to the time that they come to your operating room is 6 years. So that would be me telling Chris Malaysia to hold his arm out for 6 years. Hold your arm for 6 years, 6 years, 6 years, 6 years, and then telling Chris, drop your arm and now you can play tennis. No, when he holds it out for 6 years, what will happen when he tries to drop his arm? His arm is still there. So the leaflets become very fibrotic by the time. So extracting the leads will do nothing for these patients because the leaflet is held stiff and open and frozen. So we have to do something surgical. So this is what they often look like. It's either on, engaged to, or even right through the leaflet when we get there. You can see very nice that 3D echo is a very good way to see this. This is engaged on the septal leaflet. And we do not put on epicardial leads. We tuck them in the commissure, as was discussed yesterday. We leave that lead in there, and we usually put it inside the ring. You can see this case was stuck and riding on the septal leaflet. And we just move it around and we put this one in the posterior septal commissure, and then exclude it by putting a couple commissuroplasty stitches to keep the pacemaker outside of the center of the valve. And you can see that the postoperative result is perfect. So I think you have to be very aggressive about these patients surgically. Extracting the leads will not work. What about patch augmentation? Sometimes these leaflets after pacement are so fibrotic in there, we have to do patch augmentation. As we saw yesterday, you can patch the tricuspid valve. And as we saw yesterday, if you're going to put a patch in there, put a very big patch, a very oversized patch that probably will expect them to shrink down in the future. So that the patch is so big, when you do the valve test, all you see is the patch, basically. And this is an anterior leaflet patching. You can see that the anterior leaflet has been basically replaced by the patch itself. So we know now in the techniques, the state of the art is surgery has a toolbox of things that we can do. Leaflet things, annuloplasty is the basis of all of our therapy for tricuspid valve repair. What about percutaneous therapies? we must talk about percutaneous therapies when we talk about tricuspid because it is the state of the art. Perhaps not here in Korea right now, but certainly in the United States it is right now. Our patients think that. And in Korea it will be coming. It will be coming everywhere. So what is there out there? Well, there are annuloplasty devices, ring annuloplasty devices, other devices that are not what we would do at surgery. If we look at this, there's two major approved devices in the United States. One is the TriClip, which is basically the mitral clip moved from the mitral side to the tricuspid side. How does it do? Well, you can see that we leave these patients long-term, 50% of the patients are left with moderate to severe tricuspid regurgitation. That is not a good answer. This is not a good answer. And yet, in the randomized trial, this was approved by the FDA, and this is commercially available. If you look at the difference between death or need for tricuspid valve surgery, it's exactly the same in the clip and the not clip group. If you look at heart failure hospitalizations, it's exactly the same between the clip and the not clip group. And you must ask yourself, how did this get approved by the FDA? Well, again, we know that tricuspid regurgitation hurts both the quantity and the quality of life, and that in this study, the quality of life was actually improved in those patients who they got a good result, enough so that they had a quality of life indication. So the Trilumina trial basically showed no mortality benefit, no heart failure effect, no change in 6-minute walk test, but if you drop the TR to less than 2 grades, there was a positive trial, maybe. What are the other devices out? Well, if you look at the real-world results, the problem with the real-world results is that these patients are all left with severe tricuspid regurgitation. And you know, we had to reinvent the tricuspid scale to have torrential and massive and severe to show that we'd actually changed it for the patients. All the patients have severe in the real world. Well, if we can't do a repair with a CRIP with tricuspid, maybe we should replace them, percutaneous replacement. We are in both the EVOQUE trial and the Intrepid trial at Michigan, and we've used this. The problem with these devices is this. They're the size of a Diet Coke can. So this is the size of my tricuspid annulus, 28 millimeters. The devices we put in are 56 and 62 millimeters, and you can imagine that thin curvilinear right ventricle that's going around your left ventricle is now propped open and can no longer twist with the left ventricle. The problem with these devices, again, is a high screen fail rate because they're so large, procedural mortality because they're so bulky, pacemakers. We almost always get a pacemaker, but the biggest problem is RV non-recovery because we put this giant device in the base of the heart which splays the valve open. When you and I put a ring in, we're going to pull the base back down and reestablish normal geometry. And in fact, you can look at this New England Journal paper as long as you want, and I will even magnify it for you. And of course, there is no mortality difference between the group that has their tricuspid regurgitation completely extinguished and the group that has no therapy whatsoever. That's because even though their TR is gone, we have hurt the right ventricle. And in fact, the state of the art is we need a reality check on patients that come to us in TR. We saw yesterday talking about struggling to do surgeries in massive, severe, torrential, horrible tricuspid regurgitation. And the reality check is if these are the patients we operate on, a patient who has 1 foot in the grave and 1 foot on the banana peel, we will never see any difference. It is too late. It's like if I ask Chris, does he believe if he jumps out of a plane, would he like a parachute? Chris would say, yes, I will have a parachute, please. That's much better than not having a parachute. But what if I told Chris, you can use a parachute, but you can only pull the cord when you're 1 meter above the ground? What would happen? Chris would wait, pull it 1 meter above the ground, and Chris is dead. And we would think from that experiment that parachutes don't work. No, parachutes work just fine, but if you lose them too late, they don't work at all. We're doing the wrong experiment in this group of patients. And in fact, this very nice paper from Jack looks at the survival of severe patients treated medically and with surgery, and the survival is exactly the same. Any therapy done too late will not show a difference. And if these are the only patients we intervene on, we will never be able to tell a difference. So, in conclusion, I will say very simple things. TR is bad. No one here can argue that they want to have TR. We should not say that it is okay to leave our patients with moderate to severe. No, I would not want that for me or my family. TR is bad. Annuloplasty is good. Annuloplasty is the state of the art. We know how to do it. 10 o'clock to 6 o'clock. Make it small. Reestablish the Roman arch. TR is very underutilized. And my last statement is, I am a very much fan of Beyonce, and TR, put a ring on it. Thank you very much.
Thank you very much. It's a really brilliant talk. Dr. Bowling's contribution to the heart valve disease is outstanding in the last quarter centuries. And we learned a lot from his talk always, and we learned a lot, we enjoyed a lot as well. So any questions or comments from, any questions for Dr. Bowling from the panelists? Or let me say the fundamental questions. In the last 20 years, Duvega is predominated and a change to the ring annuloplasty. How do you think Duvega is cheap? How do you think it? Like a moderate TR, Duvega may be the best idea.
So that's a very good question. When I started my career, I was doing the Duvegas. And obviously, it has an advantage that it's cheap. It's a Prolene stitch or 2 Prolenes with 2 pledgets. It's very cheap. But it's cheap and it doesn't work. So no matter how cheap it is, if it doesn't work, the cost-value analysis says don't do it. And yes, a ring may cost hundreds of dollars, but you save patients' lives with the ring. And in fact, I learned this when I came to Michigan. I trained at Hopkins. When I came to Michigan, I was doing Duvegas, and my echo people started naming my Duvegas. They changed the name to Why Bother? Because it just doesn't work. So I would say don't do a Duvega. Our fellows have no idea what a Duvega is. We don't show it to them. We don't tell them about it. I know there are other considerations, but the cost consideration is very low because it just doesn't work.
Okay, thank you very much. Thank you. Yes, please.
Thank you for your great lecture. I have learned a lot from your very good lecture. And I have a short question. When we perform the surgery for severe TR, sometimes when we perform the repair, the patient sometimes remain the mild to moderate. I think the less than moderate. In that case, did you perform the repair in operation room or the observation?
That's a good question. So in reality, obviously, our goal is always 0. Our goal should be 0 MR when we repair the mitral, 0 TR when we repair the tricuspid. If we come off with mild TR, I will not go back on and do it again. Sorry. If we have moderate, I'll go back on and do something because I've probably thought about it in a wrong way. The better question is, we get a very consistent result. I think the better question is, when do I decide to replace the valve? Because those are the ones that I've said, okay, maybe I can take this ring that's 6 centimeters and bring it back down. I can't do that. So somewhere around 5.5 centimeters, I decide to myself, I cannot get an acceptable result. I will replace it. But anything lower than that, I know if I put a 26 ring in, the math of the size of the leaflets will tell me. Often I will bicuspidalize the septal and posterior leaflet together, JB, like we did the other day, because that makes that one, the septal posterior complex, really work like one leaflet and catch it. And oftentimes, as they dilate, those leaflets are pulled down, and again, they come to us late and they're fibrotic and they want to stay down. So I lift them up and so on. So that's a technique to bicuspidalize the 2 leaflets. But I think you can get a very good result with a small ring up to 5 or 5.5 centimeters.
Yeah. Today, the annuloplasty is good and TR is bad. This simple sentence has been carved into my head today. But when it comes to the torrential TR, I think sometimes the valvuloplasty is not enough to repair completely. So my question is, when you are taking every effort to repair the torrential TR, doing a leaflet augmentation and papillary muscle and chordal maneuvers and something like that. And of course, in addition to the ring annuloplasty. But is there any moment, a kind of anatomical threshold that strongly lead you to the valve replacement instead of repair?
When I see a patient with torrential TR, the first thing I try to repair is the thinking of my cardiologist, because they have thought wrong. As we talked about yesterday, where was that patient 5 years ago? The thing that I think of is not so much the size of the annulus, but the angle of the cords and papillary muscles to each other. So remember, both in the tricuspid and the mitral, the chordal apparatus and the papillary muscles should face each other so they can leap up during systole and lock on each other. But we've seen when the RV is very dilated and the papillary muscles go outwards, once they've turned from 90 degrees and they start tipping outwards, you can't get an annuloplasty to work. You would almost have to sew the valve shut to make that happen. So if they're still like this, and that has, in each patient, that may be a different size. But two things, I think, if I'm greater than 5 centimeters in the annulus, or I see reverse angulation of the papillary muscle, the RV is very dilated, then I think I cannot get a good repair, even with, augmentation and so on like that. Obviously, the valves that we have now for replacement are very good. Often these patients come to us later in life, they won't outlive the valve, and if they do outlive the valve, we will do a valve-in-valve tricuspid. And so I think those are the two things, absolute size and annulation, reverse annulation of the papillary apparatus. David,
please.
Great talk. So your presentation is so straightforward and strong that clear. I think of no question. It's pretty much threatening because I have to argue that no repair is reasonable in this afternoon against Chris. Okay, and I at least have 2 adversaries and maybe 10 more. So it's really pretty threatening. Simple question. So we have severe TR, and you put the ring, and then we also have discussion. We'll have discussions on papillary muscle reapproximation or other things to be discussed. What do you think about the subvalvular procedures in severe TR, and when do you decide to replace it in cases?
So I would say at Michigan, we do not do a subvalvular procedures. We tried them in my youth, and I did not enjoy them doing their redos. And so I think if I do have reverse angulation or severe dilation, I will replace the valve. That is my threshold to replace the valve. It is not in that group of patients. Every other patient, repair. But in that very specific small group, it is not criminal to replace the valve.
So you have only 2 options, ring or replacement?
Yes.
Okay, thank you.
Okay, thank you very much.
Thank you very much.
Thank you. So the next talk is Dr. Chris Leslie from the Northwestern University. Everyone knows Chris. We will have a great talk. So the managing functional tricuspid regurgitation, multidisciplinary perspective on surgery and beyond. Thank you, Chris.
Good morning. Thanks, Dr. Bowling, for setting the stage. I think it's the job of the rest of the speakers in the discussion day to unpack some very important concepts. TR is bad, annuloplasty is good. My job for this talk is to give some insight on what I think the future is for the multidisciplinary team, specifically what we can offer the team in the treatment of TR as surgeons. I'll talk about 3 things today. What do the current clinical practice guidelines, and I'll give some updates on the European guidelines that were just published 2 weeks ago. What do they say, what they don't say, and what is our role as surgeons in the multidisciplinary valve team? So let's start with a case, and this is going to be, we're pulling the parachute too late case. Think about this case I did a couple weeks ago. 78-year-old man, severe TR, previously admitted with heart failure, now class 3 after OMT. That's the best they could get him. Secondary to long-standing persistent atrial fibrillation. Host of comorbidities that make this patient unsavory. Previous esophagectomy, so we really can't do a TEE. Cancer is in remission. Biopsy of the liver, they always say fibrosis, but no cirrhosis. Who believes that sort of biopsy? This is a sick patient. All right, this is what we see on preoperative echocardiography. Secondary TR, which is the focus of the talk today. Secondary TR, we're not talking about carcinoid, not talking about prolapse, endocarditis. It's only dilatation, maybe some restriction, severe TR. Okay, think about that case as we go through this talk. The context of TR is primary versus secondary. Don't get confused about these alternative synonyms. So primary is also organic. Secondary is also functional. So functional is a secondary TR. Secondary to something else, whether that's ventricular TR, functional TR, or atrial functional TR. These are the current clinical practice guidelines. You'll notice that they're both class 2A recommendations, not class 1, like you should not, it doesn't say you should do something here. Class 2, it is reasonable to offer surgery for severe and symptomatic. The Europeans add asymptomatic with moderate RV dilatation that's not too severe. Only a class 2 recommendation. Think about that. Why is that? Well, when we look at the outcomes of TV surgery in the past, we have never really done a good job showing that there is a survival benefit. I've looked long and hard, and only Jaewon Lee's publication here in 2010 has shown any significant separation of curves. You could see that on the left side. It's only because they did such a great job with surgery. Almost 0% death. Even after propensity matching, the separation of curves exists, but p-value is only 0.068. We have not done a good job demonstrating survival benefit for TV surgery. Most of the curves you see for survival look exactly like this. Surgery has the same mortality as doing medical management. We've not done a good job. What we have done a good job at showing is that the risk of TV surgery is bad. So 2017, looking at large population study, operations for TV surgery has gone up, both replacement and repair. Mortality is still no good. Who would offer an operation or even send their patient for an operation that has a risk of 8.8%? This is not a good outcome. It has gotten better. This is the most recent look at the STS guidelines, published in 2024. Good news is operative mortality is going down, as are the rest of the complications, but we're still sitting at an operative mortality of 5.6%. This is really high when you consider that isolated mitral valve repair is associated with less than a 0.5% 30-day mortality. So that's a lot, tenfold difference. What about the outcomes from transcatheter tricuspid valve interventions? Well, they're really no better. These are two randomized clinical trials looking at the TriClip device. And like Dr. Bowling said, you could look long and hard at these two curves, but there are no demonstrated survival benefit with TriClip in both the TriLuminate trial that was conducted mostly in the United States and the TriFR, meaning French trial. There's no separation of curves at all, no survival difference with the use of T-TEER. Similarly for the EVOQUE valve, which is a complete replacement valve, goes up through the groin. Pretty amazing to me that they could shove a 5-centimeter valve into a catheter about this big. The curves on the left also demonstrate no survival benefit, 0. Both devices did show an improvement in symptoms, and that's what led to FDA approval for both devices. The TriClip was approved in 2024, and the EVOQUE valve was also similarly approved just last year. So these are actively being used in the United States. So updated guidelines now have added transcatheter tricuspid valve intervention as a class 2A. They give it a level of evidence A because of the randomized clinical trials. But pay attention to this language from the Europeans. for high-risk surgery patients. So low-risk surgery patients should not get this, should probably get surgery. We could pull the cord earlier and save our patients and get a better result. How do we know if the patient is high risk? You have two tools available for you. Here's the tri-score. If you're in Europe, this can estimate the risk for tricuspid valve surgery. What I use is the STS risk calculator. This was just released last year for isolated TV repair. It will give you a number as STS Prom does. This is one of the most important things we can do as heart surgeons when we show up to multidisciplinary team, is declare that this patient is a low-risk patient, should not get transcatheter, but will do better with surgery. Last point I'm going to make is that repair is better than replacement for TV surgery. Going back to the guidelines, you read the text, they'll add a couple of text lines in there that say that repair is preferred over TV replacement when possible. We've demonstrated from the STS database that the addition of TV repair is safe. So operative mortality is safer than a TV replacement. So 30-day mortality, you can see the top curve. Operative mortality has an odds ratio that disfavors replacement, so has a 56% higher risk of operative mortality, as are the other complications associated with surgery. STS. So STS database, TV repair is safer than replacement. The Europeans have gone further and demonstrated a long-term survival benefit after TV repair as compared to replacement. You'll see the blue line is the repair group. Out to 10 years, a 61% survival rate. This is compared to the gray line, the replacement line, 30%. This is twice the survival. You compare replacement, repair versus replacement. Why I think that replacement is worse than repair is clearly the heart block. There's a higher threefold risk of heart block after surgery. This is one of the reasons I prefer to do my tricuspid valve operations with a beating heart, so no aortic cross clamp, because you can see this pretty cool effect here. So this is a tricuspid valve replacement I'm doing through a mini thoracotomy tricuspid valve, and I'm trying to take the thinnest bite as possible, and the heart stops beating. So that's pretty cool. So we just take that stitch out and replace it somewhere else. So back to our case study. So of course, this 78-year-old man with severe symptomatic functional TR, secondary to atrial fibrillation, was not a candidate for TTR or TMBR, turned down. We're going to see more of these patients, transcatheter turned down. So I did a sternotomy, TV repair with a 30-millimeter contour ring, so an undersized ring. I think the contour is just a little bit bigger than the MC cubed. Coxmaze 3 with an AtriCure, Cryo 2, and close the appendage with a Flex Mini. This is the outcome. We get nice coaptation because we've narrowed the annulus so much that there is 0 TR. I'll leave with one last thing. Atrial functional TR, I think, is going to be an area of research for us in the future. But please, if your patient has atrial fibrillation, at least close the left atrial appendage. They've made it so easy now to close the left atrial appendage with multiple devices. This is just one device that I like to use. This is from a sternotomy. I'm standing on the patient's left side. You measure the base of the left atrial appendage. This is the newest AtriClip device. It's a closed loop. And you remember Whitlock's study, LEOS 3, the addition of left atrial appendage closure was associated with a 33% reduction risk of stroke. This clip, you can nudge pretty much the entire left atrial appendage inside here without tearing anything, so we avoid having any stumps. I think it's impossible to have any leaks with a clip. 30 seconds to reduce the patient's risk of stroke by 33%. Please do the left atrial appendage occlusion. So in conclusion, guidelines acknowledge that there is no survival benefit when we treat tricuspid regurgitation for functional TR, either with surgery or transcatheter interventions. They're all class 2A. Because it's a class 2 recommendation to intervene on these patients, it demands that we have a well-functioning multidisciplinary heart team. I think there's two things that surgeons can contribute to the decision-making in our MDTs. The first is risk assessment. You have tools for doing that. STS Prom is an excellent one to identify the low-risk patients that could go for surgery. I think for surgery, as we heard, annuloplasty is good. Repair is better than replacement. And please address concomitant disease to the TR, especially atrial fibrillation. Thank you very much.
Thank you very much, Chris. That's brilliant talk again. Yes, please.
Chris, thank you for your excellent lecture, and your presentation always is fantastic every time. So I have very short questions. What do you think about the optimal timings in surgery in iris TR? Because as many cardiologists transfer to me only in the massive interventional TR, and if the patient is not good, so they are say to me that just surgery is a very high risk in this patient. So I always say that only transfers to me for isolated TR. So what is optimal timings in patient to intervention or surgery in isolated TRs? What's your opinion?
Yeah, I think we're really good at identifying when patients are too late to surgery. The early patients are harder ones to get. I try to tell the cardiologist that look for other reasons that we can treat your patient. I mean, for instance, if they've got like a single vessel coronary artery disease, maybe they've got some moderate MR, maybe they've got some other valvular heart disease, especially atrial fibrillation. They always forget the atrial fibrillation. Well, why is there a severe TR? Because there's TR. Well, we know we can treat the atrial fibrillation. So I asked them to look for concomitant disease.
Thank you. Dr. Bowling, please.
Chris, very great talk. Your comments on the separation in our thinking between patients who have isolated TR, which you show the data from, isolated TR operations, and those that have concomitant TR operations. It's a class 1 indication to add a tricuspid ring in someone who has TR at the time of left-sided valvular surgery. So let's not be confused about that. That is a class 1. However, isolated TR is different. That is one that has a 5% mortality, because those patients are one of two groups. Either those patients had mitral disease and we did not fix the TR at the same time, so they're sicker, or they have something else going on in their pulmonary bed. So when I see someone with isolated TR, that raises a red flag to me. Your comment on the difference between the isolated TR and the not isolated TR.
Yeah, I agree. I mean, it's secondary to something. Well, what is that something? The patient just doesn't come out with TR, that's primary TR. So there's a different approach for primary TR. Class 1 recommendation to fix primary TR, but when it's functional or secondary, look for why that TR is occurring.
It's great talk, Chris. So let us think about a case, massive torrential TR with annular dilatation of 5 centimeter. And then we can put ring on that, but there will be some risk of residual mild moderate TR. Then you said repair should be always better than replacement. Then which one between leaving some moderate TR or having a risk of permanent pacemaker implantation by TVR? What do you think?
Yeah, I'd like to make a comment on massive and torrential TR, like these annuluses that look like 6 centimeters. I'm not scared to ring that. If you're scared that the rigid ring is going to tear through or not hold stitches, that's actually a good time to do a de Vega first. So you can do a de Vega first to partially narrow it down halfway, and then you could put your rigid ring on top. I'm not afraid of these huge 6 centimeter annulus to repair. They actually look pretty good afterwards because there's so much leaflet. There's so much leaflet that's stretched out that once you bring that ring in and bring the leaflets back together, I actually don't expect much TR at all after that.
So let me add one more point, that in the guidelines, the comments is like repair is preferred over replacement, and these are backed up by all the observational study, and then they are all subject to the limitation of selection bias. And very recently, we tried to look at the a really fair comparisons between the repair and T-valve replacement, and found out that outcomes are pretty similar. If we adjust for baseline profiles. So T-valve replacement patients are always worse than repair, and that's the core reason why we see different outcomes. But when we take a very detailed look at the annulus diameter and outcomes, and we saw better outcomes in subgroup of very large T-valve annulus when we did replacement, and replacements were better in cases with very huge annulus. What do you think on that? So we also saw several cases of annular tone down. We didn't do the Vega ring complex, and yeah, it's not easy. Then replacement should also be considered. In my thought that it's not bad thing, and you can also choose it whenever needed, such as such cases.
Yeah, I think so. It's multifactorial, of course. A good replacement is better than a bad repair, another concept to think about. But there's no denying there's a higher risk of pacemaker with the replacement. You're putting stitches somewhere near the triangle of Koch. You just can't avoid that. And you also think about valve thrombosis with, you could put definitely with a mechanical valve, but there's also valve thrombosis associated with a bioprosthetic valve. We've seen that in the EVOKE trial. There is valve thrombosis risk, I think of almost about a 5% risk. All these patients, even with a biovalve, have to end up on anticoagulation.
Hi, Chris. Thank you for great talk. I have a question. So sorry.
It's okay. Please.
Sorry.
I can wait.
So, unfortunately, our country just used the tricuspid ring. We can use the MC3 and triad. We just two options. But in case of the torrential tear, you use the rigid ring. Your thing or the Steve, any difference? Many kinds of ring product. There are any different result that ring affect the result? What did you think about that?
All right, so my preference on rings, well, there's two reasons I have to use the complete ring. The first is MC cubed is my boss's ring, Pat McCarthy. Yes, I have to use. That's one good reason. We've actually never seen a higher risk of pacemaker using that ring. I think you just have to just put it in correctly. The second thing to think about is with a triad ring, because it's incomplete, there is no chance you're going to be able to do a valve and ring case, as opposed to you put in an MC3, a physio tricuspid, Medtronic Contour 3D, which is almost a complete circle. You can do a tricuspid valve and ring actually pretty well with that.
Thank you, Joshi. Please.
Chris, great talk, as always. In your practice, after all these tricuspid trials came on, are you doing more isolated tricuspid surgical cases? Because I can tell you in my experience, when the Triluminate and the Tricentral started, I started doing more and more of these isolated tricuspid cases. However, once they got FDA approved, they were growing. It just plummeted. Because I think all the industry, now it's commercialized. They don't have a rigid criteria. They will approve these cases to go. They give green for almost everything. So because of that FDA approval for both devices, my personal experience has not been, climbing as much as I thought. How about yours? How's your experience been?
Well, baseline before these transcatheter options came available, isolated TR cases are very rare. So we're not losing something that we already had. It's not like aortic stenosis where we had a lot of cases and we lose it. Like TR cases, we never really had a lot of those to begin with. So I'm seeing I'm seeing more tricuspid valve cases because of all the turndowns. We see a lot of patients come in, a lot of them go to transcatheter, but a lot of them are turned downs. There's a second group of patients that we're gonna see, and everything we've put in, I've taken out. So I've taken out EVOKE, I've taken out TriClips, I've taken out Pascals. The failures are gonna come.
Which is ironic, because in the guideline it says, the high risk should go for transcatheter, and the surgery should be the first option. And we're not just seeing that, unfortunately.
Thank you.
Thank you for your. Can I get one question, Chris? So I'm sorry. So I really wondering of this topic. So because when I performed the severe TR because of atrial fibrillation, so I, as a beginner surgeon for minimal invasive surgery, I have been struggling to do a procedure for aortic via the thoracotomy. So what do you think of the proper approach for the tricuspid regurgitation because of atrial fibrillation to perform the aortic procedure?
Yeah. My interest is how big the atria are. If the atria are blown out because AFib has been there for like 5 to 10 years, there's no ablation that we can do that can cure that. That's actually not it's a recommendation against doing AF ablation. You got a huge left atrium. So I would just do a clip for those cases and skip the AF ablation, fix the TR, and get out. Another thing I think about is I also like to do right-chested approaches, is whether or not the patient has liver disease and can tolerate a long pump time. I like doing mixed tricuspid, but I'm faster through a full sternotomy. So if I think I can cut at least even 10 minutes off of the pump time with liver cases, I'd try to do the quickest case possible.
Thank you. Thank you, Liz.
I'll chair next 2 sessions. I think the fate of isolated TR should be the same as the ischemic MR. There may be disappear from surgical field. Next session will be pivot balloon catheter in tricuspid valve. First speaker is Dr. Junho Han. He graduated from Seoul National University, and he was a fellow in Stanford and now in Samsung Medical Center. Please go ahead.
Thank you, Chairman. Good morning, everyone. I'm Ju Han from Samsung Medical Center, Seoul, Korea. I would like to thank the kind of invitation, and I'm very pleased to be here. These are my disclosures. This slide summarizes the current transcatheter therapies for TR, such as edge-to-edge repair system, triclip Pascal, and annuloplasty, such as cardioband, and coaptation device, such as spacer, and TTVR, and heterotopic K-valve valve implantation. Of this, coaptation device, such as spacer, might be not familiar to you. Spacer has the unique advantage that do not manipulate the valve leaflet or annulus, and do not interfere the future surgical or transcatheter procedure. This figure schematizes the Forma system, the prototype of the spacer. It has a very unique and creative, but has some disadvantage. It needs the exact coaxial adjustment and need traumatic anchoring in the RV. The pivot TR is a novel, vertical, self-centering spacer without anchoring structure. The procedure is relatively simple. It takes typically less than 20 minutes. It does not require complex imaging guidance, such as TEE or ICE. It can deal with TR with a large gap and is less dependent in annular or RV size. It can be retrieved if needed within 2 to 4 weeks. The pivot TR device is made by Tau Medical in Korea. This slide summarizes a pivot TL family, pivot balloon, bridging, and extend. Pivot balloon is the device for proof of concept of the vertical space of pivot system. It is made for temporary indwelling, typically a couple of minutes. It proved the concept successfully in the first in human trial, and we reported the results of this first in human trial in Korean Circulation Journal this year. The patient has torrential TR after pivot balloon implantation. The TR was markedly reduced. In this first in human trial, a total of 7 patients was enrolled. The mean age was 76, and the female patients were predominant. The patients had several comorbidities, such as AFib, chronic kidney dysfunction, and diabetes. The device was successfully implanted in all patients, and the mean puncture to deploy time was only 20 minutes. During the pivot balloon implantation, TR was markedly reduced in terms of TR jet area, effective regurgitant to orifice area, and so on. At baseline, all patients had torrential or severe TR, but during the balloon implantation, only 1 patient showed severe TR. In summary, the pivot balloon system is safe, feasible, and effective for TR reduction in human. The procedure was easily performed within a relatively short time frame under fluoroscopic and TT guidance. After optimizing the device position, the average reduction in TR was 2 grade, and no cases of RV intolerance were observed in any of the patients. No adverse events were observed, not only during the procedure, but also at the time of device retrieval. Based on these initial results, we moved to develop pivot bridge. It was designed for a short-term implantation, typically less than 1 week. It can bridge patients to other treatments such as surgery or device. It consists of a pivot axis and an expandable 3D leaflet, and its proximal end was spiral-shaped to embrace the device itself against the IVC wall. The procedure was typically done through right femoral vein, and the distal tip of the pivot bridge is located right lower pulmonary artery. After the appropriate position is achieved, gentle unsheathing allows expanding of the spacer and IVC spiral anchor. It does not need a traumatic anchor system in the RV. It is made of nitinol massy with a EPT-FE coat. And the size of spiral anchor is 4 or 5 centimeter, and several specification is available. It's a 20 French introducer is compatible. Let's take a look at the short animation for the procedure. The wire is located right pulmonary artery. And after that, the device is advanced over the wire. After the appropriate position is achieved, gentle unseating of device allows expanding the spacer and IVC spiral shape. The mean procedure time was 47 minutes for this procedure. I'd like to share representative cases. 64 male patients was recurrently hospitalized due to heart failure. Echocardiography showed torrential TR. The coaptation was not done with a large gap, and RV was D-shaped, and IVC showed a plethora. We decided to implant the pivot bridge for this patient. First, curved pigtail catheter was located into the pulmonary artery. After that, wire was positioned in the right lower pulmonary artery. Pulmonary angiography was done. Based on the angiographic information, the wire was repositioned into the more appropriate branch. The wire was exchanged into the stiff wire. And after that, the Swan-Gonj catheter was advanced to exclude the possibility of coda entanglement. After that, the pivot TR system was advanced over the stiff wire. If the position is appropriate by TTE and fluoroscopy, gentle unsheath was done to allow expanding the spacer. And after that, the further unsheathing allows to expand the distal spiral-shaped end. If everything is okay, detach is done, and after detachment, the spacer is still shows a stabilized position. So after the implantation of pivot bridge, the amount of TR was markedly reduced. D-shaped and the plethora disappeared. We conducted a first-in-human trial for the pivot bridge in South Korea. A total of 15 patients were enrolled. The pivot bridge was successfully implanted in all patients, and 10 patients underwent open heart surgery with TV repair in 9 and TV replaced in 1 patient. Pivot bridge was retrieved during the surgery. And in 5 patients, the patient's status was stabilized by medical treatment only. In these patients, the pivot bridge was retrieved percutaneously. The mean age was 68, and the patient had several comorbidities. In echocardiography and CT analysis, the annulus diameter was about 5 centimeter, and the coaptation gap was 10 millimeter. And 13 patients showed massive to torrential TR. In CT analysis, RV and diastolic volume was 330. That means these patients had far advanced severe functional TR with markedly dilated RV and IVC. These features challenged to treatment by other modality of transcatheter therapy, such as triclip, evoke valve, or annuloplasty. TR was markedly reduced in terms of EROA and vena contracta by about 50%. And at baseline, most patients had massive to torrential TR, but at follow-up, 1/3 of patients had mild to moderate TR, and none of them showed torrential TR. The procedure was successful in all patients when it was defined by 1 grade reduction or more. Venous function improved, and the peripheral edema was decreased, and the symptomatic status was also improved. RV volume decreased by 8%, and annulus area was also decreased by 10% in spite of a very short-term indwelling period. The treatment effect of the pivot bridge was consistent even in patients with a torrential TR and a large annulus. Major adverse outcomes occurred in 1 patient who had gastric ulcer bleeding. Minor adverse outcomes occurred in 3 patients, puncture site hematoma in 2, and transient bacteremia in 1 patient. The spacer position was changed slightly in 2 patients due to too big IVC size, but TR reduction was maintained without causing any other adverse effect. In summary, pivot bridge, the vertical TR spacer, significantly reduced TR in patients with suboptimal medical control, leading to symptom alleviation and stabilization during short-term implantation in this first-in-human study. Procedure for a pivot bridge can be done relatively easily, quickly, and safely under fluoroscopic and thoracic echocardiography guidance. Additionally, pivot bridge prompted a favorable change of TV geometry and RV volume reduction, which can adapt the patients to the subsequent corrective procedure, such as open surgery or other devices. So the pivot bridge play an adjunctive role on top of a medical treatment in patients with medically refractory TR. For the next step, we developed pivot extend for a permanent implantation. This device was improved in several aspects compared with a pivot bridge. This device was successfully implanted in Germany for compassionate use, and we will conduct first-in-human trial soon in South Korea. Thank you for your attention.
Thank you. Discussion will be done after next presentation. Next presenter is Dr. Jae Heng-kwon, who is actually very famous in Korea, and he's from Asan Medical Center, and now he's in Bundang Seoul National University Hospital. Please go ahead.
Thank you, Chairman. Good morning, ladies and gentlemen. There are nothing disclosed about this talk. When I was a resident at the time, Professor Lee, he is my boss in the valve section. When we encountered torrential TL patient with severe hepatorenal failure, as you can see, there are neck pain pulsation, and intractable ascites, severe pitting edema. The septolateral dimension is over 5 centimeters. They are torrential TL. At the time, he taught us we should dry the patient. So we admitted the patient and gave IV Lasix and IV dobutamine and make the patient as thinner as possible. So this is my patient. I operated him in 2012. Pre-op volume reduction was done for 18 days. 17 kilogram weight loss was achieved with medication. And then finally, I did the redo tricuspid valve replacement via mini-thoracotomy approach. But recently, many cardiologists, they just start to name it prehab to optimize the patient condition before TTR. So they give IV drugs, and sometimes they tilt the table during their TTR program. One paper says during the tricuspid TR program, when they tilt the 10 degree of the radiographic table, it decreased the 25% of gap, and the area can be achieved with the simple tilting the table. And the annual parameter of the T-valve reduction about 4%. With this simple maneuver, they can achieve 100% technical success, and they got about 95% of TR reduction. So, as we all know, the severe massive torrential TR is bad, and prehab, somewhere, somehow, we already done it, but data of T-valve surgery is limited. So I collected data of the 2 tertiary centers between 2012 and this year. Inclusion was adult T-valve surgery patient with a severe or greater TL. Exclusion is emergency endocarditis, absent anomaly, and concomitant thoracic aortic surgery, transplant, LVAD, and pericardiectomy. After exclusion, the severe or greater TR was 224 patients. About 30% of them we done prehab procedures. Method of prehab is admitted before the operation, three or more days before operation, and some IBO or high dose of oral furosemide or equivalent dose of other diuretics. Or some patients need dialysis, or 3 of them have pivot balloon you saw before. We checked the safety about the change of the hepatorenal function. And efficacy was evaluated with the weight reduction. There are no studies such as this kind of paper, so arbitrarily I just made it 5% weight reduction as a responder or non-responder. So about 40% was non-responder, about 60% was a responder. Prep day was median was about a week with admission. Most of them done with the diuretics. Non-responder, they are about 1 or 2 kilogram of weight loss, but responder group was 5.5 kilogram weight loss. Interestingly, there are no significant changes of hemoglobin, platelet, and albumin, and creatinine. I worried about when we gave a high dose of diuretics. Acute renal failure was worried, but not happened in those cases. The pre-op data is quite similar between the two. Only non-responder group has a higher serum creatinine level. That is the reason why their volume reduction was not effective. They are quite sick patient. Functional class 3, 4, dyspnea was about 60%, 70 to 80%. Stage 4, 5, chronic kidney disease is quite common. Euroscore was about 10 to 11% in both groups. Operation data, non-responder group has a little bit bigger atrium and a higher pulmonary arterial pressure. Isolated T-valve surgery was done about 50%. T-valve repair was done about 70%. 30% of them was reoperation. Minimal invasive approach was done in about half and half. Pump time and cross-clamp time is about 100 minutes over 85 minutes. actually, I expected the responder group will show the better early operative outcome. But yeah, my expectation was wrong. Major comorbidity was the same. Mechanical support, prolonged ventilation, tracheostomy, and transfusion incidence was quite similar between the two. But the thing is, the pulmonary artery pressure was decreased numerically more in responder group, and LA diameter was decreased to smaller. But hospital stay and ICU stay was similar. But surprisingly, when we follow up longer, non-responder group, they died more in 3.8 years median follow-up. So in summary of prehab, prehab is work in selected patient. And although early outcome was similar, responder group shows better survival. So I wanted to have new device, except just IV dobutamine and Lasix. But there are no such device retrievable. Atraumatic deployment is possible, so no such things. Every single device, they prevent further repair of tricuspid valve. So as Dr. Han, previous speaker, says, the people TL, it has basic research with the animal form. You saw it before. I will skip this animation. And they published the first in-man study in this year. I skipped this. The best thing is it needs only 30 to 50 minutes to apply. The concept of surgeon or people bridge is every Monday they decide to, they put the people balloon to the tricuspid valve of the patient, and every Friday I operate them. So 5 days span of the prehab with this atraumatic spacer and tricuspid valve. I operate 3 patients. One is combined CABG and tricuspid valve repair. 2 is just beating out isolate TL patient. 5 days application of the PIVA balloon. Pre-PIVA bridge, all patient has functional class 3 dyspnea, and this is basic their kidney function and Euro score. Functional class decreased one grade in 5 days, and body weight changed about 0.5 kilogram to 3.2 kilogram. And I did beating out T valve repair with the club technique in 2 patients. Both of them, all 3 patients discharged on foot within 1 week. You can see ICU stays 1 day and go back to home in 4 days. T valve annual change was dramatic, about 12% decrease. And before pivot balloon, all patients with a significant, severe or greater TL. And during the pivot, 1 or 2 grade down. And then after T valve repair, every patient has 0 TL. The change of the size of ventricle, I will show you the surgical video clip. This is the last patient. Pump time was 42 minutes. It's a beating heart, no ACC. Oral extubation was done. He came back to his home in 4 days. And mini thoracotomy, I opened the airway first, and then put SBS cannula through the aortomy, and then removal of the pivot balloon. As you see, it's quite easy to removal because there are no hard fixation in this device. The first, remove the pulmonary artery part, and then just pulling, gentle pulling of the IVC part is enough. And as surgeon's perspectives, there are no thrombus in it. The nitinol and Gore-Tex covered the frame. Before I talked to my echocardiologist, they said coaptation gap is over 1.5 centimeters, so there are high possibility of T valve replacement. But when I look at the valve after removal of balloon, repair can be possible because the tip of the leaflets can touch together. So I put MC3 ring, and I use the cornut. And the beauty of the beating heart surgery is I can check the saline test more effectively because I wanted to make it perfect. There are some hard and fibrous portion of the anterior leaflet can be defined, so I added Clover technique to this patient. So, yeah, as I told you, the pump time was 42 minutes. The patient maybe whole operation time is less than 2 hours, I think. So the summary is people balloon is easily, quickly, and safely done with the fluoroscopy guidance. And with this balloon, we can bridge the patient and we can rehab the patient. So during the bridge period, unmasking of LV dysfunction can be achieved and favorable repair of the highly dilated patient. This is my talk. Thank you.
It is the beginning of K culture in medicine. Let's start.
I have a question. Yep, Prof. J and Professor Han frequently said I was a KFD investigator of this study and this device. So I know before I saw many papers and then result of the study before. So, so I accept every study because of very good result and a very good design of the whole study. Right? Congratulations. So my simple question is how I don't know who made this device. How you get the idea of make this kind of device? I saw the report before. So one of a similar device before. So I think get the idea from that and then develop this device. I think. Please explain how make this kinds of device.
Yeah, this device was invented by Professor Junhong Kim in Yangsan, Busan National University Hospital. So as you mentioned, he might be inspired by the former system. As I presented as I show in my presentation, the former system is the prototype of the spacer device. It is very creative, but as I mentioned, it has two disadvantages. It needs the very accurate coaxial adjustment, and it has to be fixed using LV anchoring system. So in the pivot TR system, it does not need the anchoring system, and the vertical spacer is more easily centrally positioned.
I want adding some history of it. Actually, Junhong Kim is my ex-colleague. He's a cardiologist. He spent 2 years in NIH in US, and he developed a suckless mitral annuloplasty system, interventional. It's the wire going to the septal vein, and he selected septal vein, cardiac septal vein, and pulling out the septal, he just punctured the septum. It just go into the coronary sinus and encircle the mitral annulus and go back to the interventricular septum LV side and pulling it to the LA and squeeze it. A couple of papers are written down. And unfortunately, he did about 90 or 95% of all the invention process, but the copyright things and some financial problem, there's some conflict between the Korean American doctors. So he quit those invention and he changed his idea because he already has a wire from the septal interventricular septum to tricuspid annulus. So he tried to put something in that area. between the interventricular septum and tricuspid valve. So initially, he tried to put some kind of some spacer between them, and try to fixation of that area. But the problem is quite big. That thing is quite big. So it cannot go through the septal vein. So he changed his mind, IVC fixation to the pulmonary artery fixation. So it's maybe about 10 years history of that, and he did many animal tests.
Dr. Han, I have some comment on. Actually, 2 of my patients die on waiting for that trial. That is a problem. And another one is I don't like the direction of the valve balloon. That is directed this way. I think that should be go ventricular way, and that balloon should be at the anterior, posterior, or anteroseptal, that area. But it is at the septal area.
That's that idea. Coaxial position is very instinctive, but as the former system was failed, the coaxial system need very accurate adjustment. If the line is inaccurate, the efficacy was very reduced. On the opposite, the vertical spacer is a little bit freely movable and self-centering position. So initially, the coaxial system seems to be more appropriate, but in reality, the vertical system is safer and self-centering. It does not need any accurate adjustment.
Dr. Bowring?
Two comments on that. I had the very same question that other devices, they appear to have to be coaxial to the plane of the tricuspid valve to work. And I would have thought that this did not work, but obviously it does work from the echo. So that's interesting. The second thing was in regard to your question, having done many startup companies and many products, and I'm going to talk about that at lunchtime. The history of this is, and every device is fail, 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 change, pivot, fail, fail some more, succeed. So you should be congratulated on this. Thank you.
Thanks for a great talk. I have some question for this device, and I don't understand exactly the purpose of a device. Is this device just for bridging to surgery or medication? And really, this device can affect for decision for ring size or surgical strategy for T-valve repair, such as ring size or something replace, or I think urgent operation is better, I think, for this kind of pivot period. Adequate medication or management, I think, is more important than this kind of device. It looks like very, very hazard rather than pacemaker read, I think. Yeah?
My ideas differ. When you operate urgently, those very downhill hepatorenal failure with severe torrential TR patient, you go straight to the OR, the patient gonna get RV dysfunction. Yeah, you fix it completely. The right ventricle just stopped, bulging and stopped. So we did prehab for a week or 2. But the thing is, only drugs, not enough. So I thought that there is something else will be helpful for this patient. As I show you, 40% of patients, we will give IV dobutamine, IV Lasix, no response. And their creatinine level goes up, need to dialysis. So at the time, I tried to put those devices, spacer, decrease the TL grade 1 or 2, and then check that LV can be okay in that situation. We can do operation, we can fix the valve. That is one thing, unmasking the LV dysfunction. The second thing is repairability. You're gonna replace it, no matter what, the huge annulus. But 5 kilo, 10 kilo reduction of the patient, you can finally achieve the repair. with a favorable anatomy.
From the slide of Professor Han, patient average T-valve diameter is just 5 centimeter.
Septorateral dimension.
Yeah. It's not so, I think it's not so big. So
No. When you check with the Dr. Jill Dreyfus diagonal direction, about 5 centimeter echocardiogram septorateral dimension is equivalent of about 8 to 9 centimeter of diameter. It's different. Echocardiography septorateral dimension. Over 4.5 is quite big.
If you can do emergent operation, please do. But sometimes the patient status was very ill and very critical, and in those kind of patients, prehab may be needed, as Dr. J presented. If TR amount is decreased, the patient is improved in terms of body weight, decrease in body weight, and improving in renal and hepatic function, and patient even eat more. So the patient status is improved, and if I were a surgeon, I do operate in the much improved patient. So the bridging is very meaningful, in my opinion.
Okay, I have a quick questions for Professor Han. And I saw the animation and say that it's a very huge device is located in right ventricle side. So I think it's absolutely needed in the anticoagulation during device. What is your strategy for?
Yeah, most patients had already AFib, so NOAC is needed. In rare cases, patients do not have AFib. In that case, in those patients, we do DAPT. You use DAPT for 6 months.
Okay, we'll finish the session. We'll start at 10.
Can I have a question? Thank you. One question. Can I have a time for one question?
Go ahead.
Okay, thank you. Professor J, I want to have a question. Since the TR patient had a long time of the condition, but you said that only 5 days of bridging, and are you telling us that 5 days bridging can improve the surgical outcome? Because I really can't understand the mechanism of the improvement of surgical results, because since there's only a small cases you had performed, and I can't understand the TR patient had a long time of TR conditioning that since the heart is very,
Yeah, let me explain. I totally agree with you, but that was the protocol. At the time, it was the 3 cases of them was all in the protocol. So 5 days deployment is the rule at the time. It is not commercially available. If I can use it commercially, I will put more 2 weeks, 3 weeks, until the patient gonna lose their weight sufficiently. But at the time, it was part of the protocol. So I have no choice at the time, 5 days.
But see, I want to ask you that this really bridging can improve the surgical outcome. I can't understand the mechanism of the bridging of only 5 days. What does
Okay, for your understanding, the guys in cardiology, they check echo every day, and they show the perimeter of the T-valve annulus decreased 10%. So it makes sense. When annulus gonna smaller, we can put a ring easily and make more coaptation. So that's the evidence of them, not from me.
Just very congratulations to Professor Han and Dr. J. I think, did you look at the CVP after 5 days? Because I think the renal function improvement after implantation this device, there is a big difference on renal function. If the diuresis is not responsive, but after 5 or 7 days, if CVP is decreased, diuresis effect is going.
Yeah, thank you for your good comments. But to checked the CBP. We need the central venous catheter, but no one has C-line before operation, so unfortunately we do not have any data of that.
Thank you.
I'll make one last comment. Let's say we had a device that we could put in transcatheter that would help our patients in the operation and their postoperative course. We do that for coronary bypass patients all the time. We put a balloon in them to help their operation and to help their postoperative course. Even though they've had coronary artery disease for years and years and years, we put this in for 72 hours, we put them on the pump, we leave it in, we take it out postoperatively. It helps their postoperative course. This is exactly the same thing. This is something with very low risk and appears to have very high benefit. You should be congratulated to continue the course of these. This is the same thing that helps the patients through their operation and their postoperative course with very little risk.
The only drawback of this device is this all, they handmade, kind of, we send the CT data and they made, the bespoke, like, yeah, for 3D modeling. So it takes some time. Yeah.
Okay, thanks again for hard participation. Thank you.
Okay, so we will now have a coffee break. The next session will begin in 10 a.m. Coffee is available in the first floor and the first floor. Please enjoy some refreshment.
Let's dance in style, let's dance for a while. Heaven can wait, we're only watching the skies. Hoping for the best, but expecting the worst. Are you gonna drop the bomb or not? Let us die young or let us live forever. We don't have the power, but we never say never. Sitting in the sand, but life is a short trip. The music for the sad man. Stay on. It's so hard to get on without a ghost. I don't wanna perish like a fading horse. Youth like diamonds in the sun, and diamonds are forever. Forever young, I wanna be forever young. Do you really wanna live forever? Hush, don't speak. When you spit your venom, keep it shut. I hate it when you hiss and preach about your new messiah, 'cause your theories catch fire. Covering my ears like a kid. When your words mean nothing, I go la la la. I'm turning up the volume when you speak, 'cause my heart can't stop it. I find a way to fuck it. I go la 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 la
저기 죄송한데 용훈 씨 그 위딜리 좀 꺼줄 수 있어요? 지금은? 네, 지금 꺼주세요.
Your little brother never tells you, but he loves you so. You said your mother only smiled on her TV show. You're only happy when your sorry head is filled with dope. I hope you make it to the day you're 28 years old. You're dripping like a saturated sunrise. Feeling like an overflowing sink. You're ripped at every edge, but you're a masterpiece. And now you're tearing through the pages and the ink. Everything is blue. His pills, his hands, his jeans. And now I'm covered in the colors, pulled apart at the seams. And it's blue. Hey, I was doing just fine before I met you. I drink too much and that's an issue, but I'm okay. Hey, you tell your friends it was nice to meet them, but I hope I never see them again. I know it breaks your heart. Moved to the city and I broke down car. And 4 years no calls. Now you're looking pretty in a hotel bar. And I can't stop. No, I can't stop. So baby, pull me closer in the backseat of your Rover that I know you can't afford. Buy that tattoo on your shoulder. Pull the sheets right off the corner of that mattress that you stole from your roommate back in Boulder. We ain't ever getting older. me before I even knew her name. La, la, la. It felt like oh la la la, yeah. Oh, sapphire moonlight. We danced for hours in the sun, tequila sunrise. Her body fit right in my hands. La, la, la. 'Cause you know it's been a long time coming, don't you let me fall. Oh, honey, your lips undress me, hooked on your tongue. Oh, love, your kisses that me don't stop. I love it when you call me señorita. I wish you could pretend I didn't need ya. But every touch is ooh la la la. It's true la la la. Oh, I should be running. Oh, you know I love it when you call me señorita. I wish it wasn't so damn hard to leave ya. But every touch is ooh la la la. It's true la la la. Oh, I should be running. Oh, you keep me coming for ya. Call my name, I'll be coming for ya.
See, it started at the park, used to chill after dark. Ooh, when you took my heart, that's when we fell apart. 'Cause we both know that love lasts forever. They say we're too young to get ourselves sprung. Oh, we didn't care, we made it very clear. And they also said that we couldn't last together. You're way too beautiful, girl. That's why it'll never work. You had me suicidal, suicidal. When you say it's over, dang, all these beautiful girls, they only wanna do you dirt. They'll have you suicidal, suicidal. When they say it's over. See, it's very divine. You're one of a kind, but you must shut my mind. You have to get declined. Oh Lord, my baby's driving me crazy. It was back in '99, watching movies all the time. Oh, when I went away for doing my first crime, and I never thought that we was gonna see each other. And then I came out, mommy moved me down south. Oh, and I'm with my girl who I thought was my world. It came out to be that she was the girl for me. You're way too beautiful, girl. That's why it'll never work. You had me suicidal, suicidal. When you say it's over, dang, all these beautiful girls, they only wanna do you dirt. They'll have you suicidal, suicidal. When they say it's over. See, it's very divine. You're
네, 시간이 돼서 착석 부탁드리고요. 이번 세션 시작하기 전에 짧은 영상 보고 시작하도록 하겠습니다. This session is Innovation in Tricuspid Valve Surgery and Interventions 2. This session will be chaired by Professor Chris Malesi and Chris Kyung-Han Kim. Thank you.
Good. Good morning, ladies and gentlemen. Professor Chris Malesi is coming, so I will start this session. So the first speaker, Dr. Hosoba. He is from the Nagoya Dokushikai General Hospital, Japan, and he will be talk about the totally endoscopic beating heart tricuspid valve surgery. Ladies and gentlemen, please welcome Dr. Hosoba.
Thanks so much, kind invitation, Dr. Kim. Thanks so much for having me here. It's truly an honor to presenting my paper at a great meeting with great people, with experts from all over the world. I'm Dr. Hosoba from Nagoya, Japan. I'm gonna talk about the total endoscopic heart surgery. Let me start then. Oh, here's the COIs. So, everyone know that the tricuspid valve surgery has a worse outcome compared to other cardiac surgery. It's had been bad over years and decades, and I hesitated to take our patient to the OR because it's high risk. And the ancient samurai said, call it makeikusa, which is mean that losing battle. We lost before the battle, actually, so I hesitated to do that. And replacement, in terms of replacement versus repair, replacement has worse outcome. We all know that is not great. And still not great, the recent paper showing still that tricuspid replacement has worse outcome. That same situation all over the world. That's from the Taiwan National Database showing that the replacement is worse. And looking to Japanese database, we have a nationwide registry a couple of years, or 2-3 years these days, 200 to 250 cases annual volume we have, and 78% repair, around 50 cases replacement. And 30-day mortalities are around 3, and the repair 2 to 3. It varies over the years, but replacement has worse outcomes, like 4 to 6. So I want to try to repair, avoid replacement. If high risk, too high risk for repair, what should I do? So my solution is beating heart and endoscopic, the combination. So beating heart, I believe it's gonna be less ischemia. Shouldn't be no ischemic time, and we can do anatomic valve assessment. That's my point. And if you use the endoscopy, it's going to be better visualization for sure. You're looking down the barrel, and less RV manipulation for sure, because you can touch the RV. So what we do for that minimal invasive surgery, I always use this 3-port platform, what I call it, 3-port platform. I place a 3D endoscopy in the center, the left and right independent port. And I utilize this technique for almost all valve pathology. For the mitral tricuspid, I place left atrial retractor, right atrial retractor through the main port, signet cross clamp coming in through the main port, no other additional stab wound or anything like that. So I'm going to show you some example here. It's an 81-year-old guy, isolated tricuspid surgery. His tri-score was 6, MELD 18, NYHA 2 to 3-ish. That his CKD create level 2. That he had some rhythm issue, proximal AFib and the 6th sense. Here's a pre-op TTE showing a massive range of TR, lost coaptation already, and a dilated right atrium. So what I do is a 2-centimeter incision at the 4th intercostal space, and my assistant go on the fen bypass from groin. In this particular case, I use the 2-stage venous cannula from right groin, and this is a 3D endoscopy coming in. and open up the pericardium, and two-stage suture in the bottom and top. And I snare this case for the IVC, and I don't snare from the SVC. So sometimes I use it because this is a two-stage venous cannula from the femoral vein. So open the right atrium. So just the communication between the perfusionists is very important in this setting. I told them not suck up the blood all the way, that just keep the water surface and look at the monitor. They kind of control between the sump suction and vacuum drainage from the venous drainage. There's a tack stitch on the right atrium and the pericardium. So the sump sucker going underneath the two-stage venous cannula to the coronary sinus, I think is the best position. And placing an annular stitch. I think this is just as usual, annular stitch. So making sure it's beating, so try not to tear up something like a friable RV tissue array. And using a core knot to tie all the knots. As Professor Jay said, we can do a valve assessment. That's a pretty good point. And I do water tests. With my left hand, I grab that RVOT and giving water test. So this case is showing some leak from between the anterior leaflet and the septum leaflet, which I have to treat. So I decided to place edge-to-edge repair stitch with a forward pleated stitch. As you can see that, with a beating setting, we can still easily do that edge-to-edge because it's in front of you. And usually the tissue is not that friable because the regurgitation has been there for a long time. So again, water test looked great, and it said close. So closing a two-layer closure with a polypropylene suture. And this particular case, the cardiologist asked me to place that LB, epicardial lead, that RV, epicardial leads. So not quite sure why, but they asked me to do it, so I just do it. So through the 2 centimeter incisions, you can still reach to the RV free wall and the RA, that tuck it down. And then one more thing I did is clip the left atrial appendage. You can do it with the beating setting still. I use a Pro 2 atrial clip. This is how it looked afterwards. So patient doing well after surgery. He has extubated the day, out of ICU 1 or 2 days, and then went home in 6 days. This is a follow-up 2-year. He's got nice looking chest X-ray. This is TTE showing trivial leak in 2 years. Okay, so pacemaker related TR, we have been debating with it. So the TTR experience showed that transcatheter, the transvalvular lead for TTR or without transvalvular leads, not changing anything in terms of the result. So this is the case I got. The lady had a pacemaker 5 years ago, had a torrential TR. That looked like a pacemaker leads related TR to me. And it looks like the jet towards the septum, so probably posterior leaflet. That's what I thought. So same setting. So utilize the jugular and the venous, femoral venous cannulation both. So putting a sump sucker. So I put the steel wire in it. The wire, I bought it at the Home Depot type of DIY shop and placed it into that thumb sucker. It's kind of make it malleable. So, so looking through that right atrium, you can see that lead is not attached to the leaflet at all, but it kind of had been contacted to the posterior leaflet. And I was looking for the best place to kind of place the LV lead, RV lead. So I think that the septal posterior commissure would be the best place. So at this moment, the sizing is not doing anything for me, so I think just a 30 ring is enough. So I chose a 30 physioflex in this case. So starting up the annular stitch at the edge of septal leaflet, and making sure that the lead is not, it's gonna sit the proper position. So placing annular stitch. So changing position on the RA retractor. In the endoscopic setting, I think the needle angle, the needle driving is important. I think that staged driving of the needle is, I think, technically a little demanding, but needed to have proper annular stitches like this. So I think as you go in, you're gonna change the needle angle and drive, and you come out the needle. So same thing, place that flexible band. I'm a semi-rigid, I think. And it's a physio tricuspid. And I tied knots, but not pusher. It depends on the financial situation of my institution. Well, but sometimes all right. Then I close that commissure, not commissure, it's edge to edge to posterior leaflet to septal leaflet. It's a P1, P2, and septal leaflet edge to edge. So it's gonna be, the lead's gonna float between the commissures and beneath that ring. So all the tests looked okay, and I closed the right atrium as usual. So that's pump run is 70 minutes, 2 hours, a little bit of the operation time. She went home day 7. She's been doing fine for a year. And that post-op, TTE, showing arterial leak. Never had heart failure admission, readmission at this moment. So how about the redo case? This is an 80-year-old guy, had AVR tissue valve replacement and left appendage closure from inside. So he was in a bad shape before surgery, so decided to take him to OR. So this is a redo case. So we found a dense adhesion on the chest. So placing a port and using a little bit of thoracic surgery technique, we try to avoid that adhesion. So I cut the pericardium and the right atrium at the same time, like, and block, and go into right atrium. So with the 2 thumb suckers, you can see that valve clearly pretty well, and the same thing, an annular stitch first. And the redo case, you can see better actually with that, because the right ventricle is kind of attached to the close to sternum, and coronating in this case. And it looks like the posterior leaflet P1 is kind of a little prolapsing. So let me figure out why. So I decided to place edge to edge and P1 to septal leaflet in this case. and the closing is easy. He's got the liver failure a little bit, but I don't worry about the bleeding because we just cut the right atrium, that's it, in this case. So post-op TT looked okay. He went home on day 7. So Dr. Pitts is from Thessaloniki, showing the similar technique. And this is his endoscopic surgery. In terms of beating versus arrested heart, I understand there is no robust evidence to supporting beating is better than arrested. This is a recent study, meta-analysis showing no difference between those. And some studies showing a slight difference and better in beating, but I think it's a slight difference. And but the point is, I don't see any downside using that beating heart in my experience, and moreover, it is easy to convince my cardiologist that it's 60 to 70 minutes pump run, that's it, and would you think 60 minutes ECMO is going to hurt my patient? Probably no. So about the edge-to-edge repair, I think Dr. J. Sok-Yu is going to talk about later, the next. I know some of you hate this technique, but I do MTR by myself, and from my experience, it's not going to give you a stenotic valve, and the study showing that long-term result is okay. So in terms of the TTR era, so we're going to see that often which is better TTR, or this is a study from Germany, Bonn. They do endoscopic beating heart minimally invasive surgery, so see no difference between those. In the high-risk patient, probably better in TTR, but overall it looks great on that beating heart surgery too. So, but the important point is the TTR, like the annuloplasty link, which is a bad thing in the long term. So this is a paper from Asan, and they show that long-term durability in terms of the regurgitation is better on that tricuspid annuloplasty group. It's going to be a point in the near future. So I think a contemporary tricuspid valve surgery, minimally invasive repair is going to be the way to go, and the beating heart procedure may help the patient. Thanks so much for your attention.
Thank you. Thank you, Dr. Hosoba. And we have several panels. The question or comments? Dr. Badu? Yeah.
Well, first, congratulations. Excellent presentation. I think what you're showing everyone, as along with Dr. J before you, is that minimally invasive approaches are feasible and safe. And so congratulations for doing this, and as well as your nice presentations in Cincinnati just the last week, which we spent some time together. I guess from a technical question for you is that we found that as you showed in your 80-year-old, the last redo case, that when you do bicaval cannulation, the effort and the exposure is so much nicer. We haven't snared for many years, and by doing bicaval cannulation and placing the jugular cannula distal to, or to the azygous vein, so that, and I guess for venous it's proximal technically, that collapses, and then by pulling back the venous cannula just before the hepatic caval junction, and use heavy vacuum, it almost completely eliminates the blood, and all you're doing is your sucker is just for the coronary sinus. What do you think about that, and have you, in your experience with minimally invasive techniques, have you modified your approach for bicaval drainage?
Totally agree with you. I do the same thing. I pull back the IVC cannula a little bit and see how it does, usually, then pull back on the jugular cannula too. The first case, I utilized the two-stage venous cannula is because the patient had occluded IJ. So usually I do that two venous cannulas utilizing and see how it does.
In the minimally invasive approaches, sometimes you can actually put a regular right angle cannula and a purse string through a separate port on the side, and then just it stays out of your field. It's just something to think about. And the last sort of technical question is I saw you use snares, and then you use a slider to put on the snares. One option, sometimes you take an umbilical tape, cut it, and make your own loop, and just tie it inside the chest. It sometimes works for the venous. Have you tried that before, or what do you think about it?
No, but I'll do that next time, probably this week.
Congratulations.
Thank you.
Thank you. Other questions?
I have one question for Seoul. Very great talk, your video clip. And my question is about the exact sizing for beating heart T-valve surgery. So it is totally different condition in beating heart and arrested heart. So we easily can check the size in arrested heart, the retracted and often fully the right atrium. But however, beating heart is something different during cardiac cycle systole and diastole. So do you have any on your tip or technique for exactly sizing for T-valve ring? Okay.
I mean, good question. Thank you, Dr. Lee. So in terms of sizing, I think actually that hugely dilated and sizing is not doing anything in this type of patient. So I just use that 30 ring for if I add some edge-to-edge procedure, I'll just put a 30 millimeter ring, and if not, I'll do 28. That's my strategy.
Next question, Dr. Lee.
Yeah, I'm Dr. Lee from Fujian Central Hospital. Thank you for your excellent presentation. I have a question for the PFO. Do you assess PFO preoperatively, and if there is PFO, do you change your surgical strategy or not?
That's a great point. We always check with the TEE. Make sure there is no PFO. But if there is a PFO, let's try to keep the water surface up to the bottom of the valve. So just make sure there's nothing drained to the left system. That's a very important point. We sometimes use that bubble test for making sure.
Okay, Daniel.
Yeah, so great talk. So my question is just follow the same idea as Dr. Lee. So have you ever have some experience that although there's no intracardiac shunting, you still found some air inside the left side system? Well, in my own experience, I have about 10% of the patients, in particular those patients have a redo surgery, previous surgery. Supposingly, theoretically, you don't have any air once you just open up the right side of the heart. But unfortunately, some of them, they do have the air, probably I will guessing from the intrapulmonary kind of a shunting, and that's why we need some sort of a venting. Do you have that kind of experience?
Oh, I do not have experience for that, but if I found some air in the left system, I'll just place that cannula in the ascending.
Yeah, how about in redo situation?
Redo, I think sometimes redo we have to clamp, right? So I probably can find a way or place to place that ascending cannula. So that's my experience.
Thank you.
Okay, last question, Professor Jay.
I want to have a comment on that. Daniel, there are some bubbles can happen during the beating heart, but I 100% checked post-op the brain ML diffusion for every patient. We always use the CO2 insufflation thoracic cavity. Those amount of the small air bubbles do not make any problem. In the diffusion weighted image, no acute restriction, acute infarct happen with those bubbles.
I agree. I do that. The same thing. And CO2 insufflation is a key, I think.
Okay.
I have one more comment about beating heart T-valve surgery. In my experience, my scrub nurse prepared the cold saline for saline tests. So at that time, I infused cold saline for T-valve regurgitation test. At the time, the patient rhythm was changed to ventricular fibrillation. So
right.
you have to prepare the warm saline for T-valve regurgitation test, okay?
Yeah, I agree.
Thank you.
I had the same thing before. That's why I grabbed that with the RVOT with left hand. Try not to pump out the saline into the left system.
Okay, thank you.
Thanks so much.
Next speaker, Professor Yoo Jae-seok, Asan Medical Center. He will talk about tricuspid edge-to-edge repair in the tri-clip era. Please.
Thank you, Chairman. Good morning, everyone. It's my honor to have this opportunity to speak in front of many master cardiac surgeons. But I feel a bit intimidated because this topic is not fully established, but many cardiac surgeons use it, but I'll take responsibilities for any negative comments on edge-to-edge repair. I have no disclosure regarding this issue. TR is bad, and severe TR is very bad. And when we think about severe TR, we are probably imagining images like this, very tough clinical course. And it's well known that the isolated tricuspid valve surgery has very poor outcome with high mortality and morbidity. And a lot of the studies mention the importance of early referral before the patients get worse. But if the clinical outcome is not so very good, the early referral will be impossible. So it's a vicious circle. So for early referral, the surgery should be simple, minimally invasive, and the result should be very good. So these represents simple minimalist approach in TV surgery that I have in mind. And these two topics so already covered, so I'll just briefly mention them and move on quickly. This is my setting, very similar as Dr. Hosoba's, but it's just a small change. I use two-port system using this homemade malleable sump, and I do not use extra port for left hand. This is postoperative wound. And I really enjoy beating heart surgery, and regarding the shunt issue, I always check bubble test before surgery, and if the bubble test positive, I do the surgery under fibrillatory arrest. In STS data, beating heart was better than arrested heart. And this is my topic today, simplified repair technique, edge-to-edge repair or Clover technique. It's also in STS data, repair was better than replacement. But TV repair is not so easy because TV tricuspid valve has very complex chordae, complex papillary muscle, and very delicate leaflet, and often combined with severe tethering. And although the textbook presents the tricuspid valve morphology as quite easy, but in reality, sometimes it's very complex and has diverse characteristics, as you can see in this video. So this Clover technique is very simple, was first introduced by Dr. Alfieri in traumatic complex tricuspid regurgitation. And the result, favorable result, was published in the similar group of 14 patients with complex tricuspid regurgitation. And as you know, recently, TTR, for TTR, the tricuspid edge-to-edge repair is gaining attention because many cardiologists are interested in TTR procedure. So these are the advantages of edge-to-edge repair. Ruptured chorda. Yesterday we saw Dr. Fukushima's case. It was a very fancy neochordae implantation in tricuspid regurgitation, but I just tried once, but it was really difficult for me because the LV morphology is not as simple as the LV, so making it very difficult to accurately adjust the length of chordae. So neochordae implantation in tricuspid valve regurgitation is very difficult. However, the edge-to-edge procedure is very simple, and you can make better coaptation just as single stitches. And when in cases with very severe septal leaflet tethering, with just a simple edge-to-edge stitch to pull up the leaflet can make the coaptation surface better. And even in very complex cases like this, you can do the repair very easily. So the advantages are easy and quick even on beating heart setting, and you can correct residual TR after intraoperal TEE. Just you can open the right atrium and then adding some stitches. And edge-to-edge repair involves only valve leaflets without distorting the RV geometry. And saline test is more reliable. And it's applicable to various types of TV pathology. However, this edge-to-edge repair technique may raise some concerns, such as long-term durability and possible future stenosis. I was also curious about that issue, so I searched for evidences. At the time, this paper, the midterm result of 66 patients who are RFA group was the only one, but the result was very favorable, and there's no risk of tricuspid stenosis. So when I was working at Sejong Hospital, we were curious about the long-term durability of our edge-to-edge repair. It included data of late Dr. Samse-Oh. The total patient number was 237 patients. Clover technique was used in 32%, and just a simple two-leaflet approximation was in 68%. And tricuspid annuloplasty was performed in 74%. The results are like this. The freedom from late TR at 10 years was 85%, and no TS in 10 year was 88%, and reoperation rate was very low. So the favorable long-term durability with no tricuspid stenosis. After 2 years of our data, RFA group published another paper with very similar design with 145 consecutive patients. And the result was favorable. And in TTR era, the key difference between TTR and surgical edge-to-edge will be whether the annuloplasty can be performed simultaneously. So we were curious about the impact of tricuspid annuloplasty at the time of edge-to-edge repair. So we analyzed our data and compared. The results were like this. The tricuspid annuloplasty group showed a better overall survival and freedom from late severe TR, but there was no significant difference between tricuspid stenosis or reoperation. So consequently, the tricuspid edge-to-edge repair along with TAP is better. So this result can provide insights to our cardiologist. And we also were curious about the difference between just a simple edge-to-edge versus clover repair. And the result, the two groups showed no difference. So this result suggests that a stepwise approach, just beginning with just a simple two-leaflet approximation and clover, if necessary, would be a reasonable strategy, not instead of clover repair initially. So this shows the two orifice, simple two-leaflet approximation, and this shows a clover repair. And this is the concept of stepwise approach. Just put a ring first, and ring annuloplasty first. And then saline test shows some leakage here. And I added just a simple posterior septal edge-to-edge repair. And the saline test showed leakage here. Then I put in a clover stitches. Considering relatively poor outcome of TTR, I think this would be a good option in severe tricuspid regurgitation. Now I'd like to show you some cases. 78-year-old female with multiple comorbidities with high Euro score. Very similar with those cases. I always use dual cannulation. And I understand we don't need to do the SVC block, but sometimes many patients have very big SVC and the cannula is floating. So my perfusionist complain about air bubbles. So I put in just a small gauze packing in SVC. After completing the simple annuloplasty, there was a prolapse of posterior leaflet. And in redo cases, I don't separate the pericardium from right atrium, and this pericardium acts as a very good reinforcing material. It's better than bovine or Teflon felt strip. So the tighter the adhesion, the easier the operation in redo TV surgery. And this case is pacemaker lead impingement case. Yesterday, Dr. Sak Lee introduced in her case. And this is the last case, the torrential TR due to mild form of Epstein's anomaly in 50-year-old female patient. You can see septal displacement of, apical displacement of septal leaflet, about 1.5 centimeters. Yeah, this shows how the operation goes. 3D total endoscopy approach as I shown you previously. Yeah, same procedure as Dr. Hosebas. And I use 3 tagging tenting sutures and use bulldog clamping in fresh cases. You can see here, this is the true annulus and the septal displacement, apical displacement of the septal leaflet. And put in ring stitch first. And saline test shows gap here. So first I closed the gap and did the water test again, and you can see the septal leaflet severe tethering. So the stepwise approach, I proceeded with clover repair using Gore-Tex suture, not at the tip of the leaflet, but caudal approximation to prevent future cut through of the very friable septal leaflet. The final saline test showed satisfactory. And interop TEE showed less than mild residual TR. So in conclusion, surgical tricuspid edge-to-edge repair showed favorable long-term clinical and hemodynamic results. The simple and versatile technique is considered an effective and safe option in TB surgery. And the long-term outcomes of surgical edge-to-edge repair were better with concomitant TAP, so concomitant TAP should be performed whenever possible. The results of TTR are not particularly favorable. Surgery that can also include TAP appears to be more promising, and moreover, if surgery can be performed minimally invasively, it would be even better. Thank you for your attention.
Thank you. So my question is, actually you showed us the simple Clover technique, but yesterday I lectured about the T-valve anatomy, especially the posterior leaflet. Sometimes has many indentations. So usually P1, P2, or sometimes P1, P2, P3, or P1, P2, P3, P4. But your patient's tricuspid valve, only one posterior leaflet. So in those cases with many indentations, how can you handle your Clover technique?
Thank you for the good
Sometimes
question.
3 leaves Clover, sometimes 4 leaves Clover. Yeah.
Sometimes 4, and sometimes 5, and sometimes 6 maybe. But if the posterior leaflet has many indentations, if we just approximate just main portion to the septal leaflet, many cases it would be okay, just closing the main portion. If there is some residual leakage, I can add just a small indentation closure of the gap of the posterior leaflet.
Okay. Questions?
Thank you for your nice presentation. Do you have any strategy for decide your valve size for preventing the future stenosis?
Thank you for the good question. If the leaflet has very thick sclerosis or calcification, I don't do the Clover or edge-to-edge repair. Those kind of patients require replacement, I think. Only for patients with good leaflet mobility and enough window after Clover repair.
And sizing?
I don't do sizing. I always put in 28, but most of the patients have very big annulus, so sometimes I use 32 to prevent suture cut through of the annulus.
Okay, you don't size. Yoshi?
To you, great presentation. I'm starting to do more and more edge to edge after the success with the triclips. But I noticed in your paper that the mean gradient over 5 was a risk factor for survival. So tell us about the incidence of tricuspid stenosis and how do you assess it? And if the tricuspid gradient was 5 after you were coming off from bypass, what would you do at that point?
I tried to make the pressure gradient less than 5. Always my anesthesiologist check intraoperative TEE, but sometimes it's 5. But in pre-discharge echo, every case was less than 5. So I think after putting the Clover sutures, I always check the size of the remained window. If I cannot say it's not science, it's the
art.
region of arts. So I don't think it's problematic.
So you haven't had the case that the gradient was too high and went back to replace the valve?
Just 2 or 3 cases of 6 or 7. So I I reopened the right atrium. I cut some stitches, like gap closure or something, and then the pressure gradient was lower, but mild residual TR existed, but I don't think it's so problematic.
I mean, to borrow Dr. Bowling's statement, TS is really bad.
Yeah.
Professor J. Yeah.
Nice presentation as usual. Do you decide club technique before operation or during operation?
During operation.
During operation. You do not believe the coaptation gap in the echo data? I mean
pre-op echo.
Yeah, pre-op echo. Usually, most of surgeons they have a plan to do the club technique before the operation, but you look at the leaflet and put a ring first, and then if you are not satisfied, you added the club technique, right?
I think we cannot estimate the extent of leaflet prolapse or tethering even in intraoperative TEE. So I always just look at in surgical field.
Dr. So says he put 30 size ring for the club technique, or 28 for without club technique. So I absolutely follow his rules.
Yeah, me too. Because most of patients requiring Clover technique, they have very big annulus. Right. So as I told you, I put in 30 or 32 ring.
Is there any contraindication for the club technique? For example, rheumatic tricuspid. Rheumatic mitral valve with some fibrosis is
I don't do rheumatic involvement of tricuspid. Some rheumatic patients, there's no involvement of rheumatic disease in tricuspid valve. The leaflet mobility is very good, but the leaflet mobility is not good. I don't do the Clover repair.
Okay, Dr. Fukushima. Yeah.
Thank you, Dr. Yu. It's very informative, your presentations. I agree with Tsuyoshi that TS is very bad, and S shouldn't happen after the bypass off, because the patient is down, the general anesthesia, but the patient is waking up and do the daily life or maybe exercise. Is it stenosis prominent? How do you think? You think is long-term outcomes always due to survival or in-hospital the treatment of heart failure, these things? But how about do you think is exercise tolerance in this case having a mild tricuspid stenosis? That's very important, I think.
Yeah, I think it's very important issue, and I have to check the long-term data of my midterm and long-term data. But the stepwise approach concept was because of that issue. I try not to do the Clover repair freely. Just a simple edge-to-edge repair. Many times, simple edge-to-edge repair will be enough. So, okay. I try not to do the Clover repair freely.
I feel it's a mild tricuspid stenosis worse than mild tricuspid regurgitation. Maybe worse than moderate tricuspid regurgitation.
Yeah.
Mild TS is not good, I think. Thank you.
Okay, thank you.
The next speaker is Daniel Chan from Hong Kong. We've asked him to speak about tricuspid valve replacement, but with a catheter. So transcatheter tricuspid valve replacement, Hong Kong experience.
Thank you, Chris, and thanks again for the kind invitation. So it's a true honor to involve in this wonderful meeting. I've learned a lot so far. So when JB asked me what I'm going to talk, I say, wow, Hong Kong is a small place. We don't have a big number. Same in the presentation, no big numbers. He just told me that, oh, something crazy, something stupid will be fine. So, well, let's say, I would say, how about just a experience sharing? So here, again, no numbers in there. Just try to show you a real life, how the moderate size of a cardiac center in a small place deal with those patients with isolated TR. So I will place some focus, particularly in those TT we have performed so far. have no disclosure. So we have great lectures and great speakers, cover everything about the TR. So, but one thing is that still, it's only contribute to about 5% of our total cases, and still it carries a lot of mortality and morbidity. Now, I just go ahead to our thinking, how to deal with these patients with isolated TR. So, of course, risk assessment. In recent years, we use the tri-score, and some of them with some liver derangement, we incorporate the MELD score as well, see whether that helps us to make the decision. And of course, when we're facing a patient's low risk, young, surgery definitely. But more of the discussion among the heart team, definitely the immediate risk patients, immediate age. Now, some of them, if they are relatively good, we put them to surgery, of course. If not, then nowadays we still believe repair is better than replacement in the tricuspid area. So our cardiologists will do the T-tier. Some special group is that part of the patients have a previous tissue valve there, so we do the valve in valve. And if the T-tier is not feasible, then we think about the TTVR, or in a last resort, we do some extra anatomical replacement, which is the tric valve in our center. So just a brief idea how we are doing in this sort of a setting. Surgery is not that good. The results, I would say, as well as the computer, I think, is not moving on. So I just give you a brief idea that our patients group here is not a large amount, 56 in the recent 5 years. Majority still a replacement because we still have a big proportion of patients with a rheumatic heart disease. High proportion of them has a previous surgery, and the Euro score is quite high. The Tri score is also in the moderate range, which I would say that it represents the real mortality better compared to the Euro score 2 we are using right now. So because of the high proportion of a replacement, our mortality is closer to the high side, 8.9%, and up to 10% of them suffer from certain stage of complication. But this 8.9%, we particularly use the in-hospital mortality. For tricuspid patients, I think it's better to represent the real life compared to a 30-day mortality, because we have patients with a successful immediate surgery. They might linger on in the hospital, die of different kind of complications, maybe 2 or 3 months later on. So I think in-hospital mortality can represent a better real-life situation of a tricuspid patient. So the TTM, our group has just submitted a review of our results. Is with the previous 5 years, we've done 78 tri-kip. So the mean age is 75, but definitely is a high risk. And we have quite a nice result, is that the mortality 3.85% with a very low complication rate. And also the follow-ups up to 30 days only. So at least at the early follow-up, the TR severity stayed the same, at least achieving 2 grades down, and also most of the patients have a significant improvement in their symptoms. So let's go to the replacement. Of course, valve in valve is a special group, and technically it's quite easy, so we'll just skip that. But in other patients that doesn't fit any of the procedure we have, still we have 5 patients underwent this type of tric valve. But personally, I don't like it because we still question about the RV remodeling. There's a large amount of blood still within the heart. But the patients got improved symptoms. And on the follow-up around 1 year, 2 out of the patients we have put in the tric valve died of heart failure. So that's why this is only our last resort. Now I have put more focus on the TTVR. Basically, as I mentioned before, we prefer the repair. So T-tier is the first choice, but most of the time, if the anatomy is not feasible, basically is the coapplication gap is too large or there are multiple jets, the location of the jet is not feasible, or it is induced by the pacing lead, then we consider the TTVR. So in Hong Kong, we don't have the evoke, we don't have the interpret, so all the experience by using the Lux valve. For those not familiar with this valve, so just briefly introduce, this one is a China design and China made valve. So as Dr. Bowling mentioned this morning, most of the TTVR, the problem is that just like a can of Coke, it's too big, so it prevents the RV remodeling. But the beauty, I love this Lux valve, is that the majority of the anchoring force for this valve is not coming from the stand. It's actually coming from the, we call the septal tongue here. So they have a septal puncture here through this tongue to anchoring onto the interventricular septum. So that's why this valve doesn't need a big oversizing. Usually we just use a match size or about 5 to 10% oversize from the diameter we derived from the CT. So it's also like other TTVR design, it have a two-stand system. So the outer stand, as mentioned, we have the septal tongue here. They have the leaflet clip here. The idea is to clip the anterior plus or minus the posterior leaflet. So that will provide about 20% of the anchoring force. And then you can see a bulk atrial tongue here. So this tongue will rest in the atrium, so the overall size in the annulus or in the ventricle is much smaller. So hopefully this changing a can of Coke back to the old style bottle size of the Coke, so slimmer, and hopefully the RV can recovers better. So besides the valve, it has quite a complex delivery system just because it doesn't involve the mechanism of a releasing only. So, but in brief, this is a transjugular venous system. So our cardiologists get confused when using that. So that's why I get the chance to first use it, because from surgeons, it's like make more sense to what we are doing, when we're controlling the delivery system. But on the echo and on the action is totally on the other way around for our cardiologists, because they usually use the system from the femoral. So in brief, the delivery system can allow a certain set of motion, like retraction or the advance of the system, give us the making this the valve itself towards anterior or posteriorly. Returning the whole system can make the valve towards closer to the septum side or to the lateral side. Or of course, there is a turning knots over there. So it offers this flexing of the system, and then to, of course, release the valve, and also a knot to make a fine adjustment to make the valve more ventricle or more atrially. And then also a turning at the end, so that we can better align the valve by turning clockwise or anti-clockwise. And at last, they have a septal puncture through the septal tongue to have the final anchor here. So, and of course, we have to release by releasing all the small strings inside. So let me illustrate with one straightforward case. So this is 63, relatively quite young, very bad TR and very bad symptoms. So he had a rheumatic heart disease with a double valve replacement more than 20 years ago. EF not that good, and we have measured the RV is still acceptable, and also permanent AF, but he had quite a bad lung condition, so the lung function is less than half of the predicted, and also have a suspected renal cell carcinoma, so we think it's quite a high risk for open surgery. We refer for a Lux valve placement. So as other TTVR, we go through the CT assessment. First of all, we see whether the route is feasible from the neck down to the atrium, and also the space, because this is quite still a bulky system, so we need a certain space in the atrium as well as the ventricle, usually more than 6 centimeters from measuring from the apex to the annulus plane should be considered enough for the delivery. And then the angle of it, And also, most importantly, is the angle between the septum to the annulus, because as I said, majority of the anchor is over the septum. So that's why if the angle is too acute or too obtuse, it's not suitable for the valve to place. And also, finally, we use the CT to predict the deployment angle. So this is TTVR is just like the other kind of a transcatheter procedures, heavily rely on imaging. So I would say that we need both the fluoroscopy and the TOE to make sure that every step is correct. So first of all, we can see that the system runs through the tricuspid valve. We have to use the TEE to make sure that it's in the middle of the valve. So it's a biplane. Sometimes we need the 3D to make sure that we go through the tricuspid valve in the middle. And the next step, we will start to unsheath the delivery system, and then the two clips will comes out. And by that time, we need the TE again to make sure the clip is below the anterior leaflet and the posterior leaflet sometimes. So once we confirm the location of the clips, we will have a full release of the valve. So you can see the most of the atrial cuff release, and it rests beautifully in the atrium. So, and then the next step is to go to the septum, all right? To make sure that we have a good alignment of the septal tongue with the interventricular septum. So this is the most important step, as if fail of this part, there were high risk of a dislodgement of this valve. So we need take a couple of views from the standard view plus some of the transgastric view from the TE to make sure that the tongue is in contact with the septum. Then we push the punch, and the hook will go through the tongue and into the septum to make the anchor. So the rest is easy. We just reverse the process. Then the valve will be released, and we retrieve the delivery system. So from the Hong Kong experience, now, first of all, one thing impressed me is that the screen failure rate is not that high. So we submitted 22 patients to the company, and 17 of them approved. Now, interestingly, we submit the same number of the case to evoke, and the turnout, only one patient approved. And most of the reason is that the annulus is too big. But the first thing is that the valve per se, it can up to 70 millimeter of the annulus of tricuspid valve, and also it doesn't need a huge kind of oversizing. So that's why the failure rate is pretty low. And for these 17 patients, most of them is above 70 of age, and high risk, Euroscore to 6.4. Tri-score is very high, 5.8. And most of them have very bad symptoms requiring high dose of diuretics. And nearly half of them have RV moderate dysfunction by all those right heart cath or echocardiogram criteria. And cause of the TR, majority is functional. And part of it, a second reason is rheumatic. So you can see the size of the valve we use is mostly the large size. The 50 or above is the commonly used size. We have one patient because of the jugular vein is not big enough, so we go through the transatrial approach. At least intraoperatively, we have 100% successful, which means that we can deploy the valve with less than moderate paravalvular leak, and also without a conversion to surgery. So the early complications is pretty low. One patient have a bleeding problem from the neck. We need extra stitch and compression. One patient have a renal failure, go through a new hemodialysis, and one patient have a new pacemaker. So the pacemaker rate also impressed me. Although I would say like 40% of our patients, they have pacemaker already before the procedures, but the new pacemaker is quite rare. I think that's the beauty of the, no need of the oversizing of the valve. So, but the follow-up mortality is a problem. Now, the mean follow-up is 15 months. 4 patients we lost. So 2 of them is actually have a progressive RV failure. So and then 1 of them have a complication of a subarachnoid hemorrhage. 1 of them have a sudden death. We don't know what's the reason, although it's very close to the reassessment echo, which the echo shows still very good results. So we still don't know what's the reason why have a sudden death. And 1 patient have a readmission. Other than that, all the patients have a very good symptomatic improvement at the follow-up. And also, I found some of the parameters try to illustrate the improve in the quality of life. Although we don't have a formal quality of life assessment, but at least patients have a subjective less of an edema, and around 40% of the patients require less diuretics as before. And the echo findings quite stable. So only 1 patient have more than mild tricuspid regurgitation from the Parafa leak. All of them remain trivial or none. So the mean gradient is only 1.2 millimeter mercury. It's quite low. And RV remodeling, by the definition of the improvement of the RV in about 50%, half of the patient. So just share a failure case here. So 1 patient have quite successful initially after the procedures, but 4 months later on, readmitted to the hospital because of the RV failure kind of symptoms. And then echo found that the valve literally dislodged. So the patients at that time have not much choice, so I have to go in the operating theater and see what happens. So this is the intraoperative video. Okay, so you can see that the atrial size of the valve is quite large. So that is one of the thing we have to be careful during the explant. So we have to not to cut open the valve instead. So keep it the incision as lateral as possible. And then I can find that one of the leaflet clip has been dislodged, but the other one over the posterior leaflet anchored quite well securely, with some fibrotic tissue as well. The reason why these patients have a dislodged valve is that the progression dilatation of the right ventricle, so that there is a cut through of the septal anchor here. So basically, I didn't need to use any force to take out the valve. So there's a kind of a cut through of the anchor from the septal muscle. So here, I'm not supposed to compare all those results because from the surgery, TT and the TTVR, they are basically from our centers, different group of the patients. But just as a reference here, so for the surgery, we perform those patients have the least risk, of course, but still we have quite a unsatisfactory kind of mortality and complication rates. But in other terms, TT and the TTVR, although they serve the high-risk patients, at least the 30-day kind of a mortality here is pretty low and also quite satisfactory. So for the TTVR with the LUX, also there are some special situations after 17 cases of experience. Like previous TIA, we've performed 1 case. Fortunately, the clip is at the side of the valve, it's not right in the middle. So we can still perform the LUX valve without any particular problem. We just push the clip onto the side without any special kind of a technique like cutting the leaflet also. Or the presence of the pacing lead. We have quite a number of cases have a previous pacing lead. So also from our experience, it's feasible. And also it doesn't cause significant parafa leak afterwards. And also 1 case with an inadequate jugular access, so we can go through the right atrium. So basically, this is their first generation of a delivery systems designed for the transatrial approach. So they are still manufacturing that. If the neck vessel is not big enough, we can open up a small wound from the chest, from the right chest, and go directly from the right atrium. And also, 1 big problem for this procedure is that acoustic shadow from the previous, particular the mechanical replacement valve. So you see from the TE, sometimes very difficult to see the target. But 1 thing we adopted is using the ICE. The newer generation of the ICE gives us very beautiful images, although there are previous kind of procedures having the obstruction view or under the TEE. So now sometimes difficult patients, particularly those previous surgery, we use both TEE and eyes to help to guide us the overall procedure. So for summary, in particular to the TTVR with the Lux valve, for us, our experience shows that it's still safe and effective, at least at the early stage. But we are still not sure how the patients go in the midterm or long term, in particular those RV, whether they can come back or not. So more experience, more data can help us where to put the TTVR in which stage of the overall treatment for tricuspid valve. So thank you very much.
Thank you, Dr. Shan. We've got time for a couple questions. Anything from the panel?
Thank you.
Yeah, go ahead. Yeah.
Thank you for your great presentation. And my name is Kita Kim in Assam Medical Center. And most data on transcatheter tricuspid intervention extend only to 2 or 3 years, showing encouraging results. And given the lack of long-term evidence, especially in patients with advanced RV dysfunction, do you see transcatheter tricuspid intervention as a truly durable solution or more of a palliative option for high-risk patients?
Thank you. It's a good question. So for now, we don't have enough data to say that it's a good option, you know, compared to TTR or surgery, still in an early phase. So for this valve, I think it's more than 800 cases implanted worldwide. Most of the study in mainland China, of course, so they completed the European CE study and also the FDA study as well. So, but a follow-up still up to 6 months. So we don't know how it works in later on. So that's really rely on all the data, especially in the early experience, see how the patients goes with a longer follow-up. But I think for the valve itself, durability is all right in the midterm, but we just don't know how the patients will behave in that period of time.
Thank you. Dr. Sackley.
Oh, thank you very much for sharing your experience with us. And I have one question. So, looking at your explant video, it seems really bulkier than I thought. So, do you have any anticoagulation strategy? Do you need more high-intensity INR or longer duration for these patients?
Yes, so majority of the patients have a previous left side heart valve, so we just put them on warfarin. We didn't top up the level, just keep the level what usually for the mechanical valve or the tissue valve on the other side. But for a couple of patients, they have the TTVR only because of the, some of them are pacing lead related thing. So we still at least keep them on the NOAC, the non-vitamin K kind of thing, or if their renal function is not that good, we prefer to use the warfarin. As you said, it's quite a complex kind of a design of the stent, so we worry about the thromboembolism that's going on inside. So I would recommend a higher level of anticoagulation is better for this kind of valve.
And you have no experience for thromboembolic events?
Not up to now, not up to now. So probably one of the patients is actually having too much anticoagulation and suffering from SAH. That could be one of the reasons. But still, we didn't see other kind of clotting problem inside the heart under that dosage of anticoagulation.
Okay, thank you.
Thank you. Dr. Steve Bowling.
Daniel, fantastic presentation. We do not have the Lux valve at our institution. We do have the Evoke and we do have the Intrepid tricuspid. A couple points I'd like to make. They are very big footprint. There's flanges, there's flaps, there's hooks, there's things, there's pericardium, there's nitinol, and so like that. These patients have to be anticoagulated at a high level for life. The second thing is the actual diameter of a Diet Coke can is 66 millimeters. So you do actually have some that are bigger than a Diet Coke can, for God's sakes. Yeah, I use that as a joke. The Intrepid, the largest Intrepid is 56, so it's not actually the size of a Diet Coke can. And my last question is, you were as all these valves are very successful at getting rid of tricuspid regurgitation, we congratulate ourselves with a high five. Yay, I've gotten rid of tricuspid regurgitation. You saw that in 97% of your patients, you had less than mild TR, but only in 46% of your patients, you had RV improved remodeling. So I think comment on that is because they are the size of a Diet Coke can, or in your case, larger than a Diet Coke can in some, and they just prevent it. I think that's going to be a problem with some of these. Great presentation.
Thank you, Dr. Bowling. So I think the size itself, this largest 70 is not the portion at the annulus. So majority of the size they measure is the length of the clip, and the leaflet clip, and also the atrial tongue. So the real portion inside the annulus is not that big, to be honest. But again, is much bigger than we expect still. And then the second thing is that the selection of the patients. We still have no idea which is the contraindication, who are the contraindications, because these patients definitely have a very big and large annulus, large RV, and a big coaptation gap. That's why they cannot go through the TTR program. So that's why we're still figuring out which are the patient groups that this technique can really help.
One more? Okay.
Okay.
Dr. Kaneko, one more.
Right, I'll make it quick. So the RV dysfunction after transcatheter tricuspid replacement, I think there's two different mechanisms. One is immediate, where you see immediate severe RV dysfunction. And then there's another group that just doesn't feel well and slowly progresses. Which one were the ones that you saw? You had two RV dysfunctions that led to mortality. Which were they? Did you see it immediately, or were they just not recovering?
No, both of them after that. So immediate function is quite all right. I remember both of them, at least they have no tremendous improvement, but at least they stay like the same. So the RV failure, as you said, they comes later.
So that probably is related to the size, of the device itself, I have to say.
Thanks, Dr. Chan. Our next speaker, Dr. Takashi Miura from Japan, Nagasaki University. Switching back to surgery, the issue of torrential TR, contemporary surgical approaches for a complex challenge. Thank you.
Thank you. 안녕하세요. 처음 뵙겠습니다. Hello everyone. I'm Takashi Miura from Nagasaki University, Japan. Thank you for the opportunity to present contemporary surgical approaches for torrential TR. I talk about our surgical repair technique, spiral suspension, tethered leaflet, no COI. Okay. This slide shows a torrential TR or massive TR. How do you manage this patient? I think the isolated tricuspid angioplasty is not so effective. Residual or recurrent TR happen. And tricuspid replacement is good to control the TR completely. But the tricuspid repair, it depends on the surgeon's preference, I think. And but our heart team tried to repair these patients. Tricuspid repair technique for severe tethering, TR, functional TR. There are, I think, two approaches. First is a leaflet approach, the Clover technique, also presented, leaflet augmentation. And the other is a subannular approach, very famous papillary muscle approximation. And yesterday, I annular anterior papillary muscle to the septum approach is effective, I think. I think the sublunar annular approach is insightful, and the straightforward approach, I think. So our approach is spiral suspension. I introduce our approach. This technique already presented in the 2018. This approach is papillary muscle approximation, papillary muscle, and then lift up to the septal leaflet, mid portion of septal leaflet, and plus TAP. And the key of a spiral suspension is the RV anatomy. One is a trabeculation. The other is a papillary muscle location. Okay. Unique of a right ventricle anatomy is a trabeculation, I think, as very, very rich trabeculation. You can see the CT image, very rich trabeculation. This is anterior papillary muscle, look like Tokyo Tower, Eiffel Tower. And neocords to the leaflet. You can see the anatomy. Anterior papillary muscle is from molecular band. It's important. And this is an excellent paper published in 1971 and morphology human tricuspid valve. This is schema. And the anterior papillary muscle supports the commissure between anterior posterior leaflet. And the inferior papillary muscle supports septal and posterior leaflet. And posterior leaflet, some scallop. In that case, there is a accessory inferior papillary muscle. Our technique suture root here, 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 and approximated and pull to the here. Okay, suture size is a CV3. Okay, and important thing is this technique is less effective this portion. So we sometimes one or two magic suture here, not Clover technique. Okay, this is our surgical video. This is anterior papillary muscle. Support the anterior leaflet and the posterior leaflet. And the accessory inferior papillary muscle support the posterior leaflet. Inferior papillary muscle, inferior papillary muscle exists border, septum and the right ventricular valve. First, stitch root of anterior papillary muscle next to the accessory. This is the accessory stitch. And then inferior papillary muscle. Now I check the approximation. You can see the good approximate. And then stitch up to the one or two stitch to the septal leaflet mid portion. After ring implantation, I press a pulmonary trunk and lift up papillary muscle. Until leaflet reach to the axial ring level. You can see the improved tethering. On-pump beating surgery is possible, I think. This is about 30 years ago, do a surgery, TR recurrence. So we do our on-pump beating surgery. You can see anterior papillary muscle suture, neck. Next, inferior papillary muscle. Check the approximation, and then suture up, septum, annulus. And first saline injection test not effective, so pull the thread, and once again, second saline injection test. You can see the leaflet is up to the level of axial ring. This jet is a weak point. Please stitch magic suture here. You can control tricuspid agitation very well. Why do we pull the leaflet to the level of the axial ring? This is a mixed TAP for non-tethered leaflet. I usually see the leaflet go up to the axial ring level. So we try every patient to up to the leaflet to this level. This is the outcome. Okay. You can see the improvement leaflet tethering and the TR improvement, mild or less. And importantly, the RV dilatation improve. I think this technique may be effect of RV restoration. So by now, I have experience 36 patients, 2015 to 2023. And this is our patient data, tenting height about 9 millimeter, and RV mid diameter about 42 millimeter, RV FSC about 36. Half of patient is below normal value, and follow-up 30 to 1 years. In hospital mortality are 11%. And the initial indication, the tinting height 5 millimeter or more, tinting area 0.8 square or more. Now is indication expansion, the 10 millimeter is okay, I think. This is I think there is a two group. One is vertical tethering is stronger as a horizontal tethering. Right panel shows horizontal tethering is stronger as a vertical tethering. This is, I think, the terminal stage of our atrial function TR. Patient is very high elderly. And this is outcome. TR grade improved significantly. About 91% patient mild or less. And the functional class also improved. So I tried to myself study from April 2021. Now 28 hospital and almost Japan, and one is United States, Pittsburgh. Okay, now we are investing in the 3-year outcome. He is create this surgery. My mentor, previous professor, Eishi Kiyoyuki. And this is patient data. Now the patient number is 87. And this is the data. TRI score average is 8%. And the high-risk patient, 80%. Predict mortality 22 per 65. And in-hospital mortality, 4.6%. And the in-hospital mortality according to TRI score, there are no deaths, low-risk group, intermediate group, high-risk group, 4 patients died. This patient may be cardiac intervention may be better. Okay, TR grade important grade changes. About 86 patients mild or less. Recurrent patient or 12 patient rate is 30%. We compare the echo data, no TR, residual, recurrent TR group. This is the outcome. And no TR, recurrent, residual TR. There is a significant difference, tending height at discharge. Recurrent group is higher. RV mid at discharge, recurrent group is bigger, significantly bigger. But base, no difference. And RV FAC, no difference. LVF, no difference. But the estimated systolic PAP pressure has a significant difference at discharge. And the changes of the echo data or data, tenting height decreased just after surgery, discharge, and continue to the 3 years. RVD mid diameter also same pattern. RV FSC decreased just after surgery, and Slivis increased to the but did not reach normal value. I think the timing operation is delayed is one reason. Interim report, residual recurrent may be due to a more severe disease RV or to the running curve associated spiral suspension. Conclusion, spiral suspension is an effective procedure for tether leaflet, leading to improvement in both leaflet tethering and right ventricular dilatation. Long-term outcome and clearer indication will be reported in the near future. Thank you for your attention. 감사합니다.
Thank you, Dr. Miura. This is like the third time I've seen this technique. The first time Moritz showed it. It strikes me now with your spiral technique that you're recreating the moderator band that should be there, and like the analogy of the overstretched rubber band, the moderator band in the huge ventricle you showed in that first case is never going to come back. So are you saying those 2 cases you showed earlier successfully underwent your spiral technique and a repair? Remember those first 2 cases with, you showed the huge...
A very huge right ventricle.
Yeah,
but,
did you repair those with the spiral technique?
Did you know?
the first two echoes you showed,
yes.
with like the leaflets were like nowhere near each other
yes,
with a
no.
massive. Were you able to repair those two cases
Yes,
as well?
I think so.
Great. I think we have time for just a couple questions.
Sang-Yoon Kim from Seoul National University Bundang Hospital. Thank you for a nice presentation. And in your videos, you showed us that all the case was the virgin case without any previous history of the left heart surgery. And your surgery technique is involving only the free wall, anterior and inferior wall of RV. So if there is any adhesion of previous left heart surgery, if we approach this kind of TR patients through the right thoracotomy, do you recommend the free ring of the free RV wall or?
Relief of adhesion?
Yes,
I think so. Yes, I try to relieve adhesion routinely. But right mid-track approach, we cannot approach there. So as it is. So not
only inside.
Only inside.
Approximation can
yes,
remodel the RV dilatation with this kind of trabeculation remodeling.
Yes, I think it's possible. Depend on the adhesion.
Okay, thank you.
Okay, before closing this session, I'd like to comment a couple of things. First, the case presentation from the 12:10 will be held in this number 3 seminar room in 3rd floor, not in this place, because the lunch cannot be served in this auditorium. And then another participant for lunch will be served in the same floor at the restaurant. And another important thing, for the case presentation session, Dr. Badua has donated his honorarium to the award ceremony for the best presenters in the case sessions. Thank you. And you are enjoying AI-based simultaneous interpretation program. So we are appreciating your comments and multi-feedbacks, okay?
Thank you.
Thank you. Let's close this session. Thank you.
As attention, please. As we are delayed in this sometimes, so we have to continue in special lecture in line now, so we cannot skip in the short break time. Okay. Yeah, okay, sorry. Yes. Come on. 일단은 지금 시간이 좀 딜레이 돼서 바로 스페셜 렉처를 연달아서 진행하겠습니다. 착석해 주시면 감사하겠습니다.
Oh, they all left.
자장분들은 단상으로 올라와 주시면 감사하겠습니다. Yes. Okay, we will now proceed to the second distinguished special lecture of this forum. This session will be chaired by Professor Choi Gan-sung and Professor Pyeong Park. Please.
Okay, good morning, everybody. My name is J.K. Song, working in Assam Medical Center as an imaging specialist. I'm very happy to chair this special session with Dr. Pyeong Park. Our special guest for this lecture is Dr., as you know, the eminent surgeon from Johns Hopkins, Dr. Bowling, Dr. Michigan, and his professional career involved Johns Hopkins. I made a mistake. And he's going to talk about the very special title, Innovation in Cardiovascular Surgery, Balancing Success and Failure. Dr. Bowling, please.
Thank you very much. I did train at Hopkins. So I'm going to talk about innovation in cardiovascular surgery and more innovation in general. And we saw some innovative new techniques, the pivot bridge device, so we saw the Lux device. And the course of my career has been twofold. One, I wanted to be a very, very good mitral and tricuspid surgeon. And two, I've invented things. And every day in the United States, in every operating room, in every cath lab, somebody uses something that I invented. And that course of innovation has been very difficult, and it's very rewarding. And so I have this talk, Innovation in Cardiovascular Surgery, a balance of success and failure. And really, innovation, people wonder where innovation comes from. Well, innovation, one does not simply have an innovation. It doesn't just spontaneously generate. And in fact, innovation is evolving a new idea from nothing into something. And evolution takes time. And in fact, here are two old senior cardiac surgeons walking down the hall one day, and over their heads something goes, and I think it was a TAVR, and they're talking to each other. Time to innovate? I barely have time to eat. How can I innovate? And in fact, to innovate, you must set aside the time. You must think and observe. You must learn the skills, and you must work hard at it. This is you when you just decided to run a marathon, and of course you collapsed and you weren't able to do it. This is Des Linden, who is the first American woman to win the Boston Marathon after a streak of 25 years of African runners winning. She was the first American woman. And they asked her what her secret was to running and winning, and she said she ran a lot. There is no secret. You have to put in the time. We were the students who went to college for 4 years and then went to medical school for 4 years, and then I did a 10-year residency, and then I said I will be a junior faculty for 10 years, and at 18 years old I said I will spend the next 30 years of my life to become a good cardiac surgeon, and I was the one who said, oh, that sounds good. That sounds very good. And yet, we as cardiac surgeons decide we can sit on our back porch with a bourbon or some soju, and we say, oh, I'm going to innovate instantly, and that does not happen. You have to put in the time. You have to set aside the time. The problem in innovation is the bandwidth. I wanted to be a good person and a good husband and a good friend and a good child and a good surgeon. In fact, that is the balance. Actually, I wanted to be a great surgeon. So those are 7 things that I had to keep all those balls in the air. And yet I also was told I had to be a good educator and a good basic researcher and an administrator and a clinical researcher and a trialist. I wanted to be the chair. I wanted to do database things with the STS. Oh, and really down there, I wanted to be an innovator. And there's just not enough bandwidth in your life to balance all those balls and keep them in your air. You have to choose what you want to do. And if you want to be an innovator, you must commit to do it. I break innovation into 3 parts: ideation, iteration, and culmination. The first is ideation, and you think to yourself, what is an idea? It's this intangible product of your mind. It's not really. An idea is very tangible. It's an actual thing. IP is real, it's worth, it's protected by law, and so on. And an idea is really a future prediction. Yogi Berra, a baseball player, said, it's tough to make predictions, especially about the future. Well, of course, that is what you have to do. But you, as a surgeon, already have an idea. If you've ever complained about something, you have an idea. If you've ever said, I can do that better, what we really need is a blah, blah, blah. Why isn't there a blah, blah, blah? You have an idea. Be mindful. Be mindful of all the things around you in your operating room, in your life, based on your practice, your research, nature, everything. You have an idea. Why didn't I invent Uber? I should have invented Uber, but it really wasn't what I was mindful about. At the time of Uber, there were no cell phones and so on like that. I couldn't get a cab in Manhattan. I should have invented Uber, but I wasn't mindful enough about it. In fact, where do ideas come? People say, like, think outside of your box. No, you're not going to think outside of your box. I'm not going to walk down the street and suddenly think, I have an idea for nuclear fusion power. I'm not a nuclear physicist. That's not going to happen. What you want to do is think inside your box. I'm a mathematician. I am a doctor and a heart surgeon. I'm going to think about things that are sort of related to those things. So think inside your box. Use your skill sets. That's where your ideas come. But we have to step back and say, don't be evidence-based. Don't do what we've always done. Don't follow the guidelines. I know that's a terrible thing to say. Don't be satisfied. Don't be happy with how we do it right now. Hopefully, 50 years from now, they will look at what we talked about tricuspid valve today, and we think, those people were idiots. Your idea is the future. In ideation, we have a phrase, move to friction. Move where there's a problem. There has to be a problem or a need, and there has to be someone willing to pay for that. And in fact, we say in ideation, move into a burning building. This is where you want to go. Run into that burning building. That's where there is a problem. That's where your idea will come from. Be disruptive, but timely. Predict 10 to 15 years in the future, not 1 year. Yoshi just thought up a 7-lumen swan. We already have a 6-lumen swan. No one cares about Yoshi's idea because in 1 year we're going to have that. It doesn't matter. But also don't think 100 years from now, because 100 years from now we will have submolecular atomic micro gene splicing circulating nanobots. We have no idea what will happen in 100 years. Everything occurs in a 15-year timeline in medical innovation. 15 years, that is a magic number. And if you look at it, it's not just medicine. 15 years from the introduction of MitraClip, it became a thing. 15 years from the introduction of coronary bypass, it became a thing. 15 years from PCI, it became a thing. 15 years from the introduction of automatic transmission, it became a thing. 15 years from the introduction of microwave in your house to it's a thing. JB, did you ever think you needed a microwave in your house? Did you ever want to cook a hot dog in less than 1 second? No. But now you can't live without a microwave, and it was 15 years. That is the timeline at which innovation occurs. TAVR, look at this. It is easier and works the same. It even looks the same. It's a great idea. There's going to be no more surgical AVRs, and it took 15 years from the time that was stood up to the time it became a clinical reality. So you have an idea now. Write that idea down. And people used to say, scribble it on the back of a napkin and sell it for $1 million. No, actually, if you scribble it on a napkin, it's worse. It's less worse than the cost of a napkin because now it's just a used napkin. You have to develop that idea. You have to evolve the idea. Innovation is about evolution. You need a change agent. You need time. You need hard work. You need passion. You need expertise. You need money. And then you need more hard work. No one works harder than heart surgeons. Cardiovascular surgeons thrive on hard work. We said, I'm going to work 100 hours a week at Hopkins, and those were the lazy ones. Thomas Edison said, opportunity is missed by most people because it is dressed in overalls and looks like work. Innovation is hard work. So the first thing you want to do is, people say, validate your idea. No, I say invalidate the idea. Talk to someone, sign a CDA, a friend, an expert, but always sign them to trust but verify, sign them that. Trust but verify, that was by the classical innovator, Joseph Stalin. Because your idea is probably bad. And if I have an idea, I want someone to tell me almost right away, Steve, that's a stupid idea and it'll never work. I want to have that so that I fail fast. I fail smart and I fail fast. I know almost right away that my idea is dumb and I shouldn't do it. But innovation in cardiovascular surgery has to be very careful. Look on the left. I play baseball and I hit 300. I am going to the Hall of Fame. I play basketball and 30% of the time I can hit a three-pointer. I am in the Hall of Fame in basketball. But that's a 70% failure rate. If I go into my patients, I say, I'm doing this thing and there's a 70% chance you will die or do horrible and it's going to be a total failure. We cannot do that. We expect failure never in surgery. We want to have a 99.9% success rate, so it's very different. Medical innovation is different than automotive innovation or everything. So that's why medical innovation is different, and that's why doctors are like this. Yes to innovation, no to change. Well, how about that? We're the only people that say It's new, it's different, we hate it. That's the first thing that comes out of every cardiovascular surgeon's mind when we see something like the pivot bridge. It's new, it's different, we hate it. You know, this is the Lux valve, it's new, it's different, we hate it. Absolutely. So now you have your idea. What do you do with that idea? Well, now you move to the second phase. We're very good at thinking ideas. But now iteration, that's something that we're not quite as good at. The first thing you do is protect yourself. You need to know about intellectual property and your conflict of interest at your hospital, your university, and so on like that. You want to be able to explain the concept to your mom in one word. Mom, I'm doing a really good thing. Because if you don't say good thing to your mom, you will see it in the headline in the newspaper, heart surgeon does bad thing. So always know that you're doing the right thing. Do the right thing. The second thing is protect your idea. So first you've protected yourself. You know your institution's relationship to IP, conflict of interest, something like that. Don't look at any patents. Patents, if you look at patents in the area you're looking at, it'll change your brain about things. A good patent attorney can always squeeze a good idea in. And the second thing is, certainly in the United States, file, baby, file. We file patents all the time, all the time, all the time, all the time. Half of them, 90% of them never get issues, but just keep filing, 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 filing. So now what do you need? You need two things to move ahead. You need a team and you need money. So don't be a lone wolf. No one is a lone wolf in innovation. Don't follow your own dream. You know, that sounds like a bad thing to say, but your own dream, you can't do it by yourself. Someone else is smarter in this area. So why? I've been the founder of over 23 small medical companies. Why is the founder a bad word? A startup founder? Because I am a dork. I am fixated on a vision. I overrate my own capabilities. I fail to delegate, and I micromanage everything, which is perfect for a cardiac surgeon. We have to do that in the operating room or the patient dies. That's what we're used to doing. But it's not perfect for an innovator. This is hard to believe, but eventually you are not the one. You are not the best at everything. You are not the best at everything. Cardiac surgeons, I find that hard to believe. But we're not. So get a smart, motivated team and complementary domain expertise, and it's a balance between you and your team. So now you have your team around you. You have you with a good idea. You have an engineer who can prototype and test and make something for you. You have a lawyer. He does your business for you, your intellectual property. You have a manager, maybe with an MBA, leading the team and executing. You have to learn to speak their language. So my engineers gave him this book, Engineers for Dummies, because I'm a dummy when it comes to engineering, and I gave them this book, Open Heart Surgery for Dummies, right? So we learn to speak each other's language together. That's how we move forward. So now you have your team around you. Somebody has to pay for that. That is a lot of people on your team, so you need to get money. As heart surgeons, we can get money from angels and our friends and our family and the NIH and SBIR and SDR. Also, beware of self-funding. All of you heart surgeons in this room are rich, and you can fund it yourself, and you can go broke doing that. Do not do that. Eventually, you're going to have to go to venture capital. And venture capital is like this. Here's the venture capitalist standing up, and that's you sitting down, and the venture capitalist says, with your idea and my nothing, we will be rich. What do they bring to the table? They're just rip-off artists. They're stealing my idea and make money off me. No, not at all. Venture capital wants a 5 or a 10-time return. If they give you $1 million, they expect $10 million in return, because venture capital has the same root as adventure and misadventure. And in fact, if you look at venture capital investments into small startups, 75% have no profit and 25% totally fail. And then you look and you say, Steve, that sounds like 100% of them fail. Almost 100% of them fail. So they have to cover their bets, and they want a big return from that 1 out of 100 or that 1 out of 20 that may return some of their money. Most of them We use this term in venture capital, our DNR, which is slightly different than what you and I think is DNR. This is did not return money. So, does a VC care about your idea? There's your idea. You have the greatest idea in the world. Do they care about it? They will ask you, will it make money? And you know what? They like that idea over there because it's going to make a lot more money. So if you invent something that normally sells for 1 won, and now you can have a better one and it sells for 2 won, no one cares. No one cares. They will not give you any money for that. Venture capital will come in and value your company, mostly on patents or prototypes that you have, animals, first in human data, the team and so on like that, but they're very good. People do this and they're very good at it. Due diligence is not just wild guessing. They're very good at saying, this company right now is worth $10 million. This company is worth $100 million. This company is worth $1 billion. This is something you have to learn if you're going to go into innovation. OPM, other people's money. Take other people's money in your company. And here's, as a math person, I will say, 10% of something is worth a lot more than 100% of nothing. So take money in, fund your team, give a lot of the company away, because that's the only way you're going to have success. Iteration. Now you have it set to go. You have your team ready to go. Now you're actually ready to iterate. And this is the fun part for us. Make it work. Iterate, test, reiterate, retest, lather, rinse, repeat. Fail fast, fail smart. This is where you look like, this is MacGyver. You build things that have never been built before. This is the really creative part of it. You think to yourself, this particular device, prototype thing, whatever, has never been done in the history of humanity. That's great. And somebody mentioned Home Depot. This is my favorite store, and I go there at midnight. If I cannot build something out of what I can find or buy at Home Depot, then it's not good. I can make anything at Home Depot. So we have to be very careful that iteration is not research. Venture capital, innovation is different from academics. Investors are wary of MDPH. Publication is public. So we will iterate a company more and more again, and you will never see it published. It never is published. Once it becomes published, it is in the public domain. So it is very different than research. Iteration takes time. This is what most people think. You either win or you lose. You don't. As I said when I stood up, you fail, and you fail, and you fail, and you change, and you fail, and you react to that failure, and iterate, and finally maybe you win. It is a grind. You will not get it right at first. Not all iterations are improvements. You will go down a blind alley, and you'll come back, and you'll go a different way. You will pivot to a different way. Models are not patience. I've seen many a startup company try to build the best device for a sheep. Now, you have to very quickly decide that this device is good and go to humans. Go to first in human fast, thoughtfully, carefully, but fast. Human devices work best in humans, and document everything you do. So this is Dr. DeBakey iterating. This is actually him on his wife's sewing machine making the first Dacron aortic tube graft. That is iteration, and you have to be fierce about it. He would operate, then think about it, then go home and make this in his wife's sewing room. You have to be fierce. Be fierce. This is startup. You have to be absolutely committed to it. So, now you've had an idea. Now you've had iteration and you have something. Now you have to have culmination. This is the hardest part for physicians and surgeons to think about. You have to sell this to a large company. You have to sell this to Medtronics, Edwards, Abbott, blah, 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 blah. Because if you don't, you can never make 1 million of these devices and affect humanity. So this is the hardest part for us, is to sell it to a large corporation. This is my plan. Start up, cash in, sell out, bro down. That is not how it works. You need a Yoda. I need someone in my ear who's very smart in business telling me to do this, telling me there is no try, there is only exit. The only success is when you sell this to someone who can put it in 1 million people, because I cannot do that myself. It is not a science project. Innovation is not a science project in any way. You need to build it, you need to use it, and you need to sell it. That's how you will help people. Entrepreneur, I grew up in Europe. I speak French as my first language. Entrepreneur, that word in French means to create financial value. That's what it actually means, entrepreneur. You need someone on your board to tell you this, to be an exit ninja who tells you to only speak twice. You only speak about a company or a device when you need money to start and when you want money to sell. That is it. Otherwise, you are quiet. You need someone on your board or in your group who's a terminator to tell you, hasta la vista, baby, time to be over. Because this is your baby. This is your idea. You love it so much, so much. But there's sometimes where someone has to tell you, pivot, that is not the right direction, go to this thing. And then even worse is they tell you, bail out, it's done. This is useless, time to cut and burn and leave the scene. Steve Jobs says, innovation is the ability to see change as an opportunity, not a threat. And that is the hardest thing to do in cardiovascular surgery because the stakes are so high. The stakes that you and I deal with every day in cardiovascular surgery and interventional cardiology is death. And that is the highest stake. But we need to see change. That's how we move things forward. It's interesting, Henry Ford said, if I had asked people what they wanted, they would have said faster horses. Most of the time, we don't know what we want. It's not that they really were looking for faster horses. Henry Ford gave them an automobile. They weren't even thinking of that at all. The story is that Steve Jobs in his book says if they had taken 100 cardiologists in a room in 1970 and said, J&J, we have this idea to take plaque. We're going to stick a balloon in coronary plaque, blow it up, and then inside of that blasted plaque, we're going to put a tiny metal finger puzzle to stent it open. Of those 100 cardiologists in the room, 99 of them would have said, that's a really bad idea. And one of them would have said, you need to send yourself to the police and be arrested because you're so dangerous. That would have missed $1 trillion of revenue in the field of stenting. And also, how many patients? 50 million people have been stented so far. So we don't know what we actually need. We don't need a better horse. We need an automobile. So innovation in medicine, what is it going to be like? I mean, is this going to be us as cardiovascular surgeons in 50 years? I don't know. When I was growing up, I like Star Trek. This is what I thought the future was going to be, and it turned out it wasn't this. So the things in innovation, if I can wrap it up, is the 4 Ps is you need a plan, you need people around you, people that are smarter than you in different areas. You need patience. It takes a long time. This is going to take at least 15 years. And the last P, you need plenty of time, work, and money. But if you can balance these three things, ideation, iteration, and culmination, and keep them in balance with the rest of your life, your family, your job, your surgery, and so on like that, it can be a whirl. So Churchill said, success is walking from failure to failure with no loss of enthusiasm. And I have failed in innovation more than I have succeeded. But I have been very lucky in a number of things. So innovation is a whirl. It's very much fun. And it's a whirl of try and fail, try and fail, try and fail, try and fail. And many times, this is where that whirl ends up, down the toilet. But sometimes you will hit a wave. You will hit a big wave, and then you will hit success. And that is a great feeling. If you think of it, one of my products, I don't know who does TAVRs in here, is the Claret Sentinel. We sold that to Boston Scientific for almost $500 million, and that's now had 100,000 implants worldwide, the embolic protection device that goes up your carotid. So, innovation in my final slide. It takes forever to be an overnight success. It really does. So enjoy it. Thank you very much.
Thank you, Berlin, for an excellent and quite stimulating lecture. Any comment? He finished his talk before lunch time. We are supposed to have lunch at 12:10, but he finished his lecture at 12, which means he needs some other stimuli from young people.
Great talk. Thank you so much. So you are a man of great success in the field of cardiac surgery and invention, making money, and marathon running as well. So strong and patient. So we talked earlier last night about the success and failure. So I have no question, but why don't you share your kind of greatest failure to lead to your position right now? So why don't you share some kind of detailed example to see how you
My greatest failures.
Yeah.
Thank you for that terrible question.
So how did you handle that failure to be?
So I think my greatest failure was I had invented a TAVR, and the TAVR company was called Direct Flow Medical. I don't know if any of you know it. It was an inflatable valve. At that time, Sapien had just started and had a terrible amount of perivalvular leak. So we invented an inflatable TAVR that we would put in the place. It was inflated with saline, and then it was hardened with a polyacrylate resin, and it would sit in there, and it worked really well. And we probably had 100 implants. The results were great. There was very little perivalvular leak at that time, and then we got slow. We got slowed down, and Sapien put a skirt on there, and so they sort of took us out. And we had an offer on the table from a large corporation, and our board decided, no, we'll wait a little bit, and we ended up nothing. So that is one of my biggest disappointments. My other big disappointment is I have a patent and a company on an electronic grocery cart. And I have a lot of different patents in different sensor areas. And I thought it was the most brilliant idea ever. And it was for self-checkout from a grocery store. You just throw it in the grocery cart, and it would go out, and it would charge your account. And it was a great idea, and we didn't develop fast enough, and now it's being passed by other things. So those, I think, are my two biggest failures. But I learned from both of them. I learned, to sell early to a corporation because they'll be able to take it from your hands. And even though it is your baby, you have to give it to someone else to help humanity. I will never be able to build 100 million things and put it into a human, but somebody else will. Yoshi.
Steve, great talk, very inspiring. So you are a world-class surgeon.
Thank you.
And you're a brilliant innovator.
Thank you.
So how do you do it? So do you just start innovating on Sundays?
No.
I mean, how do you divide? I mean, before you go to bed? Because, if you're operating, you got to concentrate on what you do. Yeah. So how do you balance the two? If you can give us some tips.
Yeah, so of those things that I put up there, you eventually have to make a choice. I am not the chairman at the University of Michigan. I am not an administrator at the university. I do not have enough bandwidth to do that. I don't do that. I trained at Johns Hopkins Hospital, and I was told you're only a success if you are a chairman. That is it. You will never be world famous unless you're a chairman. You'll never be good unless you're a chairman. I believed that for a little while until then I said, no, that's just not true. I could care less whether I'm a chairman or not. So I don't do that. And you have to say, this is what I'm going to pick. This is what I'm not going to do. There were 3 of us who trained at Johns Hopkins at the same time. And as you guys, the Americans know, of the 3 who graduated, 2 were in general surgery and 1 in cardiac surgery. And I went back this year and I was invited to give the Blaylock Lectureship at Hopkins. And the 2 other residents who finished, one is the chairman at Massachusetts General Hospital, great success. One is the chairman at Jefferson in Philadelphia, great success. And I'm the failure.
One last personal curiosity. Does your running marathon have anything to do with your great success, you think?
So I think it does. I think it does. I don't know if you work, but Davey knows this, that I run to work every day. It's 10 kilometers from my house to my operating room. So I run every single day to the hospital, and during that time, that is my Zen time, and that is what I think about. You have to set time apart to think of that. You're not going to sit on your back porch with a bourbon and suddenly think of a brilliant idea. You're not going to do that, I guarantee you. You have to put in as much effort into innovation as we did to become cardiac surgeons.
Last.
Thank you. I'm Dr. Jeong from Korea University. Thank you for your great talk. I already made my company 3 years ago.
Perfect.
But 100%. I got the invest money, but at least it failed. Last year I left up my company. Same to many of our companies. So same is I made some idea. I gathering the team. I make do the animal study and then cadaver study. But I contact many of international company. They have some interesting, but at least we left up. So I have some IP and some idea, but we stop everything now. So any advice about that? After that, I have to keep the IP, and then we have to more find another way. Your comment, please.
So welcome to the world of innovation. You will fail far more than you win. My very first company that I sold, I had a tube with a balloon on it. And I went to a company called DLP and I said, I think you can put this in the coronary sinus and give cardioplegia retrograde. And they bought it from me, and that became bought by Medtronic. That was my first company that I sold. So I thought, wow, that was my first idea. That's easy. I can sell everything I did. So I thought innovation is the easiest thing in the world. It's unbelievable. And then I failed, and 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 that is what we face. And it's moving from through all those failures that you've had now to enthusiasm. That idea that you have, or that company you have, may be bad. It may be terrible. It may be really bad. And it may be time to just throw that one away, but move on to something else. You've already had a taste of what innovation is like. So I would say everyone here with an idea should try to innovate that idea into something. You will fail, but don't be discouraged. Keep failing.
Thank you.
Okay, thank you very much, Professor Burley, for sharing your personal experience. And let's take a break for light lunch, and we will continue this session in the afternoon. Thank you very much.
Yes, so we now in the break for lunches. Lunch will be served in this cafeteria in the same floor. There is an announcement with lunches, but the obstructional oral presentation will take place in seminar number 3, starting in the 12:10 p.m. We kindly ask the chair, presenter discussions in the same room.
Go.
아까 공지된 대로 지금 이 세션을 시작하기 전에 베스트 오럴 프레젠테이션 어워드가 먼저 진행될 예정입니다. 시간이 돼서 착석해 주시기 바랍니다. And before the session, and we now is presenting STS Abstract Award ceremony for the best oral presentation in this program. Please waiting a minute. Okay, we are starting the ceremony. And now we're starting in the STS Abstract Award ceremony for this program. At this program, more than 20 abstract awards are made, and 6 outstanding studies were selected for oral presentations. Among them, 3 presenters who delivered the most exceptional presentation will be honored with these awards. And we sincerely appreciate it and dedication and effort of the 10 reviewers. Okay, the award ceremonies will be conducted by professors Vinay Badiwar, who generously provided funding for this prize. Okay, so may I kindly invite the award recipient to come up the stage. At the third place goes to the Dr. Yuri Lee from the Samsung Medical Center. It's congratulations. Please come up to the stage.
All of the abstracts were superb, and I want to make sure that it's the STS that's sponsoring the award. So, very good. Congratulations.
Has been selected as the STS Award held this forum in 2025 to be held on Sam in front of Team South Korea. Congratulations. So now we will go into second place. Second place award to Dr. Kevin Jin is from the Northwestern University in the USA. Congratulations. It's where? Okay, so please come up to the stage. Has been in the Progress Award in the Hot Baptist Forum 2025 in the South Korea. Congratulations one more. Okay, so we are final winner in the best presentation in this program. Dr. Patty Choi and Stanford from the USA. Congratulations. Selected the winner of the Education Award and the 2025 Hot Business Forum in South Korea. Okay, thank you for Professor Pinarudani and congratulations on the 3 winners in presentations. Okay, so now we were starting the afternoon session. The title is just debate session to repair or not repair the moderate functional tear in left side valve surgery. It is moderated by Seung-hyun Lee and Toshi Kaneko.
Thank you. This is a hot debate session. We are 2 fighters, and Dr. JB, Chris. And the topic is to repair or not to repair of moderate functional TR in left side valve surgery. So first lecture is about the treatment of a concomitant TR. What are the guidelines and where is the data? Dr. Moritz, okay. Please.
Well, good afternoon, everyone. It's a pleasure to be here with everyone. Thank you so much for the invitation. I want to thank the organizing committee, especially Dr. Kim for the invitation, and then Dr. Sung, Dr. Chung, and Dr. Malesri for putting together a truly fantastic program. I guess my assignment here was setting the stage. I'm going to stay out of the debate because I already made up my mind on this topic, but I'm looking forward to the pros and cons on this specific topic, which is really around concomitant TR, when should we repair or treat it. And I'm going to focus mostly on the data. The guidelines are going to be 2 slides, so that's going to be pretty quick. But I'll show some of the data and then some of my thought process around that. But before we do get started, I want to again thank the organizing committee and everybody for your hospitality. I also, I got home last night and I was very thirsty. And so if nothing makes sense in my talk today, there's a good reason, because I came home to my hotel room and I don't remember anything after that. Now, if we address the question if we should treat concomitant TR, so at the time of other planned cardiac surgery, I think there's really 3 basic questions we have to address. Is it common? Is TR common? And I would say, yeah, it is common. It's probably more common than we all like to think it is. And we're probably undersubscribed on detecting TR in general. We're very good at looking for TR in mitral valve patients, but maybe not so good when it comes to CABG patients or aortic patients. Then the second question, is it safe? If it doesn't increase short-term morbidity, mortality, there's probably little argument against addressing the TR. And then lastly, is it helpful? Does it improve long-term outcomes? And if it does, then most certainly we should do something about it. So just a brief slide to give you some perspective how common it is and what we're currently doing about it as a global community of cardiac surgeons. In mitral valve repair, this is from our mitral valve repair risk model, about 1 in 4 patients has at least moderate or severe TR. Number goes up if you include mild TR. If you look at CABG population, about 3% have moderate or severe TR. It's about 20% if you include mild TR as well. But then if you go over to the right-hand side and look at how often we're treating that, it's best, if you may say so, in the primary MR population, but still only 2 out of 3 patients get treated for TR if it's moderate or severe. If you look at the CABG population, less than 2% with moderate TR get any treatment, and only 1 in 3 patients with severe TR get something about their tricuspid valve. So if we can agree that it's important to address it, it's safe, and it provides improved long-term outcomes, arguably we can do much better than that. So a different way of looking at this is, what are the arguments against and for treating concomitant TR? Really, I could come up with only very few arguments or scenarios why not to treat concomitant TR. If primary surgery will entirely magically reverse all of the TR, well, that's highly unlikely. I can't think of anything that would really be like that you just magically reverse all of the TR or prevent further progression of TR. If there's very poor risk-benefit ratio, that would be an argument against it, but that I will show you with some data that's probably not a good argument to be made all too often. And then, of course, short life expectancy in general, but then someone who has such a short life expectancy that it wouldn't matter to address TR, that's probably not a good patient for open heart surgery to begin with. And then there's the yeses. Is it practical and safe? And I'll show you some data that it is. It is effective. It is helping with preventing progression of TR. And so the other 2 questions are, is it improving short-term outcomes and long-term outcomes? Maybe a little softer on that point in terms of data, and maybe an opportunity for all of us to provide more of that data and provide better evidence for it. But if you can buy into it's practical, safe, and it does address progression of TR, then almost certainly it will translate into better short and long-term outcomes. Another important aspect, I think, if we talk about concomitant treatment and maybe separately from just isolated TR, is the etiology and associated pathology. That's very important in these patients. If it's primary TR, especially if they have pacemaker leads or ICD leads, if you do something about the aortic valve or aortic surgery or mitral valve, that ICD lead is not magically going to go somewhere. If you have atrial fibrillation, again, if you do aortic valve surgery or aortic surgery, that atrial fibrillation is not just going to magically disappear. And the secondary TR is just a whole other beast in and of itself, and I'll show you some data and why I think that is. And I think a lot of that has already been alluded to, but secondary TR is mostly a ventricular problem and therefore not something that will just magically disappear if you do a mitral valve or aortic surgery as the primary indication for going to the OR. So again, it's relatively repetitive at some point in these meetings, but I think it just helps to remind everybody how devastating that tricuspid regurgitation is, how much it impacts long-term survival. And again, most of it is secondary TR. It's the result of atrial fibrillation, pulmonary hypertension, RV dysfunction, all these things that ultimately leave a dysfunctional tricuspid valve. The remodeling of the right ventricle plays an important role. Secondary to that, the remodeling of the tricuspid annulus. And again, these are not things that magically just return to normal if you address the bypass surgery that's needed, or you address the aortic valve, or the aortic pathology that you're going to the OR for. So again, most of these things that we do where we have concomitant TR will not magically eradicate the TR or prevent further progression of the TR. And that is because a lot of it is secondary. It's a dilated RV. The ventricle runs essentially out of valve. There's not enough valve to cover the big area anymore. There's more TVR. There's a vicious cycle that ensues. Functional TR is a progressive disease. I think as many others have shown before me in their talks here, there is a progression of TR. Even if we address it, there's arguably some more progression of that. And so again, another argument why we have to maybe be more cautious about addressing it and addressing it sooner. And then of course, it's that bucket of patients that have EP leads that go through anterior tricuspid leaflet, like the case I recently did, patients with atrial fibrillation, and patients that you often see here, I would assume, with rheumatic valve disease, all things that will not magically reverse or go away if you address other things in the heart, but will continue to make TR progress and worsen the prognosis. So what's additional and I think important to know is what happens with patients that do not get treated. Well, the reality is a lot of these patients don't get treated for a long time. They fall off the curve a little bit. Oftentimes, if these patients come, and you think about it, they come, they have a surgery, they have moderate TR, the surgeon goes to the OR, addresses everything but not the moderate TR, sends the wrong message to our referring cardiologist, to PCPs, that moderate TR is not bad, when in fact, it's a huge problem. So the next step, of course, is to make sure that it's not just important and we can address it, but we have to make sure that what we do and what we can offer is effective. And there's some data on that. There's some data on the different techniques. I think many of the speakers before me have alluded to the different techniques and the different possibilities of how we can address TR. This is a well-known study from the Cleveland Clinic that looked at essentially tricuspid ring band-based techniques and suture-based techniques. I would say there is some conflicting evidence out there perhaps, but overall the overwhelming majority of the data would suggest that a ring is definitely the way to go and has improved outcomes and durability in the intermediate and long term over just suture-based techniques. But even if we do rings and if we do rigid rings and we do that well, there's probably an element of recurrence and progression of TR. That's where all the other techniques come in. Some of them we've heard about, the edge-to-edge repairs, the tricuspid apparatus techniques that we've spoken about. So there is maybe more for us to discover and understand better, and I would use that as sort of an appeal to all of you to participate in research and these endeavors to better understand what these additional techniques add to this long-term durability of tricuspid valve repairs. So with that, let's get into the data a little bit. There's a vast array of studies that have been done. I'm just going to pick out some that stand out, but sort of tell the recurring story of TR is bad, TR needs to be addressed, and probably TR needs to be addressed sooner than we have in the past and than guidelines have suggested in the past. This is a study from here, from Seoul, very nice study, smaller group, a propensity-matched cohort that did not show a difference in long-term survival at 12 years, but a significantly better freedom from tricuspid regurgitation. The next study I'll show you is, and I apologize, I clicked on the wrong thing here, but the next study is a study from Al-Khoury. It's a small randomized clinical trial that was published in 2019, I believe. And it randomized 53 patients to tricuspid repair in patients that had less than severe tricuspid regurgitation at the time of a mitral valve repair. As you can tell easily from the Kaplan-Meier curves, there's a dramatic difference in the difference between the repair and non-repair group in the recurrence or existence of moderate severe TR at 1 year, 2 years, 3 years, 4 years, and 5 years. And as you can see in the bottom panel, a dramatic reduction in the TR level overall and no progression to more severe grades of TR as opposed to the group that didn't have a tricuspid valve repair. The short-term survival was equivalent, so no real harm with doing the tricuspid valve repair, and there was, again, substantial reduction in TR and TR progression. They didn't report the pacemaker rates, and that's something I'll highlight with the next study, but that's obviously another important aspect of this. And the next study, as many of you may anticipate, is the CTS-NET trial, the largest randomized clinical trial on this specific topic to date, with 401 patients randomized that underwent mitral valve repair, all of them with less than severe TR, so anything from mild trace to moderate TR, and with a 2-year follow-up. As you can tell from the panels, the progression of tricuspid regurgitation is really what drove the primary endpoint, with a dramatic reduction in the progression of tricuspid regurgitation, better reduction of TR at all time points, but with the one caveat that there was a higher pacemaker rate. And a pacemaker rate, I would say, that most of us were surprised to see, higher than most of us would have anticipated. And while many of us will say, well, that's not me, and I do a better job, I think we have to respect the fact that in this trial of expert surgeons that participated in the trial, there was still a 14% pacemaker rate between the two groups, over 14% versus 2.5% in non-tricuspid repair. So if you take all of this together and you add a few more studies that looked at other things, such as patients with no significant tricuspid regurgitation, but anal dilation that benefited from tricuspid valve repair. If you look at right ventricular function, pulmonary artery hypertension after repair of the tricuspid valve in the setting of mitral valve repair, all these other things, you will find that there's a consistent message. And it's again and again that tricuspid valve repair probably needs to happen sooner and has substantial benefits in terms of reducing tricuspid valve regurgitation. There was a meta-analysis that was recently published on this topic. They looked at concomitant early tricuspid valve repair, bunched all the studies together, and so they showed substantially reduction in TR short term, reduction in TR progression at intermediate and long term. They further showed that it did prolong the case time, about 18 minutes more on the cross clamp, but at no cost in terms of long-term or short-term mortality in these patients. I go back one slide. There was a modest increase, as you might expect, and sort of in tune with the CTS-NET trial of increased pacemaker risk in these patients that had concomitant tricuspid valve repair. And again, if you look at short-term outcomes, no increase in short-term morbidity, mortality other than the pacemaker signal. And to date, no convincing and strong data that says long-term survival is different in the patients that have tricuspid valve repair. And again, I think that's mostly to say that we have an opportunity to show that benefit in more clarity between patients that have and have not tricuspid valve repair. And it's probably modeled in these studies that take at different kinds of populations and try to figure out if it's all the same in the long term with and without tricuspid valve repair. That there's no harm with short-term outcomes in terms of doing a tricuspid valve repair is also then reflected in our STS risk models. If you take the models, you punch in a patient, and the one time here on top, you have the patient undergoing a mitral valve repair, aortic valve replacement, CABG, and then at the bottom, or to the right, I'm sorry, with the tricuspid valve repair, you do not see an increase in risk, short-term risk for these patients, no increased mortality signal in these patients. The same we did in the primary MR risk calculator, where we specifically included that along with atrial fibrillation surgery. Does not show an increase in short-term mortality, small change in short-term morbidity, but again, would suggest that doing a tricuspid valve repair is safe. So I think we've established it's common, tricuspid valve repair is safe, and it is helpful in terms of reducing TR and avoiding progression of tricuspid regurgitation over the time course. So the last two slides are pretty much going to be the guidelines. The most recent guidelines are the 2020 guidelines from the ACC and AHA, and those were short on the tricuspid patients for concomitant tricuspid valve surgery. Class 1 indication for patients that have severe TR and go to the OR for left-sided, and specifically left-sided, valve surgery, tricuspid valve surgery is recommended. That was mostly based on the trials that have done in the mitral space looking at the specific topic. And the 2A indication for patients with progressive TR as defined as patients who have a dilation of the tricuspid annulus. And I would say in a very refreshing twist of events, the most recent guidelines that have been published, and they were published I think just last week by the European Society, the European Society of Cardiology, European Association of Cardiothoracic Surgery, there's clearly a shift. There's a shift in no longer being tied to just left-sided surgery, so the class 1 indication for doing a concomitant tricuspid valve repair is for all patients with primary or secondary severe TR. So whether it's an aortic case, a CABG case, anything else, it doesn't matter anymore. It's recommended to do a tricuspid valve repair in patients with severe TR. There's now support for earlier intervention with a 2A indication for patients that have moderate primary or secondary TR that are at risk of progression and to avoid that progression of TR and RV dysfunction and remodeling. And there is support for an anatomy-based indication, so not purely on the severity of the TR, but now specifically speaking to the dilation of the tricuspid annulus. A lot of that data came from Jill Dreyfus and others that have looked at specific patient populations that didn't have a tremendous amount of TR, but had a dilated tricuspid annulus, and showing the benefit of intervening early. So what does that mean for me in my practice? It means that while in the past I have felt maybe a little oversubscribed on the tricuspid repair front, I feel redeemed with these new guidelines. I tend to take a rather aggressive approach to tricuspid valve repair surgery. Essentially, anybody with mild plus gets a repair. I personally don't really believe that if you have mild TR and an ICD lead sitting there, that will ever get better. If you have atrial fibrillation, you buy yourself a COX-3/4 MACE procedure, because without that, it doesn't matter so much what else you do, because you're missing out on a huge opportunity to improve the patient long-term morbidity, mortality, and reduction in progression of TR and MR. And of course, in the patients with secondary TR, when again, most of the damage has happened, and I think we can't really build on the hope that the RV will remodel sufficiently that this TR will go away. What it looks like for me is primary TR, tricuspid valve repair if it's mild, if it's moderate. So it's depending on the exact anatomy, whatever the problem is with the mitral valve. If there's EP leads, I will do the annuloplasty and consider moving the leads, either removing the leads and placing epicardial leads, pinning the leads to some extent. I think that's a little bit of a double-edged sword. In patients with TR, they buy themselves a COX-3/4 MACE procedure plus the annuloplasty. Severe secondary TR, that is least moderate, is an annuloplasty plus minus subannular techniques, and then pretty much across the board for all other stuff, either TR with annular dilation, secondary TR with RV dilation. I often now add a subannular technique. It's relatively simple. It doesn't add much time. And I feel there is some potential benefit, while we still have to delineate that better, what it really means in long-term durability. and outcomes, I do think that there's potential some benefit. So with that, I'll conclude and be happy to take any questions. Thank you.
Thanks, Dr. Morris. Next two topics will introduced by Dr. Yoshi Kaneko.
Yeah, so this is going to be the debate part. These two are very good friends, but I think we're going to see a death match with blood. We're going to start with Jambum Kim. Everybody knows JB. I think he's the underdog, do not repair, but we're going to hear his side.
Thank you for a nice introduction. So how do I start my slide? 좀 봐주실래요? 슬라이드가 없는데. What a mess. So,
is sabotaging you.
yeah, I guess so. Look,
It's unintentional.
So things happened like this. It was back in Seattle AETS meeting. Chris and I was running a beachside, and it was beautiful. And I asked him to do it again. What is that? Debate. This time, moderate TR, functional TR. Do you repair? I do. Me too. So what is it reasonable to do debate where repairing versus not repairing T valve? Yeah, it's good. So what is your side? Either way, me too. So let's randomize. So I was allocated to not to repair T valve in moderate TR. And then I realized that this is nice to not to repair. And ever since Seattle meeting, my strategy changed to not to repair moderate TR. So do not repair moderate functional TR during mitral surgery. So let's start. I'm sorry. So I have no disclosures. So let me start from our two papers from Assam Medical Center. First one was written when I was a junior faculty 12 years ago. It is about mild moderate functional TR in rheumatic mechanical mitral replacement. At the time, we reviewed 236 patients and published in Heart, and there was a huge difference in terms of freedom from significant TR, defined by moderate or severe TR, between the two groups, indicating that repair is reasonable. But I found no significant differences in any of real clinical outcomes. Then I wanted to ask more kind of the search for answer from big cohort. And then I asked Sang-Gyun Ro. At the time, he was a fellow, and I supervised this research and covered almost 1,000 cases, including rheumatic degenerative mitral valve repair, replacement, and mild, moderate TR. And we found that there was no significant difference at all between the two groups in this large cohort. That I found that that's the point of view. So if you only take a look at the surrogate marker, it seems like it is good. It feels good. But in the end, I don't think it really helps people, patients, with regard to the long-term clinical outcomes. And then when Jae-seok Yu was in Sejong Hospital, we collaborated on asking questions on focusing on mild functional TR in the setting of rheumatic mitral surgery. It's a dual-center observational study between Asan and Bucheon Sejong Hospital, and we reviewed mild TR retrospectively in the setting of rheumatic mitral surgery. This is a huge cohort of 1,200 patients. Of this, 1/3 had a T-valve repair and 2/3 did not. The baseline profiles were masked by inverse probability treatment weighting, and baselines were so much well balanced between the two groups. In addition, we tried to adjust for surgeon factor as well as surgical EF factor very rigorously, and found out that cumulative mortality rate did not differ between the two groups, and heart failure, same. And the progression to severe TR, interestingly, was very similar across these two groups. And moderate TR included, these were similar between the two groups, indicating that there is no beneficial impact of repairing mild TR in the rheumatic mitral valve setting. And when you take a detailed look at the interaction of T-valve annular dimension as well as T-valve mitral surgical type, there was no interaction by annular dimension and types of mitral surgery, indicating that regardless of mitral surgery, whether it is a repair or replacement or T-valve annular dimension over 40 millimeters, then you don't have to repair mild tricuspid functional regurgitation. So we had a very strong conclusion that T-valve repair does not appear to offer benefit on prevention of developing TR, death, or heart failure events. And you know all you know about this. And in this particular study, you have to take a very detailed look at this. And this covers a setting of degenerative mitral surgery, and TR of moderate or less were included. And all these patients had T-valve annulus over 40 millimeter in the baseline, and they were randomized to two groups, having 200 cases in each group. So baseline profile is similar, but TR degree was different over the course of 2 years in favor of concomitant T-valve repair. But overall survival similar, and MACC-free survival similar, and then New York Functional Class similar, up to 2 months. So we wanted to take a more detailed look at the quality of life assessment through 4 different spectrum, and they're all similar. 6-minute walking test, similar. Why do we do mitral repair to these patients? So we have to, but as you saw, complete AV block and permanent pacer was 15 times increased by T-valve repair. And then conclusion, like this. The primary outcome difference was primarily driven by less frequent progression to severe TR. And there was more frequent permanent pacemaker implantation, and then whether reduced progression of TR results in long-term clinical benefit can be determined only with a longer follow-up, and now just 2 years. Then, how do we find it? I asked ChatGPT, and please identify large-scale cohort or randomized studies that compared in the setting of moderate TR between no repair, blah blah blah, and then he answered. 제가 확인한 범위 내에서는 moderate functional TR, there's no such study, but there's a risk of lying of ChatGPT because the hallucination may occur. So I tried something else, open evidence, endorsed by JAMA and New England Journal of Medicine and Cleveland Mayo Clinic. So I asked the same question: large-scale cohort study or randomized study and long-term follow-up. No study there. Everything is short and small. But there are some studies. He added some more explanation. There were some heterogeneous study, including mild and moderate, and there was a randomized study that we also, again, already saw this. And out of reference 2 to 7, the open evidence showed that mild, moderate functional tricuspid regurgitation setting with a large cohort, long-term follow-up, and then the studies have shown reduced progression of tricuspid regurgitation by repair of the T-valve, but do not consistently demonstrate a survival benefit. So I try to look at these 6 references here. So 2 to 7. Interestingly, out of these 6 papers, 3 are from Asan Medical Center. So I could conclude that Asan contributed significantly to the body of evidence in this field. So I'm so much grateful for that. So at this moment, what we need is large-scale, long-term follow-up data targeting real clinical endpoints, not just echo data, real clinical endpoint. And then this is what I have done for several weeks by myself to take a look at the over 20-year experience in Assam Medical Center to capture large cohort and long-term follow-up. So I did all the statistical works using R script, and I identified many patients covering 23 years of single center of Assam Medical Center to capture moderate functional TL in the setting of mitral surgery, and outcome of my interest was death, heart failure, and T-valve reoperation, because or it's composite. I tried to do propensity score matching to adjust for selection bias. I identified after a series of exclusion of 1.3 thousand cases, and out of this, 831 had T-valve repair, and the others did not. So propensity score matching yielded almost 400 pairs of patients well matched for all the baseline variables. And of note, the median follow-up period covered almost 10 years. There is no such data of over 1,000 cases, 10-year follow-up. Let's see. So after propensity score matching, almost everything, measurable variables were well balanced, and then these include all the available variables, including surgical years. And this is the results. Cumulative mortality rate, as expected, did not differ up to 20 years. And T-valve reoperation was significantly higher with T-valve surgery, interestingly. So there may be a kind of practice selection bias, because heart failure tend to be higher with no T-valve surgery in this group. Then as a composite, these were so comparable between the two groups without any statistical significance. So we could conclude that, I could conclude that T-valve repair does not appear to offer overt benefit on prevention of T-valve reoperation, death, or heart failure events. Then I can assume that we have evidence of absence. This is one evidence of absence, that T-valve repair benefit may be absent. Why is that? Moderate TL, it's a surrogate marker, but is adding T-valve surgery beneficial? I don't know. This is one of the explanation from Mass General Hospital 10 years ago, and published in JACC, and many of you recognize this. Even in the setting of severe TR, surgical benefit is not that vivid. So then, why moderate TR should essentially demonstrate the survival benefit in our kind of mitral valve settings? So even in severe TR, benefit of surgery still remain questionable. Torrential massive TR may be is benefited by surgery, but moderate TR, skeptical. And when I see the rhythm was important, atrial fibrillation without MACE had a greater incidence of death, and if you ablate by MACE procedure, the outcomes were almost similar to those with normal sinus rhythm. So our target should be elimination of atrial fibrillation, not repairing T-valve. And I will talk about it later in the next session, more in detail about this, atrial fibrillation and T-valve repair and outcomes. So ablation matters. So my conclusion, the cost of the T-valve surgery, concomitant T-valve repair in moderate TR has longer CPB time and AV block permanent pacer. This is not negligible issue. Concomitant T-valve repair improves post-op T-valve function, but whether this translates to improved long-term outcomes is questionable and very skeptical. In this regard, the T-valve repair in moderate functional TR may be psychiatric, psychological therapies only for surgeons, but not for patients. So importantly, if we want to treat patients, treat atrial fibrillation, not T-valve. Thank you for your attention. Arigatou gozaimasu.
All right, to counter this, Dr. Malesri. It's supposed to be a bloodbath, not shaking hands.
Thank you, JB. I'm glad to be going last because I could offer some rebuttal as well. Just to frame this correctly, we're not talking about isolated TR anymore. We're talking about concomitant TR at the time of left-sided heart disease. So you say you're doing mitral valve repair for mitral valve prolapse. You notice on the preoperative echocardiogram there's moderate TR. So what do you do with that? I'm going to debate that you should bring this. Thanks, Moritz, for giving all that data. And thanks to my worthy opponent. This is the second installment of our fact violence between me and Dr. J.B. Kim. The first one was last year. That was a well-fought debate. I'm going to punch back a little bit since I get to go second. There's two rebuttals I have for your debate. And the first thing is you're looking at the wrong endpoints. Long-term survival is not the endpoint here. There's so much better endpoints to look at than survival for concomitant TR. The second thing is you can't bring unpublished data to a debate and show it to me at the last second. This would not hold up in a court of law. There's no way you can't do that. That's unfair. That's unfair debate tactics. Okay, here are my points. I'll show you what is important with the guidelines to date. Second thing is the addition of concomitant TBR is safe. So that's really important. The second thing is concomitant TBR reduces the risk of TR progression. And I'll make a comment and show a video on this pacemaker risk, this GAMI paper that has hamstrung the field so much. Okay, the first. Who repairs concomitant severe TR? That's pretty much everybody. Here are the guidelines for moderate TR. And I'll show you again that it's a class 2A recommendation to fix moderate TR. I think this guideline isn't strong enough, and it's based pretty much solely on that 14% pacemaker risk that the CTS trial show. Mind you, that CTSN trial was a positive trial. It met positive endpoints, but the pacemaker rate was crazy, and you ask all the individual surgeons, was that you who did it? Dr. Bowling, was that you who had 14% pacemaker rate? Gilanoff, was that you? Dr. Gami, was that you? No, that wasn't me. So we revert to what we always do. We blame the Europeans. These are the two algorithms that are present. You could peruse them in the guideline statements. Moderate TR all goes to annuloplasty. Okay, first argument, progression of TR. Ringing moderate TR will reduce this. I can show you many things, but I think these are the two most powerful ones. The reason is because these are randomized clinical trials. This one is a European trial that shows that there is zero progression to severe TR after TB repair compared to a 24% risk if you don't repair that moderate TR. P-value is 0.001, but the most profound thing is that no one came back with severe TR after the ring. The one good thing that did come out of the CTSN trial showed that the addition of TV annuloplasty reduces progression by 91%, 0.6% progression. That's very low. I'll give you an added benefit of doing TV annuloplasty at the same time, and that is it increases the rate of RV recovery. In this trial by Joanna Chikwe, increased the rate of RV recovery by 40%. The curves are a little bit different because more patients in the annuloplasty group had RV dysfunction. So the separation of curves is what you should pay attention to, and that's statistically significant. The addition of TV repair is safe. So I've got strong arguments for this one. This is a paper from Europe, Julian Dreyfus. Many papers coming from this one. And take a look at the bottom line. In hospital death, patients without TV annuloplasty, 1%. In hospital death for patients who had annuloplasty, 1%. So there's no increased risk of adding TV annuloplasty. And here I will address that TV repair is safe and does not cause heart block. And I'll use J.B. Kim's own data against him in this. The Rowe paper from the Asan University quoted a permanent pacemaker risk after TV repair of only 1.6%. So in his hands also, the risk of permanent pacemaker is really, really low. So here's a video I made for you. I didn't play. Okay. They're labeled the anterior leaflet, posterior leaflet, and septal leaflet. I marked the commissures, and here is the anterior septal commissure, and there's the posterior septal commissure. That's the interventricular septum. The coronary sinus is there with the drop suction in there. That is the triangle of Koch, right there. So same case, and looking at it from a different angle, it gives you just enough room to put one stitch in the interventricular septum while missing the triangle of Koch. And the video cut out. I like to put two small ones. Some people do one big one, but you need at least one stitch in the interventricular septum to anchor your ring, and you should not get heart block. So conclusions. European and American guidelines recommend concomitant TV repair for moderate TR with a Class 2A recommendation. I don't think that's strong enough. I think it's hamstrung by the CTSN trial. Concomitant TV repair reduces the risk of TV progression, TR progression and promotes RV remodeling. I showed you the papers on that. The addition of concomitant TV repair is safe and should not increase permanent pacemaker rate if you do it correctly. So from Dr. Bowling's lecture this morning, TR is bad. Annuloplasty is good. Thank you very much.
Okay, thanks. Great talk and great analysis and summary. And we have 4 panelists, and Daniel Chan from Hong Kong, and Jae-Seok Jang from Daegu Catholic University Hospital, and Im Seok-kyung from Samsung Medical Center, and Jung Jun-chul from Seoul National University Hospital. So let's talk about that. Okay.
Let's change it. TR is bad, and I don't know, but worse is atrial fibrillation. So AFib is bad, and ablation is good. Okay? Yeah. So think about this. If the post-op TIVAL function, if it is so important, and if the RV function measured post-op is so important, shouldn't all the quality of life, 6-minute walking test, and New York Functional Class, shouldn't they be better up to 2 years after surgery with repair as compared to non-repair? If it is better, the quality of life should be better. Why is that? Why is all the things similar in the randomized trial?
Well, there's some trialists here, but I wouldn't expect much in terms of symptom improvement when you're fixing moderate TR. I mean, because they're not really suffering from moderate TR. The reason to fix moderate TRs is prophylaxis. You don't want the TR to progress. We may get some benefit with RV progression, but I really wouldn't expect symptom improvement with the additive fix of the moderate TR.
And do you really expect the superior outcomes, survival, or in a clinical standpoints, like a heart failure, TVAV reoperation, by the TVAV repair in the randomized cohort, the NEJM? Do you think so? So 200 pairs of cases, 10 years, 20 years follow-up, still underpowered. Even if we wait for 20 years, I bet we don't have clear answer. So we may need thousands of patients to demonstrate any survival benefit. And survival is the best important outcomes. What do you think, Dr. Bowling?
Okay, Steve.
So, thank you. Great debate. Chris won. You lost, JB. No, seriously, I was one of the designers of that New England Journal trial. And every single pair that both of you showed up there Why did they go to the operating room? They went to the operating room for their mitral disease. In the paper for the New England Journal, the vast majority of those patients had severe MR. We fixed their MR. You didn't show the results of MR. We did a really, really good job repairing all those valves. They had very little recurrence of MR. These patients are going to do fantastic. So, of course, there's not going to be any symptom benefit. They got all their symptomatic benefit from us fixing the mitral. We fixed them both in the mitral and in the one that had tricuspid annuloplasty. So all of those papers, we assume that we did a great job with the mitral. And of course, they're not going to have any 6-minute walk test difference because their biggest detriment was mitral. We fixed their mitral. So the second thing I have to say is, JB, would you rather have moderate TR or no TR? Just in a general biologic sense. You'd rather have no TR. So would I. I have no TR right now.
Ever since in Seattle running, I would prefer moderate TR.
There's no doubt that at some point in time, having moderate TR will hurt you. And that is what all this evidence says is, yeah, we fixed their mitral, and that's why there's no symptomatic difference, there's no mortality difference and so on, because they primarily came from the mitral. We fixed their mitral and did a good job. But when we leave them with progressive TR, we eventually will hurt them somehow. And it's safe to do.
So, let's see, all the beautiful Kaplan-Meier curves separating the survival depending on mild, moderate, severe TR is beautiful. But when you take a very detailed look at that, it's just a surrogate marker from my perspective because all the baseline profiles are different. The moderate, severe TR patients are older, sicker, and with greater comorbidity and renal failure prevailing. So we don't know clearly whether moderate or severe TR are a surrogate of bad conditions or that's causality. As you are a mathematician, we don't have any causal relationship demonstrated by real science. So answer, we don't know. But my policy, strategy, do or do not. Not doing so is not bad. Yeah. Atrial fibrillation, we have convincing evidence that ablation matters. But T-valve repair, questionable. So I'm okay with moderate TR. If I have normal sinus rhythm, preserved renal function, yeah, running marathon, moderate TR, tolerable. So even from aortic valve and mitral valve, moderate valvular insufficiency may not have significant impact on long-term survival. Why do we repair moderate AR or moderate MR? Then why TR? So small to me.
So I think for the whole audience, this is not just entertainment, but evidence. And as you start to think about how we're going to learn from this whole symposium, I think the clear thing we know is that we don't know everything. And I think the pursuit of evidence, which we'll talk about a little later this afternoon, will continue. Outstanding job, JB, for putting this together. I've not seen that yet, so if it's truly not published, the Annals wants it. So now one thing that neither of you presented. So both sides, you made very good arguments. I think JB won, though, sorry. TR, moderate or mild, in the clinical setting is very well tolerated. We have tons of patients with this. It's become a topic because now we have tools, and you will soon have tools in Korea. But one thing that you didn't mention is that one piece of evidence we definitely know from the TAVR literature, or TAVI literature, is the cost of a pacemaker, particularly in young patients. That we know that you have to put a pacemaker in a patient, that changes their life trajectory. RV pacing and their physiologic function. So please comment in the debate about you already made the mention of the cost and value of repair, elimination of the actual functional echo, but no change in quality of life and or survival. So yes, it makes us feel better, but talk about the price of a pacemaker. And I know you said you can do it easily. Not everybody can, but just debate that one point.
The issue of pacemaker is important if the patient has a pacemaker for a good reason. Sometimes the cardiologist will put a pacemaker in just to get the patient out of the hospital. They actually don't have heart block. If they have heart block, it's temporary heart block, and you look at it again in 90 days and it's all gone. So if you give that marathon runner a pacemaker, he will never have to use that pacemaker. His heart rate's going to go to 180. Ignore the pacemaker entirely. So you have to separate that out. I actually didn't read the paper close enough to see if that 14% pacemaker were all indicated. But we know that pacemakers go in non-indicated sometimes.
Concomitant T-valve repair is not a good reason for permanent pacer implantation. So you showed our ASAN data that we have very low rate of permanent pacer, even in a T-valve repair group. But we have to be honest that we are talking about science. The data should be reproducible and generalizable. ASAN is the center of excellence and the largest volume center in Korea, and it's not generalizable. So imagine, if we see the aortic valve replacement outcomes, mortality rate is around 0.5%, but all over the country, it is around 3%. So things are different. So we published guidelines that we have to repair moderate TR as class 1, level of evidence A. Then you're gonna see many patients coming in with permanent pacer implanted in the world. I don't like that.
Okay, Moritz, one quick question before we vote.
Well, yeah, it's not a question, so you can just go to votes if you want. But it was more a reframing of how we think about that. You know what doesn't hurt? High blood pressure. You know what doesn't hurt? Diabetes. All these things don't hurt until they really, really hurt. And the same is true with mild and moderate TR. I think anybody here will take a patient with a 6 centimeter ascending aorta to the operating room to replace that ascending. It doesn't hurt. So preventative surgery is not something we do very commonly, but I think concomitant TR falls into that bucket. That's it. Thank you.
Okay. All right, Daniel, who won?
Oh, can I make it even more complicated right now?
I'm going to ask 4.
Not allowed.
We have 30 seconds, so.
All right, okay. So both of you did a really, really good job. So if I want to choose, I don't know who won, you know. But I just, a quick question, if I make it like more complicated in a clinical scenario,
15
right?
seconds.
Oh, okay. So what I say, I vote for JB.
Okay. All right. Dr. Chen? Okay, yeah.
Okay, one last comment, please.
Dr. Kim, I have one question of your series. Your more than 1,000 case, the patient age 59, around 60, and the cause of mitral valve disease, mitral valve replacement, some include, most of them degenerative MR. Did you include the double valve disease also?
Double valve, yes. Yeah. So basically they are mitral, but we also included aortic valve.
Aortic also. So that is, I think yesterday I told the left side disease pattern is different presentation after 15, 20 years follow-up. So in degenerative MR, I think moderate TR might be all right, but another disease, double valve disease, mitral valve replacement with rheumatic disease, and there must be some problem, long-term follow-up. So the patient follow-up more than 15 years, probably the outcome slight difference. Degenerative MR might be all right. But if you follow up AFib major procedure, some of the patients return atrial fibrillation. So when do you think mitral valve, tricuspid valve repair in patient with moderate TR? When you consider.
So great question.
Yeah.
That question will be answered in Daegu, October, by my fellow Dr. Ju.
Kim.
서희주. Yeah. So we did,
Quickly.
yeah. Yeah. So we did extensive subgroup analysis to take a look at whether it is different in rheumatic, degenerative, or other settings, repair, replacement, all the same. Yeah. Regardless of the baseline kind of conditions, I didn't see any significant benefit by T-valve repair in any subgroup.
Okay, time's up. Okay, let's move next session. Okay, thank you.
Okay, so everyone,
Sorry,
thank you.
guys.
Yes. I have a announcement. It's now we will group photo for STS member. May I kindly ask all STS members comes up to the stage? It is now. Okay, so all STS members comes up to the stage. STS member. STS members. Okay, so now we will move on to the next session. Session number 6, its title is Tricuspid Regurgitation in Complex Clinical Scenario. This session will be chaired by Ki Sang and Junbam Kim.
I'm sorry for tight schedule. We quickly move to next section. First speaker is Dong-Sup Jung from Samsung Medical Center. He will talk about tricuspid valve regurgitation in STS patient.
Thank you for
Please.
introduction. I'm Dr. Jung from Samsung Medical Center. And it's a great honor to present here. Let's move very fast. We are out of time. So today I'd like to share my experience with the CTAP. as chronic thromboembolic pulmonary hypertension, and our investigation to TR management during the PEA, pulmonary endarterectomy. The CTAP often leads to the severe right-sided heart failure with TR as a common comorbidity. And while PEA is curative, the role of concomitant TL tricuspid annuloplasty is still unclear. So my topic is very straightforward today, that in patient with undergoing PEA for CTAP, if the patient has severe TR, the tricuspid annuloplasty is needed. This is the classic study that demonstrated the improvement in TR following pulmonary endarterectomy. So here we can see the typical echocardiographic findings before and after surgery. So many of these patients present with severe TR preoperatively. A significant number of patients experienced improvement. However, following a successful PEA, some residual TR can persist in some patients, which raises the important questions. Should we routinely address the tricuspid valve? This is the most recent paper about TL after PEA in CTAP patient from Japan. So according to this study, patients with preoperative severe TR showed improved right ventricular dimension postoperatively. However, residual TL was still observed in a significant number of patients. During the 4-year follow-up, the presence of residual TR was associated with significantly poorer, worse survival and higher incidence of cardiac events. So I'd like to share a case from my own hospital. This is the 47-year-old female patient who underwent the surgery in 2009. She had developed a sudden onset of dyspnea 3 weeks prior to the presentations and visited the ER. The transthoracic echocardiography revealed a severe pulmonary hypertension and right ventricular enlargement. She had already been diagnosed with CTAP at another hospital and was receiving anticoagulation therapy. However, her symptoms did not improve, and she was referred to our center for surgical treatment. The preoperative systolic PAP was as 69 millimercury, and echocardiographic also revealed the severe tricuspid regurgitation. So let me ask you, what would you do of this patient? Tricuspid valve repair or not? So Professor Pyo-won Park, who is here in this today, performed the tricuspid annuloplasty in this patient. Of course, there is the perfect performed the pulmonary endarterectomy. This patient had no residual TR, and not immediately after surgery, but even 15 years later. And of course, pulmonary hypertension also resolved completely. But let me ask you this. Was the disappearance of TL due to the tricuspid valve annuloplasty? Or was it simply the result of a successful PEA? Let's take a look at another case. This patient had been diagnosed much earlier and had lived with disease for a much longer period prior to surgery. The preoperative echocardiography showed the right ventricular systolic pressure over 100 millimercury. He also had severely impaired right ventricular function and severe TR, as we performed the TAP and pulmonary endarterectomy. However, mild residual TR was observed postoperatively. He continued to experience some degree of dyspnea postoperatively, but followed remained stable and regularly attended outpatient follow-up for 11 years. Unfortunately, he eventually stopped coming to our clinic, and upon follow-up investigation, we learned that he had suffered sudden cardiac death. So despite the persistent pulmonary hypertension and impaired right ventricular function, this patient did not develop significant TR during 11 years of follow-up. This suggested that tricuspid annuloplasty or repair remained effective over a long period, but here is a question I kept asking myself, and then would the outcome have been the same if we didn't perform the tricuspid repair? Or perhaps more interestingly, So if we had not repaired the tricuspid valve, with a progressive right ventricular dysfunction, have led to the worsening TR over time, possibly allowing the patient to compensate for the longer before a sudden cardiac death. At this paper, I'm about to introduce emphasize a critical point. Even when the pulmonary endarterectomy is very technically successful, sustained improvement in pulmonary hypertension is essential for long-term reduction of tricuspid regurgitations. This finding aligns well and with what we have observed in our own practice. The TR really improved completely unless the pulmonary artery pressure returned to normal. In other words, even after technically successful surgery, we must remain focused on postoperative pulmonary hypertension. This is the key determinant of long-term TR progression. This is the representative study from US showing the natural course of after PEA. If the pulmonary endarterectomy, PEA, is successful, meaning no residual pulmonary hypertension, and if the TR resolved accordingly, the patient can do well for about 14 years. Samsung Medical Center has established a new paradigm in surgical management of CTEPH, with the clear goal of a fully normalized pulmonary artery pressure. Our center's journey has been progressive, starting the pulmonary hypertension clinic in 2009, and introducing balloon pulmonary angioplasty in 2015, and becoming a full pulmonary hypertension center in 2020. These steps reflect a structured, team-based approach to managing this complex disease. So PA is considered a definitive treatment for CTEPH, but optimal outcomes requires more than surgical expertise, showing these guidelines. The class 1 BPA. The diagnosis and treatment of patients with CTEPH, the determination of treatment method, surgery, and post-op care should all be done as a team and are the class 1 guidelines. So as awareness of CTEPH increased, so our surgical case volume rose steadily, and higher cases number have allowed us to refine our surgical techniques, gather the meaningful outcome data. What is new in the surgical field? In the past, the surgical outcomes were largely dependent on the individual surgeon's technical skills. All attention was focused on the reducing pulmonary artery pressure. That was the singular goal. And post-operatively, we employed multimodal strategies to further reduce pulmonary hypertension only. This included the pharmacological agent, inhaled NO gas, and even ECMO when necessary. After extensive multidisciplinary discussion, so we decided to shift our focus from the pulmonary artery itself to right ventricular function. Our team agreed that reducing right ventricular afterload should be the primary target. And of course, the pressure on me to perform more perfect surgery. This is the video, the thoracoscopic video of PEA using the 5mm thoracoscope in type 4 CTEPH. Thoracoscopic approach assisted and PEA has been making me more easier complete PEA. As back bleeding after PEA is proven to be effective surgery. When the complete PEA is reached, the pulmonary artery pressure is normal in operating room. If not, we send the patient to the BPA in cardiology part. BPA is considered in pulmonary hypertension and in PH team, meeting usually after 6 months. After quite a bit effort, I was finally able to perform the kind of surgery our multidisciplinary team has in mind. So what you are looking at here is a series of specimens from our most recent consecutive cases. So now let me show our recent cases. This is 44-year-old female patient, a typical presentation of CTEPH, as we commonly see. She had severe TR at the time of diagnosis. So we performed the surgery with great care and intensity. As far as I could see, so all visible thromboembolic material was completely removed. In this case, we did not perform tricuspid annuloplasty. Both immediate after surgery and even 9 years later, the patient has this patient has no TR and continued to show excellent result. So I believe that the key factor was the complete resolution of pulmonary hypertension via PEA. If there had been a residual pulmonary hypertension in this patient, outcome could have been very different. Let me show you one more case. This patient had been diagnosed more than 6 years ago and had been struggling with complications, including the cerebral events, STH, while on warfarin. She also had a severe TR at the time of evaluation. Interestingly, there was a sign of acute the thrombus of acute thrombus of pulmonary embolism superimposed on the chronic CTEP. So however, most of the thromboembolic material was formally organized and difficult to remove in the far distal, indicating the disease had been present for a very long time. In fact, the right pulmonary artery was almost completely occluded. Postoperative echo was, frankly, a bit discouraging. The pulmonary hypertension remained largely unchanged. Surprisingly, however, TR had improved significantly. We later learned there had been a reperfusion injury in the right lung, but as her lung function gradually recovered, right ventricular afterload decreased, and explaining the improvement of TR. Remarkably, that even after 8 years later follow-up, these findings have remained stable. At this point, we analyzed every single case in detail in our hospital. So we analyzed a total 134 patients, among whom the 21 underwent tricuspid valve repair. It's because the baseline characteristics of the two groups were very significantly different, so we applied various statistical adjustment methods to identify the independent risk factors. The group had underwent tricuspid valve repair, showed more severe baseline tricuspid valve regurgitation. However, both groups who underwent tricuspid valve repair and those who did not repair showed significant improvement in TR grade, with no statistically significant difference between the two groups. We also analyzed right ventricular function changes. Both groups, with or without tricuspid valve repair, showed a similar degree of improvement in right ventricular function over time. And interestingly, despite the expectation that the group with the more severe TR would have more profound RV dysfunction, their long-term recovery was comparable to the non-repair group. As you might have already anticipated, both groups demonstrated comparable long-term clinical outcomes in terms of mortality and cardiac events. This is the key slide. This key slide shows the patient who underwent tricuspid valve repair had significantly higher early complication rates and longer hospital stays. Also, the long-term outcomes eventually matched those of the non-repair group. Thanks to the intensive management of our high-volume center, these findings raised doubts about whether the potential long-term benefits of repair truly justify its higher earlier risk in patients with severe TR and RV dysfunction. The most critical clinical implication is that only the persistent pulmonary hypertension, not the addition of TAP, is the independent predictors of residual TR. This means that TR is a secondary result of the underlying pulmonary vascular disease, and controlling pressure with an optimal PEA is the most crucial strategy for TR management. With this research, we submitted Annals of Thoracic Surgery last week. So challenges the conventional assumption that more surgical intervention guarantees better outcomes and present a new paradigm focused on the mastering the fundamental procedures to achieve success. In conclusion, in patients with CTEP undergoing pulmonary endarterectomy, routine TFE did not improve survival or TR recurrence, but increased perioperative complications. High-quality PEA and pulmonary hypertension control is the key in CTEP and with severe TR settings. Thank you for listening.
Thank you very much for your nice talk. Is there any question or comment from panels?
Dr. Wang from Seoul National University Hospital. Thank you for your nice lecture. And I have just a short question. So now you don't do any TAP even for severe TR?
Yes.
Yes,
Definitely.
Yes, it means you do.
In severe TR, in case of the incomplete PEA, incomplete PEA and with the severe TR, that is the question. But incomplete PEA and with the residual pulmonary hypertension, also the risk factor for right ventricular dysfunction. So complete removal of the tricuspid regurgitation is more harmful, I think. So medical management. Then even I removed some patient slides because of the time. Residual pulmonary hypertension and moderate TR can survive a very long time. So I think tricuspid angioplasty with functional setting, I think I didn't anymore.
Yeah, your data is quite similar with the best abstract session paper from Northwestern, that residual PVR or pulmonary hypertension must be a risk factor for TR recurrence. Thank you.
Yes. The same disease.
So for clarification, you said yes. That means no, right? You don't. Do
I didn't. I do not. I do not TAP. Yeah. No. Yes. In Korean style. I am not. I'm native Korean, far distant region. Chris?
Yeah, we also found that TR goes away after successful PT. It makes sense. PA pressure goes down, the RV gets smaller almost right away. RV function gets better, the annulus gets smaller. TR does go away with just PTE. So we've had about 18% of our patients with severe TR, and the recommendation at that time was to leave severe TR alone, which is a shock. It was a shock to us. But all that is level of C evidence, meaning it's like David Jenkins from Papworth and Mike Madonna from UCSD saying that you don't have to repair TR. So we believed him, and I sort of, bit my lip not treating these patients. We only did 3 patients with a TB annuloplasty. But the problem is it does come back in about 15% of patients, and the reason it comes back is because the pH comes back, which makes sense.
Yes.
The problem is I don't know which patients are going to have recurrent pulmonary hypertension 1 year down the road. Kevin Jin, our medical student, is looking into it, and our first look at it looks like the biggest preoperative risk factor is preoperative CVP, which makes sense to me because if the CVP is high, that means the RV is already failing from the pH. And that may be a differentiator for whether or not you do a TB annuloplasty. So right now we're sort of undecided. I'm favoring going back to putting annuloplasty rings on this.
Okay, so the same strategy to the pericardiectomy. As I'm doing the pericardiectomy, after pericardiectomy, functional TR is developed, and Mayo Clinic and every guidelines recommended a TAP because of the worsening of TR after surgery. But I waited for many years without a TB tricuspid annuloplasty with this setting, the TR removed. So long-term data, the adding TAP can make some worse early complication is my very fear. Everybody know that. So a little long-term, the right ventricular function is recovered. It's TR repair. without risk of pacemaker implantation, TR function, TV regurgitation is diminished, I hope. And so when I continued my strategy and I collected long-term data and I show the right data.
Thank you, Dr. Zhang. We have not enough time. We quickly move to the next presentation. Dr. Tsuyoshi Kaneko, he will talk about AFib-related severe TR maybe is necessary.
Yes, thank you very much. Again, thank you very much for the invitation. We are 20 minutes behind, and I think we can make this very quick. The answer is yes. So maybe we can just finish. Well, there are different etiologies in TR. This was the slide that we saw yesterday. But within this primary and secondary classification, in the secondary TR, now we know that there's atrial secondary TR and ventricular secondary TR. So what are these? What's different about these? So the atrial ones, the right atrial enlargement and dysfunction comes, whereas the ventricular one, it's the RV enlargement and dysfunction. And you see the right atrial enlargement versus the RV enlargement. The cause is basically AFib, whereas the VFTR, the cause is left side disease or pulmonary hypertension. There is an annular dilatation compared to the VFMR where the ventricle dilates. So the leaflet tethers on the VFTR, whereas the AFTR, it flattens. So that's a big difference between the two. And the prognosis of AFTR is variable, whereas the prognosis of VFTR is generally poor. This is a bad RV failure. So the 2025 ESC guidelines came up with this secondary mitral regurgitation with atrial SMR versus ventricular SMR. So this was the first time in the guidelines where they differentiated, this is mitral, we're talking about mitral valve disease, but they separated atrial and the ventricular. Again, very similar to what I mentioned between the two. I'm gonna skip some of these, but the criteria is very similar, and it's generated by the AFib on the atrial SMR side, whereas the VSMR is mainly from ischemic heart disease. So the treatment of atrial SMR now has a Class 2A indication for mitral valve surgery, whereas TEER, some of the early outcomes showed that the TEER outcomes in ASTR is not that, ASMR is not great, so it has Class 2B recommendation. And it does indicate within the text saying that if you're gonna do surgery, you better do AF ablation and also left atrial appendage occlusion in symptomatic patients. So these are the recommendations for atrial secondary MR. So how about ASTR? Did they mention it in the text? Yes, they did. They did say that there's two different types of TR, atrial secondary and ventricular secondary. However, what they also say is that for these TR, at advanced stages, these two phenotypes may no longer be distinguishable, meaning that they sort of get combined. They get enlarged, atrium, ventricle, everything's super big. So because there is no evidence right now, they just separate between primary and secondary, and we'll go over that at the end. So the prognosis, as I mentioned, towards the end, you're gonna get right-sided heart failure, even with ASTR. And you're gonna get the RVPA uncoupling, and some of these will really relate to poor outcomes. This is one of the scoring systems that was recently published in JACC journals. So the question about this ASTR, number one, what is the etiology and the prevalence? Number two, if AF is the etiology, does restoring sinus rhythm relate to better outcomes? You can just do a cardioversion and then get to the sinus restoration. Or can you do catheter ablation? And the crux of this talk is effective MAZE. And do you consider repairing in less than severe ASTR at the time of left-sided valve surgery? I think this is more of a critical question, although slightly out of topic from this talk. But we do have to realize that most of these data is not in ASTR, but most of the publication is in cases with TR with atrial fibrillation. This ASTR concept is very new, and I think we're gonna learn more and more about this in the future. So the etiology, other than AFib, there are other things that can cause this. ASD transplants, surprisingly, the left-sided valve surgery can also eventually cause this, but by far, AFib is the most common cause. This is a very old study, Framingham study, looking at AFib with moderate to severe TR. The prevalence is about 6.5%. However, in a larger Japanese trial, they showed that if you have AFib for 1 to 10 years, 17% of patients will have moderate to severe TR. And if you have it over 10 years, 25% of patients will have moderate to severe TR. So if you have AFib for a long period of time, there's a very good chance that you're going to develop tricuspid regurgitation subsequently. And what are the prognosis of these atrial secondary valve disease? Same paper from Japan. If you have ASMR or ASTR, your outcomes are worse. So these really translate to worse long-term outcomes. It's not moving. Okay, so talking about the restoration of the sinus rhythm. This is a very recent paper that looked at restoration of the sinus rhythm in patients who got admitted for paroxysmal AFib or persistent atrial fibrillation. Again, this is a medicine paper. This is not surgical paper. So they had, one group had non-spontaneous restoration of sinus rhythm, either through a medication or cardioversion. And within this group, there was a patient that had recurrence recurrence of atrial fibrillation, absence of restoration. And the other group was patients who remained in sinus rhythm. The other group was spontaneous restoration of sinus rhythm without doing anything particular, and whether they maintained or not subsequently. And when they compared the three, they showed that patients who had persistent atrial fibrillation had worse TR vena contracta compared to the other two groups. So how about catheter ablation this is mitral regurgitation, tricuspid regurgitation. This is a recent paper that was published. About 95% of patients had moderate TR and 5% had severe TR. And 51% with and 79% without recurrence showed TR improvement. So this shows that the catheter ablation in mitral regurgitation actually works. How about the effect of Mays in tricuspid regurgitation? So this is actually a paper from Seoul National University. I think this was introduced on the first day. Looking at 170 patients from 1994 to 97. There was 3 follow-ups, pre-op echo, post-op echo, and then a follow-up echocardiogram. And when they compared the outcomes between the patients who had atrial fibrillation and Mays and sinus rhythm, the patients with Mays group had less TR, lower systolic PA pressure, as well as a left atrial size compared to the AFib group. Another small paper from Mayo Clinic, 33 patients with moderate TR. The patient had persistent atrial fibrillation and had mitral valve surgery plus Mays. And this one had 3 follow-ups, pre, post, and 4.9 years. And when they compared the left atrial size, the patient with Mays had smaller LA size, and the TR grade decreased in the Mays group. So the Mays group with sinus rhythm had smaller left atrial size and less TR. This is probably the largest paper from China, looking at 20-year period mitral valve disease with persistent AFib. In 408 patients had biatrial Mays. These were all biatrial Mazes with mitral valve surgery, and they compared it to patients who only had mitral valve surgery. And mortality, reoperation, and moderate to severe TR were all less with the ablated patients. So again, there are 3 papers that have shown that Mays actually works in the light of tricuspid regurgitation. So I'm going to show you a couple of cases. 50-year-old male, 5-year history of AFib, now has class 2 symptoms. Heavy alcohol use, he drinks about 10 shots of whiskey every day. Chronic atrial fibrillation with severe MR and TR. And this was the preoperative echo. So severe MR, severe TR, normal LV, RV function. So what would you do in this case? JB, what would you do?
5 surgery.
So we ended up doing mitral valve repair, tricuspid valve repair. Sorry, I don't have the video because the guy was really big and I did it with a sternotomy. But we did tricuspid repair with a edge-to-edge on the anterior-posterior commissure, and then Cox-Maze 4 with left atrial occlusion, left atrial appendage occlusion, and this was the result. Currently 6 months out and is in sinus rhythm and is doing well. So far doing okay. The other question that we have is, should you repair a preoperative AFib with less than moderate TR? Again, this is slightly different from this topic. However, I think it is a very important topic. And this is paper from Northwestern Group from Dr. McCarthy, and looking at 14-year period of mitral valve disease and patients who had less than moderate TR. Most patients had tricuspid valve repair in this group, so less than moderate, but almost all of them had tricuspid valve repair, and 194 of them had surgical ablation at the same time. But what they showed was that if you have preoperative atrial fibrillation, the outcomes were worse, regardless of whether you did tricuspid valve repair or not. And if you had a recurrence of tricuspid regurgitation, it was associated with worse mortality. So again, it argues you probably should be doing tricuspid valve repair, but the more important question is to make sure that you keep that patient in sinus rhythm rather than the tricuspid valve repair. The second case that I'm going to show is 72-year-old female who had SAVR in 2010 with left-sided maze, followed by valve-in-valve TAVR. Now being referred for severe MR and TR, and now is in chronic atrial fibrillation with class 3 symptoms. So, we only had this reconstructed echo, but this was what they called as severe MR and severe TR. EF was 45%. However, after the patient was referred, we repeated the TEE, and this was what it showed. You can argue that this was probably underread, but they read it as mild MR and mild to moderate TR with normal LV and RV function. So in this case, what would you do? You have mild to moderate TR, mild MR with persistent atrial fibrillation. So would you consider surgery with maze, or would you do mitral valve repair and the tricuspid valve repair? So in this particular case, this was my colleague's case. It was not my case. But he did a redo Cox-Maze 4, and this was the result, mild MR and mild TR. But the big question is, should the patient have gotten mitral valve and tricuspid valve repair at the time of surgery? The patient's in sinus rhythm and is doing well, but to me, I think the TR was probably more than moderate. So I'm not going to go through all the treatment options for TR. I think people have spoken about this on the new ESC EX guideline. I think Moritz mentioned about some of this, so I think I'm going to try to skip this. But Moritz's guideline from the STS, 2023, surgical treatment for atrial fibrillation. If you have recommendations for operations even other than mitral valve surgery, surgical ablation for atrial fibrillation is recommended for any first-time, non-emergent, concomitant, non-mitral operation to restore sinus rhythm and improve long-term outcomes. So I think the bigger question in these cases is, if you have isolated TR with persistent atrial fibrillation, should we be doing biatrial maze in all cases for prevention of ASTR? We just don't have that evidence at this point. I'm going to finish a little bit talking about T-tier. Again, this is a surgical meeting, and we haven't really spoken about the TriClip. But the TriClip, I mentioned in the secondary MR group that the original report of doing TIR on atrial secondary MR was not that great. It showed that the efficacy was not that good. However, when they looked at the ASTR group, the outcomes were very similar to ventricular TR. And I almost think that probably the outcomes are not really great to begin with, so it doesn't really matter what pathology it is. But it does create an argument that even if you have ASTR, you can do a clip. So the third case is 86-year-old female who had AFib over 15 years. Again, 86, CKD with creatinine 1.9, very frail. I actually saw the patient and considered her prohibitive risk. And this was the preoperative TEE. And definitely has severe MR, but also has quite significant TR. The patient was not considered a M-tier candidate because of the MAC and also some increased gradient across the valve. So we were thinking about treating the mitral first, but not a tier candidate. So what we ended up doing was we did a T-tier, so tricuspid clip. And when you look at the echocardiogram, there was only one spot in that center that was leaking a lot. So we ended up putting one XTW, which is the bigger clip, and you will see that this was the result. I think the cardiologist called it trace to mild. So yes, the outcomes are not ideal, but if you select the right cases, they will get very good results. So I think that's what Dr. Badwar was saying throughout. Once these devices are approved, you will see a tsunami of these cases. And I think discounting these therapies will be very, very dangerous, I would say. So this patient, because the TR is gone, now will be a candidate for future transcatheter mitral valve trials. If you have severe TR, these are usually excluded. So now we're considering her for TMVR at this point. So several questions remain. I think we do need a better outcome for atrial secondary TR, not just AFib TR. For concomitant ASTR, MACE should be considered. As I mentioned first, I think the answer is very, very easy. But the bigger question is, should we be doing biatrial MACE for all these cases versus just doing a left side MACE? And we just don't have the evidence to support the biatrial MACE at this time. And I think the most important question for our specialty is, what is the role of surgery if you see a patient with isolated atrial secondary TR with atrial fibrillation? Is there a surgical role for these patients with a combination of tricuspid valve surgery and the MACE surgery? And lastly, what will be the role of catheter therapies in the lower risk patients with isolated atrial secondary TR and AFib? Thank you very much.
Thank you for good presentation. Is there any questions or comment from? Yeah.
Dr. Kaneko, thank you so much for your great presentation. I really enjoyed it. So your title, AF-related severe TR, MACE is necessary, you said yes. So based on your experience, in what kind of patients, which type of patients you might skip the MACE procedure?
Skip the MACE, yes. That's a very important question. You know, I think a lot of evidence shows that for any patients, you saw it in the guidelines, the class 1 recommendation for non-mitral valve surgery, you still should be doing MACE surgery. So in theory, we should be thinking about these MACE surgery for everyone. But if I'm concerned about a longer clamp time, I might skip the full MACE and just do the Encompass and just get away with the left-sided MACE. I might do that for very frail patients that I'm concerned about. I think the giant left atrium is, I think, one of the topics that we always debate. You know, I talk to Damiano all the time about these. And, you know, some of the cases he actually will recommend not to do it. So I think it's controversial, but I think very important topic.
Thank you so much.
Another thing is about the rhythm, the AFib rhythm. It's a very slow ventricular rhythm with the fine F wave.
Yeah.
If you do the MACE procedure for those TL patients, it's the patient high probability of the pacemaker.
Yes.
So that will be worse for the TL. Yeah. So in that case, what's your thought about that?
Yeah, I think we have to think hard. But those are very, very, it's not something that you can actually identify immediately in clinic. You have to get Holter, and you really have to thoroughly investigate. So I think that's sometimes the difficulty to do. But I will probably thoroughly work up, and if you don't find, if that's just a one sort of pinpoint that you're saying, and the rest, it comes with RVR, I would probably aggressively do a maze.
I'm sorry, Chris. We are far beyond our schedule, so can we move on? Yeah, so let me introduce next two speakers. I'm so pleased to welcome Dr. Vinay Badwar to talk about advancing tricuspid surgery, robotic and minimally invasive approach.
Well, thank you so much. I have no financial disclosures, but I have a few other disclosures. One is that I've been very fortunate to be part of the discovery of guidelines and areas of this topic, and I'll talk about in the next session. But part of that is that I have to disclose that I'm extremely impressed by the content of this meeting and the structure and the level of knowledge of the details. And the second disclosure, that I've known Steve Bowling for a quarter century. And the third, I changed my slides this morning and throughout the talks to make this a little bit more provocative. I, as many of you, are a very significant advocate of being aggressive with tricuspid regurgitation and pursuing ring annuloplasty. But for the sake of exploration, I thought I'd change my slides a little bit today. So I think the principles of what we're all here to do is to provide the safest and most effective solution to symptomatic tricuspid insufficiency for the right patient at the right time. That's what we've been talking about. And then to utilize all available evidence to inform heart team decisions. You will soon be approached by clinical trials of which we have touched on the transcatheter side. And these have been informed by quality of life only, not by hard endpoints. So utilizing data that J.B. Kim just showed today, I think it becomes very important. And then whenever possible, because we are approached with transcatheter alternatives, and soon you will be, we must be very careful. So this is I'm going to talk about 3 cases today. The first case is a typical patient. This is a 65-year-old patient who presents with primary mitral insufficiency. This is a robotic approach. And the patient had persistent atrial fibrillation, and this is a robotics Cox-Maze 3 procedure using cryoablation. 3 minutes of each left-sided lesion. First, the epicardial lesion. The second is the floor lesion extending into the left atrial appendage. The third lesion is the superior box lesion to create the complete encircling lesion. And then the fourth is the mitral completion line directly opposite the epicardial coronary sinus line. All of these are for 3 minutes. Then proceeding to the right atrial lesion. This is a biatrial lesion. This patient also had moderate to severe tricuspid insufficiency. A vertical atriotomy, and I'll explain in a moment, completion tricuspid line, and then the superior caval line, which is low and lateral to avoid the mid-right atrial body and the SA nodal complex. The right atrial appendage line is parallel to the SVC line to avoid this whole central body, and then the IVC line. That's the completion of the biatrial maze. Now, you can see already you can have excellent exposure robotically. The next is completion of management of the left atrial appendage, and then, of course, completing of the mitral valve repair. I know this is not a mitral meeting, but you can see this patient had also some MAC, but this is the completed mitral valve repair. And then proceeding from there to go on to the tricuspid repair. Now, in the incision, as you see, we talked earlier of not necessarily snaring, but the vertical atriotomy not only is good electrophysiologically, but it's excellent for tricuspid exposure done minimally invasive or robotically. So in this patient, the patient's annular dimension was 4.5 centimeters, 45 millimeters, and the patient had moderate to severe TR. And in this situation, the patient also was symptomatic, so this is a robotic completion of a tricuspid annuloplasty, exactly as many people have already shown today, with a rigid remodeling annuloplasty ring. In this case, it was, I think, a 30 millimeter ring to create competent tricuspid valve, and then closure, and then proceeding from there. Now, there's been a lot of comments made, but I want to channel what Kyungwon Kim's excellent presentation at the very beginning of this meeting to provide a spectrum. Now, I know we live in a world where there is dogmatism, and in some situations you do one thing and another thing. But I think in this field, I think we need to be pragmatic, not dogmatic, because we're still in the period of evidence generation. So I'm going to take another stance here. This is a 79-year-old woman who also had atrial fibrillation. She underwent a maze, but this patient came in with significant heart failure. She had significant mitral disease, significant MAC, and so this patient had a planned mitral valve replacement at 79 to 80 years old with significant tricuspid insufficiency and pulmonary hypertension. But her annulus was only 3.8 centimeters, or 38 millimeters. So what would you do in this situation? I think in this situation we can be selective with all of the techniques available to us. And so in this patient, she had a full biatrial Cox maze, but in this particular patient, with leaflet anatomy was favorable, I decided to do a de Vega operation. So yes, I still do a de Vega, but like anything, it is the technique that matters, and it's the selection that matters. It's very important to get very deep bites. I know there's a comment about hurting the aorta and aortic valve. You have to be really aggressive to hit the aorta. I don't think you should fear that. But the fear is if you make superficial bites, then you will fail. And then that is part of the reason why de Vega has not been attributed to so nicely. But I think if you make nice deep bites with your 3.0, or I prefer a 3.0 polypropylene suture, with solid pledget bites at the anchoring points, which you've already heard, which I will not be repetitive, but when you stagger these bites and do them so that all of the bites are in the annulus, the concern is if you make them too superficial or too atrial, then you're never going to get a reduction. But one little small trick when you're doing the de Vega, at this juncture, you snug it up, but don't snug it too tight, because I think Steve Bowling said, or others have said, that the most important area is that posterior annulus. And so, as you finish the de Vega, this is where you can tighten it. One advantage of the robotic approach is that you have 5 hands, one of which can control your tightening. And so you can do a saline test, do it dynamic, and as Steve said, you cannot get tricuspid stenosis. It is physically impossible. And so this is now tightening until you get an excellent result. And then following tying while you're holding exposure, and then closing the atriotomies to complete your final concomitant repair. And then finishing the tricuspid, mitral valve replacement. This is a total cord sparing. And this is the echo. So this echo is showing the mitral valve and then the tricuspid valve with really excellent hemodynamics, normal ventricular function, no TR, no TS. And this is a patient I did 2 years ago, and I've seen her echo last month, and there is no TR. And so I think not every patient fails if selected appropriately. We fixed the left side of the disease and fixed the right side of the disease, and she has class 1 symptoms. Now, one of the other challenges we've heard about is CAID. When you start to have the ability to do transcatheter tricuspid valve repair or replacement, some of these patients come very significant. Dr. J, you'd shown some patients that now, being a center for doing this, like many of the US surgeons are, that are here today, we see these patients like you had shown us. So, but sometimes they're not a candidate because they're an exclusion, because their annular size is so big. So this next patient is a 76-year-old patient that I did recently. And I've done this technique for the last 5 years that I'm going to just illustrate. And like J.B. Kim, this is not published, but will be soon. So this is similar to the cases that you've seen already. And the reason I raised my hand when I think, I can't remember who asked the poll, internal or external, is what I'm about to show you. So, so the first, this is a very dilated annulus. I think it was 70 millimeters or something. And the patient, very symptomatic heart failure. And so I decided to replace this valve. And so managing these leaflets are challenging sometimes. These are very repairable, and I agree. But I've chosen to do this technique. So instead of going through the valve or through a ring, I'll actually traverse the annulus. And this is safe. Remember, look at the cardiac anatomy. This is not, you're not hitting a circumflex, you're not hitting a vessel, but this is like a feeding jejunostomy, a Heineke-Mickels procedure, as you may remember from general surgery. And so by tunneling it, you then exteriorize the leads. And by doing so, one of the key things that our electrophysiology colleagues always want to know, don't jail them, because if they get infected, they can do a laser lead extraction. All of the techniques you've seen so far today, you cannot do a laser lead extraction. You have to surgically excise them because you have to go through the valve or go across a ring. So by so doing this, you can see it's mobile, and you can slide it. It's almost like a sliding tunnel. And after that, you close this, and then you can perform, in this case, a tricuspid valve replacement. I personally prefer to place them from the ventricular side and incorporating all of the leaflet without resection. I don't think you can really cause undue tension in these patients, and actually you may help the patient by preserving the leaflets and the chordal continuity. But go through the annulus. And you all know the annulus is somewhat suspect in the tricuspid, but this is generally how I particularly choose to do this. And then when you're approaching the AV nodal complex, as Chris Malasry just showed in his slides, is that you can go majority on the leaflet and just a shade on the annulus. So you completely avoid the AV nodal complex, and doing a replacement is possible without block. Now this is an important step. Once you place the valve in, deliver a little bit of lead into the ventricle to remove slack, because this becomes very important when the heart dilates. And therefore, you confirm its mobility. You cannot get a leak through that small little hole. Don't worry. And so that completes a tricuspid valve replacement in the setting of lead preservation and exteriorization. And something a little different, perhaps. And then you can see and confirm the leads are fully mobile in the ventricle at the end of the procedure. So, in summary, as you start to think about how to expand your practice, be engaged as the field of transcatheter therapies evolve. And that means follow evidence-based approaches to concomitant disease, as you've already heard, and really focus on RV and end organ optimization, and as Dr. J said, prehabilitation for safe, isolated tricuspid valve surgery, and then technique adaptation for minimally invasive techniques, because when this tsunami comes, you may not see patients any longer, because the de facto position is that tricuspid valve surgery is not done anymore. This is what they say in Europe right now. And that the mini right thoracotomy, peripheral cannulation beating heart is ideal for a straightforward replacement, particularly in endocarditis. Much of our tricuspid experience has been through endocarditis. And that robotic technology, when adapted, though minimally invasive is just fine, is really ideally suited for concomitant or isolated tricuspid valve surgery, either repair or replacement, patches, augmentation, multiple different things, particularly in endocarditis. But this focus area is in the evolution of tricuspid valve surgery. So I think this has been an outstanding meeting, and I congratulate the organizers. 감사합니다.
Thank you very much, Dr. Badwar. Excellent presentation, and it was a very fascinating technique to externalize the lead. Although we are beyond 20 minutes beyond of the schedule, we can accept one or two questions or comments from the floor or panel.
Quick question. very fragile patient, your concern is about to minimize the pump time. In that case, do you still pick the robotic? Because in your hands, sternotomy or direct vision mini thoracotomy will be much faster than robotic.
Yeah, so I'll just provide a little provocative answer. Let's be thoughtful, do the correct operation. All of you are excellent surgeons here. Do you really care about another 20 minutes of pump time? I think the most important thing is to do a precise operation. In our view, which is different than others, I will admit, I think the robotic technology can actually decrease morbidity. The speed of a sternotomy, we're all fast surgeons here. We all can do a fast tricuspid valve, no question. But the morbidity in some of these sick patients, like some of the ones that you showed, a minimally invasive robotic approach actually, I think, can improve outcome.
I totally agree, but my question is about robotic and mini thoracotomy.
Yeah.
So some robotics, we have to admit, maybe 20 to 30 minutes longer pump time for some patient. It can be problematic, those short times.
I think you can, just short answer to that, I think as you gain experience, it becomes a tool like any other. In our program, and some of you have visited, it's a regular case. It's a tool. It's not necessarily a added time. In fact, our times are such that it's no different than a mini thoracotomy incision. It's a matter of experience, yes.
Any comments, Dr. Jae-seok? You may have your own thoughts on robotic repair.
Robotic procedure, it requires more than 4 or 5 ports compared to direct vision thoracotomy or totally endoscopic approach. How do you think about it?
So we put the camera in the main working incision. It's a 3-centimeter incision for those that require concomitant mazes, 2 centimeters for just a repair, and then 3 ports. And so because the camera goes through the wound. So, and these are all like the size of your pinky nail, so yes, it's not a big deal.
Okay. As we have another special lecture from Dr. Barbara in the next session, let's look forward to the next speaker. I am pleased to welcome Dr. Sung-ji Park, one of the key leading imaging cardiologists in Samsung Medical Center. She's going to talk about TR in patients with severe RV dysfunction, balancing risks and benefit. Please.
It's a great honor to join this session. I'm Sung-ji Park from Samsung Medical Center. Maybe it's that I'm the only one cardiologist in this room, so I'm so scared. Yeah, my major is valvular heart disease, especially in structural heart disease, interventional imaging specialist. The next 20 minutes, I will talk as below is the TR and RV dysfunction, the relationship, and when is the optimal timing of tricuspid valve surgery, and is the how about the outcome in RV dysfunction. So first of all, chronic tricuspid regurgitation in right. First of all, how chronic TR and right heart failure works together. In left side, chronic TR increased the venous pressure, leading to hepatic congestion and impaired renal function. And right side, and chronic TR developed is the annulus dilation and coaptation defect worse, and finally is RV dilation further. The key important thing is later stage, this damage is irreversible. Recent 2025 ESC guidelines suggested the stepwise evaluation of the patient with tricuspid regurgitation. So it's the assessment of RV function as the cardiac MR and echo, and these guidelines suggested and emphasized the role of right heart catheterization for the evaluation of RA pressure. And this guideline also suggested the 3 score. T-score is the simple and is the practical tool to predict in-hospital mortality after the isolated tricuspid valve surgery. So T-score composed of those kind of things: age higher than 70, and NIH functional class, and right side heart failure sign, and daily dose of furosemide higher than 125, and GFR less than 30, and elevated total bilirubin, and RV ejection fraction less than 60, and moderate to severe RV dysfunction. But it's the moderate to severe RV dysfunction, the point is only one, and it's the higher tri-score above the 6. That time is the higher in-hospital mortality after the tricuspid valve surgery. So tri-score was actually developed in European population. So my question is that is also useful in Asian population. So Severance Cardiovascular Hospital and Samsung Medical Center and enrolled 202 patients with isolated tricuspid valve surgery for severe tricuspid regurgitation. Among them is the 81% was functional tricuspid regurgitation. Among those patients is moderate or severe RV dysfunction, the percentage was 22%. Here is the mortality. All-cause death was 11.4%, and the in-hospital death is 33.5%. So tri-score was validated in the Asian population to predict the in-hospital mortality and is the all-cause mortality after the isolated tricuspid valve surgery. As you see is that higher tri-score above the 6, that time is the all-cause death and in-hospital mortality was worse than the lower tri-score. ESC guideline suggested, same as the previous guideline, tricuspid valve surgery without severe RV dysfunction or severe pulmonary hypertension. So my question is, what is the definition of the exact RV dysfunction? What is the RV dysfunction? So we look at the RV dysfunction, how we measure the RV dysfunction. So ESC guideline also is the currently released guideline suggested and is the emphasized the multimodality imaging of right type function. So we use the echocardiography as TAPSE, TDI, fractional area change, and pre-wall strain, and 3D ejection fraction. And cardiac MR including RV dimension and trial volume and 3D ejection fraction. That is the abnormal value. TAPSE is less than 11, TDI S prime less than 9.5, fractional area change, and 2D free wall strain. Also, 3D ejection fraction was very important. And cardiac MR should decrease the RV function less than 45. So here is one patient, 74 years old, massive tricuspid regurgitation with atrial fibrillation, and is also he has non-small cell lung cancer and COPD. And massive tricuspid regurgitation, and how about the RV function? Pre-wall strain is the 30.3% decrease, and the 3D RV ejection fraction was 40% decreased. And interestingly, in the cardiac MR, RV ejection fraction was 35%. That was moderately decreased RVC3 dysfunction. So we discussed this patient in Valve team conference. So we calculated the tri-score. This patient, the tri-score was 5. So this patient predicted in-hospital mortality was 14%. So we decided that the tricuspid valve surgery is effective in this patient. So tricuspid angioplasty and modified Cox-Maze procedure was performed. Those echo image after the 6 months after operation. So good RV function and it's the no remnant tricuspid regurgitation. So I have a question. In my mind: is the RV dysfunction? Is this a really contraindication in isolated tricuspid valve surgery? So I look at those reference cited in this guideline. 95 isolated tricuspid valve surgery was enrolled in this retrospective study. Interestingly, this retrospective study showed the operative mortality was very low, is the 3.2. But in this study, emphasized the careful patient selection and pre-habilitation, including aggressive diuresis and millinone therapy, contributed to improve patient outcome. The other study, a single-center retrospective observational study with tricuspid valve surgery or without tricuspid valve surgery. In this study, is a major predictor of worse outcome was severe RV dysfunction. So the other study is from the Junbong Kim from Asan Medical Center is the load of the RA pressure for estimating the to predict the worst outcome in isolated tricuspid valve regurgitation surgery. So higher than RA pressure 15, so that it was worse outcome after the isolated tricuspid valve surgery. So timing is crucial. Delaying surgery until severe RV failure greatly increased operative risk. Earlier intervention before advanced RV dysfunction markedly improved the outcome. Contemporary data showed significantly better survival when TR surgery is performed at a less advanced stage. But in clinical practice, late referral issue was always developed. Patients have often been referred very late for tricuspid surgery, only after severe RV dysfunction and end-organ congestion developed. Once TR progressed to irreversible RV failure, surgical benefit is minimum. I agree with that. So what is the important RV remodeling, RV function in secondary tricuspid regurgitation? Interestingly, in this study enrolled 1,292 patients, moderate TR and severe TR. They divided 4 groups. Normal RV size and normal RV function, and RV dilation, normal RV function, and normal RV size and RV dysfunction, and RV dilation and RV dysfunction. As your expectation is the worst outcome should the pattern 4, RV dilation and RV dysfunction. However, that is an interesting point, is the pattern 3 and pattern 2. Pattern 3 and pattern 2 is the, pattern 3 is worse outcome compared to the pattern 2, and pattern 3 showed the normal RV size and RV dysfunction. So in this study showed the significant secondary tricuspid regurgitation, patients with RV systolic dysfunction have worse clinical outcome regardless of the presence of RV dilatation. So the other study, if the patient have preserved the RV, we expect the better outcome after the isolated tricuspid valve surgery. I also agree with that. In this study, the purpose of the effectiveness of the tricuspid valve repair and replacement. However, we look at those in red box. Tricuspid repair and tricuspid replacement, those red box is the baseline RV dysfunction and is the post-op RV function. Both those groups is baseline RV dysfunction worse. After the surgery, RV dysfunction getting worse. So before the RV dysfunction is we should perform the tricuspid valve surgery to get a good outcome. Severe RV dysfunction, in the patient have the severe RV dysfunction, what is the outcome? What is the outcome after the isolated tricuspid valve surgery? In this study showed the earlier surgery for functional tricuspid regurgitation compared to the structural tricuspid regurgitation. So functional, especially in functional TR, early intervention and early surgery is very effective in those kind of patients. So the other question is that if the patient has high TRI-score, higher than 6, the outcome, how the outcome of this patient? So 3 registry enrolled a multi-center registry in 3 centers and 10 countries, and 2,413 patients with severe isolated functional tricuspid regurgitation. In those trial registry composed of medical management and transcatheter therapy and isolated tricuspid valve surgery. So look at that is the low tri-score and intermediate tri-score and high tri-score. And low tri-score and intermediate tri-score is surgery and transcatheter repair or replacement with a successful procedure or improve the patient outcome compared to the conservative management. However, the high tri-score, higher than 6, and although the tricuspid valve surgery or the transcatheter therapy with the successful procedure did not improve the patient outcome compared to the conservative management. So this study also emphasized the high tri-score patient has showed the worse outcome after the surgery. So too late to operate. In my, I summarized those of clinical and hemodynamic criteria and lead prep criteria. Refractory right side heart failure with hypertension and massive hepatomegaly with cirrhosis increased the total bilirubin, and renal failure requiring dialysis, and cardiohepatic syndrome, and RA pressure higher, 15, and very low cardiac index, and MERD score higher than 18. So look at the RA pressure in 15, RA pressure. I introduced 2 patients, severe and massive tricuspid regurgitation. Left side is 78 male, and right side is 67 female. And it looks is the massive TR. And echocardiography estimated systolic PA pressure and 39 and 30, and estimated RA pressure in 15 and 15, same. However, we measured the parameter directly by the right-side cast. Mean RA pressure in left-sided patient has 6, and right-side patient is 22. So RA pressure higher than 15 is the worst predictor of the worst outcome after the isolated tricuspid regurgitation. But in real world, echocardiographic estimated RA pressure is not exact, is not correct, especially in severe tricuspid regurgitation. So in our hospital, in prospective single-center observational study, from the 2021, we enrolled 48 patients severe tricuspid regurgitation and simultaneously measuring echo and right-side cast parameter in our hospital. Until now yesterday is that we have the, not yesterday, last Friday, we enrolled 100 patients in those groups. So this baseline characteristic is the secondary TR was 89%. And this graph showed the Brandon analysis, and is the correlation graph showed the echo RA pressure and CAS RA pressure is well correlated. But look at that, is the estimated RA pressure 3 and 8 and 15. And those group is higher than estimated RA pressure is 15. So CAS RA pressure was very, very widely distributed. We focused on those group, and we suggested new criteria for estimated RA pressure. RA pressure estimation is the RV dilation and pressure, and is the other parameter, including 3, IVC collapsibility and hepatic vein systolic flow reversal and V-wave cutoff sign. And those kind of sign is the incremental value for estimation RA pressure. So this is the estimated RA pressure in the new echocardiography. RA pressure is very well correlated with simultaneously measured CAS RA pressure. So this is my take-home message. Don't wait too long. Refer for surgery early to maximize benefit. But in clinical practice, I'm the cardiologist, I'm the valve specialist, but the early report to surgery is very difficult. Because the patient, when take the patient diuresis, is the symptom improved, and patient doesn't want to go to the surgery. And second, assess RV and systemic impact. And third, high risk advanced tricuspid regurgitation. When tricuspid valve surgery is unlikely to help. So multidisciplinary approach is very important. Thank you for your attention.
Thank you very much for your insightful lecture. And now the discussion is open to floor and panel. But yeah, we may lose coffee break. And after that, we have a 2 consecutive hours of lecture. So we need a coffee break. So why don't we take only 1 or 2 comments or questions, beginning from Dr. Min-seok Choi. Please.
Totally or for the last? Yeah. I have a short question. Sung-ji Park, I wonder the role of a transcatheter tricuspid valve repair for patient with RV dysfunction, because I would hesitate to operate such patient.
Yeah. So I can hear the previous part is the question, so I didn't hear that is the previous.
The role of transcatheter tricuspid valve repair.
TTO,
Yeah.
So, as you know, this ESC guideline suggested the transcatheter tricuspid valve intervention class 2A indication for the severe tricuspid regurgitation. So the previous time is the 2AC indication, but this time is the 2A indication. But in my mind, in the transcatheter therapy, the Trans-Illuminator trial or is the Transcend trial should so the soft endpoint is the improvement KCCQ9, the kind of improvement, but they didn't show the hard endpoint is the improvement of the cardiovascular mortality or is the in-hospital mortality and all-cause mortality. But in my mind, in severe tricuspid regurgitation patient, the important thing is the symptom and it's the symptom and sign in severe tricuspid regurgitation. So the role of the tricuspid, transcatheter tricuspid of therapy in those kind of severe tricuspid regurgitation with the severe RV systolic dysfunction is that I prefer TTR compared to the tricuspid valve surgery. Only those kind of patients.
Thank you.
Super fast. I'm still disturbed about the under-referrals for TR. How does cardiology feel about a patient that has been admitted for heart failure, just flat-out heart failure, but has been optimally medical managed, comes to clinic with class 2, but the patient's been admitted with heart failure at one point. How do you view that patient? Do you refer that patient for intervention?
No. It's no. I didn't say that because it's the before intervention is the exact and it's a long time. GDMT is very essential for before the interventional treatment. So after the full time of high dose of GDMT, and we consider which is the better, the TTO or is the TTVR or the surgery in those kind of severe tricuspid regurgitation with severe RV dysfunction.
Short final question. You showed us TriScore over 6, sick patient. They are better with TTR than surgery. But you know, those failed RV patient has huge gap between the valves. So there are very dramatically low possibility of successful TTR. But if you try TTR, there are very low chance of repair. We have to replace it because there is something happening in the valve. So what is your opinion about that? Just straight go to the surgery or something happening in the valve and then we have to replace the valve. That is a disaster for us.
So is the important thing is the anatomically suitable case. Because it's the huge gap and it's the anatomically non-capable tricuspid valve. I can't. Yeah, so I'm not interventional cardiologist, I'm the imaging specialist, but I prefer surgery compared to the interventional treatment, but some patient with the severe RV dysfunction, I request to the cardiovascular surgeon, but the cardiovascular surgeon, not our hospital, and the cardiovascular surgeon hesitated to go to the tricuspid valve surgery because it's the severe RV dysfunction, and it's the very old age, 89 years old female. And those kind of patients, how do you do that? Yeah,
Technically, a TTR is not permitted in Korea, so I'll do operate. Yeah, 100% operate.
This is not a short question. So, thank you very much for elaborating the discussion. So we are now 15 minutes behind, and we are given 20 minutes of coffee break. But luckily, in the next session, I am given almost 30 minutes of speech. Let me cut out 15 minutes. Then we can enjoy 20 minutes of coffee break. Is it okay to you? Yeah. Let me close this session. Thank you so much. So we're gonna come back after 20 minutes, which will be 4:20. 힘들어.
네, 다음 세션을 시작하겠습니다. Next, we have two special lectures prepared. This session will be chaired by Professor Dong-Sub Chung and Professor Jun-Sung Kim. I would like to invite the chairperson to beginning the session.
말 너무 많이 했어. 아 형이 하세요. 뭐 정치고 형이 하세요. 신이어가 원래 하는 거야. 한다고? 6개월 차이 난다고 신이야. Good afternoon. Just we will start the next section. Yes, we are behind the time, so a very quick start we need. So let me introduce the bad word. We already met the last sessions. Yes, the title of the Professor Badwar is what will be the role of the cardiac surgeons in treatment of isolated TR? Please.
Thank you so much. So the topic, as you can see here, is that I was assigned was what will be the role of the cardiac surgeon in isolated tricuspid valve surgery from a leadership perspective. I have no disclosures. I modified the slide I just showed in the previous session to say that our goal must be to provide the safest, most effective solution for symptomatic TR for the right patient at the right time, but all available evidence. And I want to reemphasize all available evidence to inform the heart team. This becomes very important because in Europe and in the United States, the evidence bar is changing, and the attention to just a couple of industry-driven trials is the key focus, and not everybody is listening to all available evidence. So one area, as you saw already, is the STS risk model that you were comparing 466 patients in some of these trials to 13,000 patients, and looking at the overall population of an operative mortality of 5.5%, that is quite a robust risk model with multiple variables. And I'll come back to that in a moment. Now, when you look at the real-world evidence from transcatheter tricuspid valve replacement, it is sobering. The survival and the impact of TTVR. We can do a procedure and it's safe, but does it help patients? When we talk about hard endpoints, I think we have to question it. And I think part of the message today, continuing to question and pursue all evidence in making decisions, because this field is continuing to evolve. So what is the leadership engagement of our specialties? Because we're in a unified specialty. Our cardiology colleagues and cardiac surgical colleagues, we should be unified. And our goal is to keep that unity, and I'll go through that here today. So the first goal is evidence analysis and interpretation. So much as you do all, you appear to be very thoughtful, and you're reviewing every paper that comes out critically, looking at inclusion, exclusion criteria, the statistical methods. Continue to pursue that. And make sure that we value the evidence. The evidence tree was shown, or the pyramid was shown the other day, and we should continue to challenge that, because randomized evidence is at the top of the pyramid, but only if the trial is done well. And I think we have other evidence, and J.B. Kim just showed some, that we should always keep an eye on. The next, at a leadership level, is to then start to communicate with governing bodies. And I'm going to give you the example of the United States. Hopefully you can take what I'm about to say and apply that to Korea and across the Asia Pacific. And that is you all have heard about the Food and Drug Administration, but in specific, the medical device branch. And that is an august group that evaluates all new devices and looks at the appropriate evidence, be it mechanical valves, be it tissue valves, be it transcatheter devices. And then from there, we look back at once it gets to the level of consideration for approval, which is based on focused data. And let's be honest, the TTVR concept was approved on 97 patients. with minimal longitudinal follow-up and questionable comparators. So that was a bit of a shock to everyone, but we have the evidence, and now we have to create multi-societal consensus, and we are in the process of doing that. And that involves, you know, consensus on the interpretation of approvals, but also other elements, the guidelines, but also the tricuspid valve academic research consortium that you've heard. You've got some slides before. The next is then communicate with our funding bodies. You have approval bodies, the FDA, but approval does not mean payment. And so next you engage with the bodies that create payment. And that's, in the US, it's the Center for Medicaid and Medicare Services for the patients over 65. Usually what CMS says, the commercial insurance payers then follow suit. And there's two branches of the CMS. One is the Center for National Coverage Analysis, or NCA, and the other is the Center for National Coverage Decision. So the NCA interprets data with partners, such as the STS and ACC, for transcatheter therapies or surgical therapies. And then once you receive the analysis and you receive commentary, then there's what's called the NCD, and that's the decision which they can modify. CMS can take all the input we give and make their own decision. But they decide based on the evidence. So our goal within leadership of our specialties is to participate in this process, because this is where the decisions are made. So you saw some of the slides from this paper that we did in 2022 and 2023, and that's the first TVARC document. And honestly, that TVARC document, remember, this is now several years ago, was more of an exploration because the devices were coming. And in that situation, we looked at all of the historical technologies and new technologies. You've seen modifications of this slide before. Now, some are still available and some are not. And so there's a lot on this slide, but these are the areas where we were pursuing in 2022. And the only one that actually has a clinical trial in place, the green box, is the EVOKE trial here. You've seen this slide also from that document where we decided on the categorization of TR, and I think you've heard this already throughout the meeting, so I won't go into too much detail on primary versus secondary. But really what the goal of this was to identify the knowledge gaps. That, you know, how can we identify classifications for etiology? How can we extend TR severity grading scales? And that's where the massive and torrential emerged from this effort. You may remember that that was not a thing, but it became a thing, as you say, and we can debate this if there's time, on really what's the difference of taking someone from massive to severe. I'm not so sure we have that as a therapy, but and then how do we identify optimal medical therapy, different management strategies, and really, of course, patient selection. After that, and I'm kind of going in chronological order, then after we had approvals of TTVR and TTIR, then there was a national coverage analysis request. So that's when we all got together and created a response. And that response was for the requirements for intraoperative technical aspects of TTIR. This is transcatheter tricuspid repair. And that should be performed by at least 2 physicians working as co-operators. One should be an interventional echocardiographer, and they must serve as a co-operator. So our colleague that just presented last, hopefully she's here and is getting a priority, because as we start to do tricuspid therapy, you will very quickly realize it is totally imaging based. If you don't have good imaging, you don't have a good outcome. And then an interventional cardiologist, and this is important, or a cardiac surgeon. Not and, but or, because this does require one procedural operator as the other cooperator. Now, the interventional echocardiographer can't provide anesthesiology, so there's the different people in the thing. Now, at the heart team's discretion, and we inserted this, if appropriate, an additional physician, either another interventional cardiologist or a cardiac surgeon, can be involved as the third operator. Now, why this is important? Because it can be funded. You're not just there as a spectator, you're there as a participant that can be funded. So be engaged. That was the first point that we made today. Now the transcatheter tricuspid valve replacement national coverage decision response. The societies do maintain that due to the complexity of the TTVR procedure, the Coke can, and that a 3-physician operator should actively participate in the procedure until the institution can demonstrate consistent safety. 1 is an interventional echocardiographer for the reasons that I just mentioned for T-tier. The interventional echocardiographer can't provide anesthesia. 2 is an interventional cardiologist must provide expertise in vascular access, catheter management, wire manipulation, and device deployment. And a cardiac surgeon. Skilled in transcatheter valve procedures must provide additional expertise in catheter management, wire manipulation, device deployment, as well as intraprocedural complication management. When programs commence, the cardiac surgeon is an and, should and must be involved. However, once the program attains safety, the third operator becomes optional. And this is a signal for what's going to happen in the Asia-Pacific region and particularly in Korea. So you must be involved. We went further to describe the qualifications to initiate a TTR program, to have greater than or equal 50 open heart operations in the prior year, greater than 20 in the last 2 years prior to program initiation of tricuspid valve operations. They can be repair or replacement. At least 2 physicians, at least 1 interventional cardiologist, at least 1 cardiac electrophysiologist, but also have skills in the heart team and using other transcatheter procedures, such as greater than 100 TAVIs, greater than or equal to 20 tiers, so that's M tier, mitral tiers, per year, or greater than 200 TAVRs or 40 over 2 years. And then a complete TE schedule of greater than 200 TEEs or 400 in the previous year. To maintain a program, so that's the initiation of a program, but to maintain a program, you should do at least 20 transcatheter or surgical procedures, of which at least 10 are transcatheter, and at least 5 in the first year, or in 1 year, or these cumulations. And the initial complement of specialty must be maintained. So in other words, the combination of all 3 operators. And then the transcatheter structural cases, at least 50 per year and over 100 in the previous 2 years. That's all transcatheter procedures. And then the primary catheter operator, which can be a cardiologist or a surgeon, should be greater than 50 career structural valve procedures, of which at least 25 are tier procedures, so mitral tiers, or tricuspid tiers in this case. Or a combination of both, and then basic certification and training. This will all be published in an upcoming JACC publication that has taken quite a bit of time to put together. That's a combination of the ACC, AHA, American Society of Echo, Heart Rhythm Society, and the STS that will be coming hopefully in JACC here pretty soon, but I've just summarized all of this. This is also available online because they were part of our Joint Society public comment period to the CMS. Now, you've seen multiple parts of the guideline, but we haven't talked about isolated severe tricuspid regurgitation without left-sided disease. This is the EACTS and ESC guidelines. It's important to note here that, that the 2A recommend, this is all for tricuspid valve surgery. So for tricuspid valve surgery in asymptomatic patients who have RV dilatation, it's a 2A level of evidence C. That's important. It means if you have isolated tricuspid regurgitation, but you start to have dilatation of the ventricle, just like in mitral disease, remember, in primary MR, it is still a 2A indication to actually perform surgery. And that surgery can be considered in patients with severe secondary TR who are symptomatic or have RV dilatation as a 2A level of evidence B, and of course transcatheter interventions based on the randomized trial for TRISCEND 1 and 2, it's a 2A level of evidence A. But this is important because it does establish a flag in the ground for surgery. Now, I want to approach something that you will see more and more. You've heard TriScore mentioned all the time because that was a European-based scoring system. The Euroscore 2 is not really designed to analyze tricuspid and do reference to my very close European friends that are part of the Euroscore, not at all. It's not designed at all to talk about tricuspid. It's looking at overall risk. The TriScore looks at in-hospital mortality. It's based on 466 patients undergoing isolated tricuspid valve surgery in 12 centers in France. That's where the TriScore was developed. That's its cohort. Internal bootstrapping for validation. The model performance was good with a validation cohort of an AUC of 0.7 and the 1-year mortality of 0.78. So pretty good. But it only included 8 variables, and including a subjective variable of Lasix dose and right heart failure signs. That's open to interpretation, but it's been used in at least 4 retrospective studies. The TriValve score is recently a new one introduced that really looks at 12-month mortality or rehospitalization, and that's based on 483 patients on a registry. Again, internal bootstrapping, but validation okay, but not great at 0.681, but only 5 variables, including a subjective one of signs of right heart failure, and it's only been validated or used in 2 retrospective studies. The STS tricuspid score looks at operative morbidity or mortality based on 13,587 patients undergoing isolated tricuspid valve surgery, and 8,756 of those were not endocarditis, basically the same patients that are eligible for TTVR. 8,756. Their statistical cohort validation was 9-fold cross-validation. You all are fairly statistically sophisticated. You know that that's better. And AUC, far superior at 0.81 for our math guy in the room. And then there's 40 standardized variables, and now an online risk calculator. There is no more superior method of assessing risk of a patient for surgery than the STS risk calculator, which is now free online for everyone to use, as Dr. Kaneko showed the variables, very easy to use. So I will leave you a concept for a moment that as we start to think about the future, and we start to think about trial design, because that's the next frontier. How do we then pursue, how do we assess someone? First is the etiology-based approach. Is this a repair strategy, or is this a replacement strategy, or maybe somewhere in between? Once you do that, assess surgical risk using the STS risk calculator. If it's low risk, less than 4%, then that's really going to be in the future a surgery versus device analysis. If it's intermediate risk, surgery versus device, but maybe device versus device. Right now, the focus is on high risk, so greater than 8%, and looking at 1-year mortality, device versus device, 1-year mortality or heart failure rehospitalization, device versus optimal medical therapy, and then 1-year mortality that's very high, just medical therapy. This is unofficial, so please try not to take a picture of that just yet. But we will hopefully get back to you in the next few months about why you might see that again. So what should the specialty do? First, evidence is the currency of truth. We need data, and more data. Last night, I looked at PubMed. I asked a very simple question: tricuspid valve surgery outcomes. Since January 2025, there's been 380 publications in PubMed. Tricuspid valve surgery outcomes was the search criteria. 11 were actually tricuspid valve surgery. The rest was transcatheter valve operations. If we do not continue to pursue evidence of this forgotten valve, surgery will be forgotten. So we need to continue to pursue evidence. Technique evolution and experience brings improved outcomes. So as we start to think about tricuspid valve surgery, innovate, do it better, do it more specific, get good outcomes, because reproducibility and standardization of non-sternotomy approaches, if we're going to offer an alternative, is very important. But most importantly is engage as operators when TTVR comes. It's not that hard. I can see at least 3 or 4 of us in this room that are doing these right now. And it is highly structured and organized by the valve companies. Surgeons can do this procedure. But most importantly, and I'll conclude here, is to protect the integrity of the heart team. We have a situation that's growing that in Canada, for example, the actual function of the heart team, this is published in JAMA, has gone from 80-90% how they criteria down to about 45%. Here in Korea, you have a very good functioning heart team. In Europe, when it comes to transcatheter right now, the heart team's kind of soft because people have all but ignored tricuspid surgery. As part of these guideline discussions and expert consensus, it is amazing to me and all surgeons in the room when the response from our European colleagues is, well, no one does tricuspid surgery anymore, do they? No one does tricuspid surgery anymore. That's coming from our European cardiology colleagues. We've just spent the entire last day and a half talking about tricuspid valve surgery. So be careful. But our job is to embrace this technology not as a threat, but as an opportunity, and work together to cement the heart team, because this unifying approach to all evidence and clinical decisions must be kept intact, because there's forces that are coming that may try to threaten that. But I think this type of meeting, the thoughtfulness that you all have, is going to be very key for the future of this field. Thank you very much.
Thank you very much for great presentations. And is there any comments and questions on the floor? Dr. Kaneko?
Vinay, great.
Yes, please.
Great talk, and thank you for your leadership in engaging the surgeons in this field. I think it's very, very critical. However, I think over the years, TAVR, when it first started, 2 operators. MitraClip went down to 1 and/or, and then now tricuspid or. And my understanding is that in Korea, the surgeons are not involved in TAVI and MitraClips. So we can sort of see the future in the tricuspid in Korea. I don't know if the surgeons will be involved in this, right? So in these, there's global politics. And what should we do as a surgeon in a specialty where the politics are different? US was very lucky that surgeons were involved with the effort of the pioneers and also, political leader like yourself. But how can we, as sort of a, united specialty, work on this to make sure that we continue to be powerful in this field?
Yeah, I think I want to make sure I make a point that it's not us versus them here, right? I think it's us, and we should continue to be us. If we start to approach this as a threat, this is, I think who said it? You said it, or Chris Malasry said it, that it's an area that we don't get a lot of anyway, so what's the point? I think don't throw in the towel yet, which is, I think, what your point you're trying to make. Stay engaged, stay focused, be part of it, embrace the technology, because this can really help. I mean, you and I both put these in, and Steve Bowling puts them in, Chris puts them in. So it's a pretty straightforward procedure. The patient, it's very safe. If it's safe and it's appropriate, now, does it make a difference to long-term outcome? I don't know about that. We've already talked about this. But still, it's an option. And be engaged in embracing the technology in your hospitals. Now, I'll defer to the leaders of Korea here, but I think probably the lesson that we have from our American experience could be applied to the Korean national experience as you adopt this in your governing bodies to ensure that the cardiac surgeon's engaged. Whether eventually, as an operator, that remains in question, at least in the decision-making. That's the most important, because if the surgeon is totally saying, forgetting it, they won't even ask. Yeah. The key thing is to keep being asked to make the decision with the cardiology team.
Completely agree. The heart team is so important.
It's key.
Yes.
Thank you very much for your sharing your deep insight as a leader. And it's pretty much inspiring and motivating. And when we try to apply your thoughts and concept to the real world, I am confronted with some challenges. For example, Ho-Jin Kim is now mid-career surgeon in Assam Medical Center. I wanted to grow him as an interventional cardiac surgeon. Started with a TAVI room, sharing all the TAVI cases, and in the middle of open surgery. So it's kind of hybrid surgery, but hybrid surgeon. But in the end, all the facilities are already well occupied by interventional cardiologists, and there is only small room to intervene for cardiac surgeons to start with, and it's not kind of maintainable throughout our system. So what would you recommend for Korean cardiac surgeons, especially young surgeons, to overcome this kind of very institutional limitations where we want to figure out a way to embrace more interventional works, but things are pretty fixed and unchangeable when we view this in the everyday hospital life? What is your thoughts and what is your advice for us?
Two approaches. One is be a true peer to the interventional cardiologist, not an impediment. And what I mean by that is be as good as, through practice, through other experiences, as your interventional colleagues, so that you're considered a true colleague, so that when there's a complication, when there's a challenging anatomy, when there's a choice to be made, you're collaborating at the bedside, and you can both do the procedure the same way. The second is embrace it. Embrace the technology. So as a leader in your hospital, you be the one to go get the device and bring it and provide it to the program. And so that maybe not, Ho-Jin Kim's job, but maybe that's your job or another person's job to bring it in device. And you are the advocate, because it is. I mean, these are patients that we all have the same patients, but be the advocate to bring it in and then lead. But be as good as, if not better. The knowledge of three-dimensional anatomy, and particularly in the transcatheter mitral and tricuspid, no one knows it better than you as a surgeon. You've been there, you know the three-dimensional anatomy, you know clefts, you know indentations, you know where the clip needs to go, you know where the grasp needs to go. You understand the subvalvular apparatus and the papillary muscles more than anyone else in the room, including the imagers.
Yes, thank you. So I think we did well when it comes to your first answer. We really embrace and respect our peers. We have a really nice heart team in Assam Medical Center, and then we have a very nice discussion every Friday, having gimbap together. And then, but in the end, when I retrospect myself and Ho-Jin, then we so much are in love with open surgery. Yeah. So much prefer open surgery. Then we want to spend more time in open surgery, and that's another limitation. That's my weakness.
We all do. We all do. Yeah. But you can't have everything. Yes. Right.
Yes. Just I tried to remain silent, but JB just kept mentioning me. So, but so I think one of the most important thing is the reimbursement policy. So in Korea, government doesn't care. They do not mandate the cardiac surgeons to engage in TAVR procedure. So they just reimburse the interventional cardiologist. But to the best of my knowledge, in the States, it's mandatory for cardiac surgeons to be engaged in TAVR procedures. But during your really excellent lecture, I think you didn't mention about the reimbursement policy just to be engaged in the TTVR procedure. So can you just comment on this?
Sure, I'll answer it very briefly. I know we're getting at time probably, but in the U.S., and this has probably some reflection in Korea and in all countries, is that if it's suggested or mandated by the government for safety to have more than one operator, then in the U.S. example, you get 65% each of the potential reimbursement. So of the physician-based revenue cycle or physician-based compensation. Most U.S. physicians are employed by hospitals, the vast majority now. And so it's really the DRG group, basically the assignment of the thing, and that's one blanket funding that includes physician components, and it's up to the hospital to balance it or distribute it. And so in our facility, for example, I've arranged it so no one gets paid by procedures. They just get a salary. And so we generate that revenue and we distribute it evenly. So you can control that in your hospital, perhaps.
So in the future, just if the reimbursement policy changes somehow in the States, you think that all the policies that mandating the number of operators during the transcatheter therapy will change as well?
It may change, and I suspect it will change. And that may shift, at least not for transcatheter tricuspid right now, but probably for TAVI.
Yes, I forgot to introduce my friend and my colleague of my co-chairs, Professor Chun-Sung Kim, Bundang, Seoul National University Hospital Cardiac Surgeons. Next lectures will be introduced. Thank you for your presentation.
Yes, thank you for nice introduction for me. I'm Chun-Sung Kim from Seoul National University Bundang Hospital. Let me introduce the next speaker, outstanding speaker, Junbom J.B. Kim, very famous cardiac surgeon in Korea. Yeah, he will talk about the impact of AFib ablation on secondary TR in mitral valve surgery. Please start.
Thank you very much for a nice introduction. I have 11 minutes to finish, including Q&A. So I think I lied.
Don't worry about time, that we will control that.
Okay.
Please talk what you want to talk.
Let me be maximally effective and efficient. But before talking about atrial fibrillation and TR, I want to show some more important aspect of the meeting. To me, this meeting started on Wednesday morning time in front of the most expensive hotel in the middle of Gangnam area. So we met together at 7 a.m. and ran around Seokcheon Lake 2 rounds like this. It made up 5 kilometers, so fun time. And we did not only run, but we contemplated how the traditional surgical technique like double orifice technique translated into transcatheter mitral repair. It was so fun time. So this is mitral clip, successful. Afterward, we had a case sharing in the OR. Before that, we had a nice discussion. And then I was so much impressed by the so much passionate education from Dr. Bolling, and everybody in the room was so happy as you see this. Afterward, I shared my case, functional mitral tricuspid atrial fibrillation case with Dr. Bolling, and Masafumi Shibata sensei is assisting as a second assistant here. And in the next room, Chris Malesri supervised Ho Jin Kim's Ross operation. It was so fun time, happy moment. And this happy moment is well demonstrated by Dr. Shibata's comment while eating a Korean traditional rice cake. Take a look at this. It doesn't work. Go.
졸라 멋있어요.
Did you hear that? Yeah. Anyway, 졸라 맛있어요. So this is a picture we took with trainees, residents, yeah, all together. So happy moment. I think this is the core moment of this meeting with the learning from Chris and Stephen Bowling, and thank you very much for mentoring us and teaching us in this beautiful meeting. Okay, time to dive in. So I ended up with this data, unpublished data, and let me focus more onto the rhythm, like death and composite events associated with the rhythm status. And then I tried another analysis on AFib subgroup of almost 1,000 cases. And then I tried to compare between the two, ablation plus and minus. And as you can expect, death and composite events were amazingly different between the two. So I'm sure that it is much more important than T-valve repair. So we have to ablate to improve outcomes. So AFib is bad and ablation is good. So when I think back, I kind of recognize this finding from my very oldest study. It was 13 years ago when I was a fellow and then published a paper focusing on mechanical valve replacement in atrial fibrillation and try to look at the outcome differences between ablation plus and minus. So as you can expect, even in the mechanical valve replacement situation, the Maze procedure offered the protective effect against stroke. But more importantly, the TR was significantly different between the two groups after propensity score matching. I didn't expect this finding before contemplating the study design. But when I break down the subgroups to no T-valve repair group, it was also significant. And then even in T-valve repair subgroup, the trend was in favor of atrial fibrillation ablation. But the p-value was small, and not significant because of too small number of this subgroup. And another paper that I showed in my prior presentation showed a very similar finding that the outcomes were not different depending on the T-valve repair, but was affected by rhythm status, as you seen here in Kaplan-Meier curve, that AFib without ablation has very high incidence of severe TR developing, even in the baseline TR was mild. So in multivariable analysis, omission of surgical AFib ablation was associated with 4.5-fold increase in the risk of developing severe TR later on. And T-valve repair had a smaller impact than AFib ablation. So there are a number of papers, but when I study the initial two papers from Korea are identified, one from Seoul National University that I cited multiple times in this meeting, and I also appreciate Dr. J's the contribution that he showed that from Assam Medical Center data, Maze procedure was very protective against a progression of TR in the setting of mitral valve surgery. So in this study, both author groups demonstrate that Maze was the most important predictor of TR aggravation, and the T-valve repair might alleviate TR progression, but Maze had a more potent effect. So we have to ablate Maze operation. So another paper from Asan, Dr. Jae-Suk Yu's contribution has a little bit different point of view. So we also looked at the post-op AFib. So even if we do ablation, we see recurrence of AFib, and it had a profound impact on TR progression later on. So rhythm is so much important. And surgery is not the only one that prevents TR, but also in the world of catheter ablation, similar findings are observed, including our institutional EP division's paper published, and 70 papers undergoing RF ablation were analyzed. And then, as you see from this picture, the pre-op pre-interventional TR regressed to be smaller, much smaller, significantly in the quantitative measures, including vena contracta, tricuspid diameter, and RA area. The pathophysiology mechanism is pretty simple. So restoration sinus rhythm, restore the anatomical and functional reverse remodeling, and prevention of atrial and ventricular cardiomyopathy as well. It also induces ventricular regression, not only confined to the right atrial tissue. So when I come back to my original paper published in Circulation, I also unexpectedly found that every ejection fraction is affected by ablation. I didn't know that before, but ablation is not only helpful for restoring valvular function, AV valvular function, but it is very helpful to restore ventricular function. So I can say prevention of ventricular cardiomyopathy is expected by AFib ablation. Finally, let me share a short video clip of my ablating strategy. This is an aortic valve patient, and I wanted to remain small, and then this is a tricky method that I oftentimes make use of. I get access to the left atrium behind the aorta, and then above the pulmonary veins through left atrial roof. And then this is a recently available atrial device to exclude left atrial appendage effectively. Then this is followed by further exposure of the left atrium by tagging stitches. Then we apply a cryoablation device and make a pulmonary vein isolation, and additional the isthmus line is created. So I ablated 3 lines and then do aortic valve replacement as usual. So the schematic picture is like this. We got access to the array roof and made a pulmonary box region as well as isthmus region all together through a very small incision. So this is my concluding words. AFib ablation is effective in reducing and preventing TR in the setting of left side valve surgery, and then it is attributable to anatomical and functional remodeling. And ablation seems more effective than T-valve repair in restoring T-valve function and improving clinical outcomes. With the availability for more efficient tools like clipping, cryo, ablation has been safer, easier, and more reproducible. So therefore, AFib ablation should be prioritized for improving outcomes in left side valve surgery. The final picture. This morning, Chris again, we made another clipping on the very distorted annulus. Thank you very much.
Thank you for your short and informative lecture for less than 15 minutes. Yeah, you're right. Yeah, okay, so you comment about the tricuspid regurgitation T-valve approach is very conservative. However, you are very aggressive approach to the rhythm. Is that right?
Yes.
Yes. Okay, we have a very short minutes to discussion. Let me take up just one question from floor. Okay, Dr. Jeff, please.
Actually, I totally agree with your notion. But the thing is, if the rhythm is problematic, the main factor of the T-valve TR progression, sinus restoration should be the factor of the TR progression. But all of your papers dealing about delta about major procedure itself, it has another nuance of that things. Because for the biatrial major, you need to open the right atrium, and you check the annulus dimensions. So there are some, in your possible explanation, is there any bystander of the surgeon factor or procedure itself have some influence of the results? What is your thought about that? Not rhythm itself. Major procedure is more important for TR progression.
But more important is the post-op rhythm. So Dr. Jesok's used paper demonstrate that rhythm status is strongest factor to determine post-op T-valve function during the long stretch of follow-up. And then some of these papers are we did propensity matching, and then in that variables we also included surgeon factors, especially for those that of a two-center retrospective study of Bucheon Sejong Hospital, Asan Medical Center, and then we wanted to address your issue of surgeon factor, and then we demonstrate that even with the surgeon factor adjustment, the results were pretty reproducible. That ablation, intention, performance was very strong influencer to determine the later outcomes.
So your take-home message is you need to focus on the rhythm and open the LA and look at the T-valve and...
No.
No.
Yeah, even with the left side maze operation, left side only ablation, you can restore T-valve function in majority of cases. That is my hypothesis, and then the result-driven kind of my evidence.
So there are no effect between the left only or biatrial maze.
So think about it. We have a case of moderate functional TR, atrial fibrillation. Before our discussion in Seattle, let me explain. I would do T-valve repair, have to open the right atrium to leave some scar. Then I would add right side maze procedure inevitably. Now I would just leave TR there. I would not open right atrium. Then I would expect 80% of restoration of sinus rhythm only by left maze. Then outcomes will be pretty similar to biatrial maze, as we have demonstrated from multiple studies.
Okay, that makes sense.
Okay, let me make a last question as a moderator's power. Okay, in case of a very severe RV dysfunction with the AFib, you usually do the maze operation too?
Surely.
Plus TAP, is that right?
Severe TR, yes, TAP.
Yeah.
Yeah.
However, many valvular experts only do the TAP with atrial clip only, not use maze.
But you might have experiences that the post-operative tachycardia, atrial fibrillation, you add dopamine or norepinephrine, is pretty extreme.
Yeah.
And
however, in case of severe RV dysfunction, it does not independent from operation type. As mentioned before, the Professor Park Sung-ji.
Yes.
Yeah?
So severe RV dysfunction is not correctable factor. The only correctable factor is that we can decrease cardiopulmonary bypass time, aortic clamping time. But ablation to me is so important that I want to spend 5 or 10 more minutes. Meanwhile, I can be more efficient to decrease aortic clamping time by reducing unnecessary time. So we can be very effective and efficient. Meanwhile, we can still ablate. So I don't have almost no exclusion for ablating atrial fibrillation, even in cases of multiple times reoperation or emergency cases or put on ECMO. They are the patients who really need atrial fibrillation ablation so that we can restore some kind of manageable rhythm. Does it make sense?
Okay. So arrhythmia surgeons, I recommend more minutes to maze. 5 to 10 minutes is too short.
Okay, it's time to wrap up this session. Thank you for nice discussion and thank you for nice lecture. Thank you.
Okay, so we will move in the final session of our programs. The title of the session is Contemporary Challenger and Consideration Valvular Heart Disease. It will be chaired by Professor Lee Sak and Professor Choi Jae-sung, please.
Where's our distinguished panels? Yes, this is our final session today. Everyone looks a little sleepy, though. Welcome to the concluded session of this Heart Valve Disease Forum. I think it's been a fantastic journey so far, especially with STS members sitting here. So I'm excited to guide us through the final discussion. As you know, we have three different interesting topics. These are not about tricuspid valve, though. How do we go through after each presentation, and we will have a short discussion period to address any immediate thoughts and questions, and then move to the next topic. Today we have distinguished speakers and panels. Let me introduce panels first. Dongjin Kim from Bucheon Sejong Hospital, and Yoon-Seok Kim from Gaemyeong University, Dongsan Hospital, Chiun Lee, Busan National University Yangsan Hospital, and Min Jong-gu from Asan Medical Center. And lastly, Ji-Sung Kim from Chungnam National University Hospital. Yes, welcome. Let's move on to the first topic. Our first speaker is Professor Shunichi Fukuhara from University of Michigan. He's going to share the insights with the topic, challenging cases in severe AS, post-TAVI complications. Please.
Thank you so much. And I was afraid that there will be few people remaining in this room, but there are a bunch of people, so I'm very excited. So disclosures, this presentation has nothing to do with the tricuspid valve. So we have been talking about the TAVR explant pandemic, and Dr. Kaneko also talked about it yesterday in his lecture. STS database, the limitation is no index TAVR information and no follow-up data. So let's take a look at the Medicare fee-for-service data that I just presented a couple months ago at the New York Valves as a late-breaking presentation. So as you can see, so the green and the blue represent, so the blue is TAVR explant and then green is redo TAVR volume in Medicare population. Both redo TAVR and TAVR explant uptrending. And the percent TAVR explant is steadily between 40% to 50%. And the TAVR explant volume, I just overlapped the STS TAVR explant volume over this figure. So you can see TAVR explant volume of STS and the Medicare similar until 2017, and it's starting to separate afterwards. And this separation is very important because this is one of the papers recently published in JTCVS, but in certain states, such as California, New York, and New Jersey, patients with a severe AS, more than 50% of patients younger than 65 are receiving TAVR as of 2021. But if we look at go back to the Medicare data again, and then, this is not going to be perfect adjustment, but the, really intense adjustment, the propensity match plus multiple adjustment with multiple variables. So the adjusted survival, if we compare TAVR explant, which is red, and then redo TAVR, which is blue, the survival curve crosses before 2 years. And there is a significant difference for long-term survival. If we look, depict just the hazard ratio of each treatment, the TAVR explant becomes significantly less risky than redo TAVR at the 7th month. So I think the situation is probably starting to change as we have more and more longer-term data. If patients survive a perioperative phase after TAVR explant, the TAVR explant is actually yielding excellent long-term outcomes. So probably many of you know already about this, but the explant in TAVR valve is mostly straightforward, but the real problem is not the procedure itself. And this is a topic, I mean, this is just a straightforward TAVR explant. You can just simply twist and then pull out. Takes less than 10 seconds, but that's not the real problem. So the topic of this presentation is challenging cases. So I just picked a few extreme cases of this just this year within last few months. But so 73-year-old male, stethoscope 29 millimeter Evolut Pro in 2019. He was 67 at that time. Obviously, he was a low risk. And he had a new diagnosis of failing TAVR with a severe AS. And the CTA clearly showed no redo TAVR anatomy due to coronary obstruction risk. So he kept seeking second and third opinion, including renowned institutions in the US. He was everywhere over the past 8 months. And his symptoms got worse. And he was somehow started on apixaban for possible halt. It's not the halt, it's a structural valve degeneration. But nowadays, it's very hard to find a patient who are not on apixaban. Everybody is on it. So, and even after he presented with loss of consciousness, he was still managed medically. And then he was having diagnosed cath, left heart cath, and then he became hemodynamically unstable. He needed the emergent intubation. TE showed a new severe valvular AI plus severe MR. And he was placed on VA ECMO. However, he kept hemorrhaging from the ET tube. So they thought that this is just a severe pulmonary edema. So they advanced the venous cannula into the left atrium. So LA VA ECMO. Then somehow most Michigan, cardiologists somehow know my cell phone number, so they just started calling me. Dr. Fukuhara, I have a patient who's very sick, and without they say anything, I usually say yes. So, and all surgeons in their health system said, oh, he's not the surgical candidate. So he came to Michigan at 11 p.m. on a Friday, very typical Friday. So I used this new STS SAVR after TAVR calculator. I've never seen this high mortality. STS prom in this patient was 82.4% for isolated SAVR. So as soon as he arrived, our anesthesiologist was frozen because you can see massive hemorrhage, massive, from ET tube as well as traumatic intubation. And he was on apixaban until the day of operation, and he was getting heparin drip for LA VA ECMO. His arterial cannula was 29 French. I've never seen this big cannula in my life for artery. And then distal perfusion cannula in the DP, which is also interesting. As I mentioned, this was 11:54, patient entered the OR. So this is the intraoperative TEE, and then so the ECMO part, people kept saying we cannot flow. So as soon as I opened, I saw full of blood, and I started realizing maybe the cannula was in the pericardial space. Anyway, so I started arresting the heart. I can see that the leaflet fracture, possibly from the diagnostic cath. This was a fracture and caused acute AI. Anyway, the explant in this TAVR valve, nothing special, just you have to be patient and then separate the stent frame of the TAVR valve off the STJ first. And then once you get a good plane, then you can use any any clamp device, and then you can just extract this valve. You have to be just careful with the surrounding structure, but nothing is special on this part. And then, so my interest was what's happening to the left atrium. So I'm just looking at. So I found a hole on the pericardium, and then so the left atrium. So the LAVA ECMO venous cannula was exsanguinating the heart, and then basically draining the exsanguination within the pericardial space. So anyway, so this patient, he's not a small person, so if we just squeeze a relatively small SAVR valve, which is a 23, he's still young, so I just did a NICS enlargement, and he received a 25 millimeter bioprosthesis. He spent many days in the ICU, but he finally discharged recently. So next case, 78-year-old, state-exposed valve-in-valve TAVR 23 millimeter evolute FX plus. His patient has history with SAVR 21 millimeter Magna and the CABG ×4 using BIMA very recently, just a couple years ago. And then he developed a severe AS. And the valve-in-valve TAVR was performed, but that was complicated by valve embolization, the hemodynamic instability, and the time of arrival, almost to 10 p.m. Usual, I'm director of nighttime surgery anyway. So, and then, so this is again, this is an intra-op fluoro image of the procedure. And then, so unfortunately, this valve, which seems to be okay, but just got kicked out. And then what happened was, as they are trying to retrieve, the TAVR valve somehow flipped and then dislodged inside the subclavian artery where he has a patent lima on the opposite side, and he became hemodynamically unstable. So then he was emergently transferred to Michigan. Same story. They somehow got my cell phone, called me, and then I just said yes. But as you can imagine, this patient has a patent BIMA in the middle of the night. This is not pleasant, and he was unstable, so I had to go on bypass even before I started opening the chest. And then, anyway, so this was this is after opening the aortic arch. You can see the TAVR valve that's dislodged in the LSA flipped 180 degrees, which I've never seen, but I'm just retrieving this. So this part wasn't as difficult. It took probably less than 60 seconds. And then, there's an intimal tear, which we oftentimes see when, valve snaring was attempted. So anyway, so the uneventful aortic arch repair, but this is another impressive finding that the valve was totally fine. But take a look at this, bunch of plagets underneath. So this was the cause of AS. Again, this patient spent many days in the ICU and then floor, but finally he was discharged after, I think, 4 weeks or so hospital stay. This is not as extreme, but I just wanted to show you a very interesting case. This is actually our TAVR case, not outside. So this is us. So anyway, so she had a bicuspid valve. You can see very elliptical shape, but the index TAVR procedure is complicated by distal embolization with the TAVR. We implanted another one, and this TAVR in the aortic position degenerated, came back with a severe AS. She's only 64-year-old, but we are doing this procedure. But this is an explanted valve, same size valve. This is one in the arch. This is one in the aortic position. Look how different these two, including degeneration and the size. look how different. So this is what's going to happen. This is from the same patient, implanted at the same timing, and this is very interesting. Anyway, I just wanted to show you. Also, we have had opportunities to take care of these challenging cases. We had 6 TAVR explants in the presence of snorkel coronary stents. This is one of the most technically challenging cases I realized. You can see, so when those TAVR valve comes out, those stents will come out together with the TAVR. And then this case was okay, but you can see the stents keeps coming out. And then one of my colleagues actually took care of those cases, and the entire stent came out accidentally, and he felt it's okay. Then patient had a sudden onset of cardiac arrest in the ICU, and then just RCA was thrombosed on day 3, and then patient passed away. So I think when you see these snorkel stents in the setting of a TAVR explant, I think we should prepare for CABG. And then this is very important, but I just wanted to share. Another thing that probably we're gonna start seeing more and more is TAVR explant after redo TAVR. We have had 7 TAVR explants in this setting. And the 2 of them were actually our cases. Actually, we tried to put the SAPIEN inside the evolute at the node 4, and then just retrograde embolization, and we had to open. And then we realized that unlike the index TAVR, complication, this emergent opening in the setting of redo TAVR failure is a different, challenge. And then this is one of the ladies who had a TAVR in TAVR and then failed 8 months after the second TAVR, and then realized that this explanting TAVR valve is a little bit harder than usual. And then, it will come out eventually, but I noticed that I injured the anterior mitral leaflet as the TAVR valve comes out at the end. But I just primarily just oversaw this small perforation here. It wasn't a big deal, but this was the perforation I created. Or I don't know, the first TAVR was pushed by the second TAVR, I don't know, but I had to do this. But this type of scenario will be more and more in the next 5 to 10 years, I suspect. So, I always show this every time I talk about this topic, but these 5 valves came out from one patient. So patient had a surgical MVR, surgical AVR, TMVR, and then TAVR, and then redo TAVR. And then all of these procedures happened within 10 years. I think that every time reintervention happens, a patient sustains some type of a myocardial injury or pulmonary hypertension, and at the end of the day, those patients are too sick. So I just oftentimes feel, every time I see these patients, are we truly helping these patients? We had some mechanical valve talk next after my presentation, but I think we may be forgetting something more important, and then just, we are jumping on something fancy or sexy. I just feel we have to just stop and think about what we do every day now. But anyway, so we have had 17 commando procedures in the setting of TAVR explants, and the 40 hardwares came out from these 17 patients, 2.4 prostheses per patient. This is interesting. This is one of the extreme case of a commando. So this patient is a 48-year-old. Actually, Dr. Bowling is also involved. This patient, dialysis patient, and SVC stent is actually covering the coronary sinus orifice. I will show you. But the initial surgeon tried to put the TAVR first, then write the thoracotomy in the MVR, but it was aborted because of the SVC stent just prohibiting standard exposure. Dr. Bowling somehow did a left thoracotomy MVR, which I don't know, he can only do, I don't know. But anyway, unfortunately, he came back shortly with a severe prosthetic MS and a mixed severe ASAI of a TAVR valve. Very extreme. So I tried to put the retro in, but it didn't go. So I opened up the right atrium, and then still it's not going. Just the SVC stent is completely blocking the coronary sinus. So, but this is a chronic TAVR valve, so it doesn't come out right away. We cannot do direct osteo. So this is the first time I did a coronary sinus catheter insertion from an external, and using small olive tip catheter. This was just good enough to get at least myocardial protection as I expand the TAVR valve. But these are also really crazy hard case. But anyway, the rest of the part wasn't anything special. Usual TAVR explant commando procedure. And this patient, had a double mechanical valve. He actually did well, but he spent again more than 30 days in the hospital. So I just wanted to briefly talk about some myth related to TAVR explant, and then as our experience mature more, I think we are starting to clear those myths. So for instance, TAVR explant requires a frequent aortic root replacement. It's very rare. In our experience, it's only 6 to 7% for aortic injury related to TAVR explant trauma. Lots of aortic concomitant procedures are because of other reasons such as aneurysm, dissection, root abscess, or previous root bento procedure. So actual trauma is very rare. Tall frame TAVR valves should not be used because they are difficult to explant. We have done, probably more than 70 balloon expandable and more than 90 self-expandable. There's no difference. And then for double valve pathologies, let's fix the aortic valve with the TAVR first, and then do the isolated mitral. This is not going to help. But there are lots of people still think this is helpful. Probably occasionally helpful, but it will sometimes make the mitral surgery rather difficult. And then we are telling patients, let's do the TAVR for now and see what happens. Nothing will happen. Do not rely on something that does not exist. I'm starting to see patients I saw 2018. I saw the patient for TAVR, and then those patients are coming back, and then the patient was telling me, doctor, you said let's see what happens, and nothing happened. So I think that we should be a little bit more thoughtful about what we're gonna tell patients. So I think the lifetime management we talk about every day, it remains just conceptual without the supporting clinical data. And currently it's used a little bit more for marketing purpose. And then, we should avoid these extreme scenarios that I just showed. This can be avoided easily. I think the TAVR explant being safe operation, favorable long-term outcome, just showing this type of data, I think patients feel more comfortable, cardiology doctors feel more comfortable. So elective TAVR explant procedure, excellent procedure with a favorable long-term outcomes. And the heart team concept, it remains critically important. Thank you so much.
Thank you very much. You got through the nightmare, but actually I enjoyed what you've been doing through your video clip. As we all know, the TAVR procedure has been increased so dramatically. And I think we are getting more and more this kind of disastrous and strange and dangerous cases. Yeah. Any questions from the panelists?
Dr. Shinich, I truly impressed by your brave surgeries and tough cases. I have a simple question. Is there any inoperable cases for you?
If patients are dead, that's not the
Wait, I will answer that for Shin. The answer is no, absolutely not.
Any question?
Okay, we'll move on to the next topic. Thank you for your lecture, and it's my great pleasure to introduce Professor Jung Suryeon from Samsung Medical Center, who made great effort and contribution to this year's very successful meeting. And she will talk on optimal INR management for mechanical aortic valve. Please.
Thank you for introducing. I'm today is presented by optimal INR is measurement for mechanical aortic valve replacement. As compared with the bivalve valves, mechanical valves are known to offer superior long-term durability. So many classification and guideline, it just suggests that the young patient is adjustable mechanical prosthetic valve in aortic valve position in like guideline. So, but in the very big problems is mechanical aortic valve because we are always in exposure to thromboembolism. So if the patient have underwent in the AVR with the mechanical valve, we can keeping on lifelong warfarin medication. As you are always warfarin therapy inputs consider in combinations. In the current areas, when the average life expectancy approaches 80 years, the question is arise. What is the long-term quality of life for this patient after aortic valve replacement with the mechanical valve? Is there the restrictions and need for in the regular hospital visit significantly compromise their overall quality of life? As furthermore, even minor procedures such as dental treatment or simple surgery are companies in contrast concerned regarding the risk of bleeding and thromboembolisms during in the 15-20 years. It's too bad. So in light of this limitation, since the introduction of the direct oral anticoagulations as dabigatran in 2010, its numerous clinical trials have been conducted evaluated DOACs as potential alternative to warfarin in patients undergoing in the mechanical valve surgery. But then, however, the outcome is were disappointing. It's none of these trials have provided robust clinical evidence supporting the use in the DOAC in patients with mechanical valve replacement. So according to the most recent guidelines, continue designing the warfarin therapy after mechanical valve as a class 1, level 1 of evidence A recommendation. At this point, the questions became how we can use warfarin more safely, especially in patients undergoing mechanical aortic valve replacement, is what is optimal INR target, and can effectively reduce both thromboembolic complication and risk of bleeding. So according to the most recent guideline, in the absence of thrombotic factors such as rapid ventricular dysfunction, atrial fibrillation, or private stroke, in routine INR target of 2.0, 2 and 3 is recommended. However, in patients with a single tilting disc prostate or additional risk factor, the higher target range in 2.5 and 3.5 is advised. On particular note, in patients with high risk of rebleedings, guidelines suggest that in the aortic positions, a lower INR range in the 1.5 to 2.5, it may also be acceptable. But this is based in evidence, it's just one trial's Roaring IT study. This is, you know that in the compared outcomes between raw INR group and conventional INR group in patients with bi-repressed mechanical valve. But upon the close examination of the outcomes, it was noted that embolic and hemorrhagic event occur more frequently in the conventional group. but is less in evidence powered. The Western guideline is on a target. It's over the 1.5 to 2.5. It's recommended only for low-risk patient with a single bioreflex prosthesis in the aortic position. So we know that the risk of thromboembolism as bleeding in the warfarin is very depending on multiple factors. Therefore, so optimal INR should be determined by taking into account the entity, race, and type of thoracic valve, and associated comorbidity. Extensive research too has demonstrated that compared with Western populations, Asian patients face a higher risk of bleeding rather than thromboembolism while on warfarin therapy. Its genetics analysis have revealed that in Asian, the expression of CYP2C9, the enzyme response for the metabolism and inactive warfarin, is really lower than in Western population. In addition, genetics variation in VKORC1, the protein responsibility for recycling vitamin K, are more prevalent in Asia, leading those greater sensitivity to warfarin and consequently higher risk of bleeding, even equivalent dose. So because the Asian population have a higher bleeding propensity than the Western population, so we cannot accept the recent guidelines, so we are proposing in the low target INRs may be appreciated when they're using the warfarin. So let us now consider the optimal INR target in Asian populations. According to 2020 Japanese guideline, a recommended INR target is 2.02 to 2.5, which is slightly lower than suggested by the STS guideline. And regarding the concomitant use of warfarin and aspirin, the STS guideline assigned in the class 2A recommendations, but in Japanese guideline rate is as class 2B, indicating less proactive intervention. Okay, let us now turn to data from Korea. Although the sample size is relatively small, a study of 6 patients who underwent simple ABR is divided cohort into 3 groups according to their INR target and clinical event they were subsequently evaluated. With respect to patient characteristics, most receives either in St. Jude and comatose valve in higher INR level is generally maintained in those concomitant atrial fibrillation patients. Okay, excluding the patient with atrial PIPs who carry inherently high thromboembolic risk, the incidence of thromboembolic event over a 10 years period was not significantly different between low INR and high INR level. So our institution has also conducted a similar study. In a patient with a severe aortic stenosis, we stratified the valve type and adopted the lower INR target and 2.0 to 2.5 per order valve model and approximated 1.8 to 2.3 for bireplace valve new model with a follow over in the 8 years period. As a result, for bileaflet process such as St. Jude, Onyx, and Sorin valve in a new valve, a low INR target did not lead to increased risk of embolic event. So Asian peoples, including in the Koreans, Japanese, Chinese, is tolerable lower target INR 1.5 into 2.5 compared to the Western in guideline. And also, according to the valve, we know that the Onyx valve is main low in the thromboembolic event, so we can maintain in the 1.5 to 2.5. So based on this evidence and accumulated research, there is a growing anticipation that the Korean patient with bireplace prosthetic valve, it might be the drug may eventually serve as an alternative to warfarin. So everyone knows that innovative trials currently underway in Korea. We are looking forward in the promising result. Thank you for your attention.
Okay, we are now open for discussion for any questions or comments from the panelists. Okay. Dr. Kim.
Thank you for your excellent lectures. Then I have one question that if the Renovate trial showed a positive result in in Korea, then how should we interpret these results, and can we change the warfarin to rivaroxaban or DOAC in aortic valve patients with mechanical valve?
Wow, it's very difficult to say the answer. And if the might be is really is DOAC is non-inferior in the warfarin, I might be changes the DOAC in my patient, in young patient, in aortic valve replacement with mechanical valve. Because I experienced 2 patients in Northern this trial, and the study is in end, but in the DOAC is very, very high in the satisfactory. Many patients is wanted to DOAC than is warfarin. So the patient is now keep going on in DOAC. So if I would, most important is just in the clinical result, but if not inferior, I try to in the changes DOAC to warfarin is mechanical valve in within bireflex patient.
Dr. Barba?
Sure. So this is very interesting data. Congratulations on spearheading this. So you in your opening portion of your presentation, you talked about the CYP2C9 allele. But your study, I didn't get the sense that you're doing genetic testing to confirm the presence of that allele in the populations which you're applying in your study. Are you doing that confirmation? Just as an editor, I would want to make sure that you're studying the correct population so that the impact of your results are applicable to the right population. Because just because you happen to live in Korea doesn't necessarily mean you carry the allele. So how are you proving that link?
It's very difficult.
Do you think there should be a inclusion criteria to screen for the presence of that allele, where you have the ability to decrease the impact, to have the impact of the changing anticoagulation genetically directed? Because once the results, let's say your hypothesis is correct, and that it is safe or non-inferior to treat with DOAC, how are you going to apply that conclusion in a guideline or a direction to the population as a whole? Does the patient need to be screened to make sure that they're a candidate? Maybe that's a difficult question.
Yes, very difficult to say answers. Please, JB Kim.
JB, you have any ideas? I know that you're doing the clinical trial for DOAC.
Thank you. It's a good question. Difficult to answer, yeah, but let me start. So I have identified multiple papers, large cohort paper from China and South and Eastern Asian country, and including Korea, that target INL following guidelines is pretty much associated with the bleeding events higher. So our consensus is that lowering target INL would be better to balance between the stroke and bleeding. It's well known, but in the end, we don't know why. Genetic is one explanation, but the behaviors like food may be also a contributor to see the different kind of association. So we don't know. And then in the end, the trial, we are aiming for 1.3 thousand people in Korean population. So and then we came to right now at around 600 people, and then interim analysis have shown that we can go, can go, because the outcomes are not compromised. And then this is pretty much different from prior realignment or PROACT-10A trial. Why is that? Genetic is maybe one explanation, but more likely scenario is that behaviors or different drug, for example, apixaban twice a day may have some compliance issue, and then PROACT-10A trial happened in the COVID pandemic situations. But now we can examine the compliance of taking medication very nicely and precisely, and that the quality of follow may be different, and then ethnicity different, the people different, and genetic may be one explanation. So, but think about this. We don't want to run the genetic test for all mechanical valve patients. It's not practical. It's a real world. So we're gonna. The aim is to make it more generalizable and doable in a real practice.
Well, we encourage you, and I hope that you have the results. But as an investigator in the PROACT 10A trial, these were part of the challenges in many discussions. So I hope you're successful, especially since you're using all valves. You're not being selective to one valve or another. So good luck.
Thank you for your lecture. What is your target INR for mechanical aortic valve without risk factor? Your target INR is lower, such as 1.5 to 2.5. If your target INR is low, do you add aspirin?
If I have good questions, is my strategy for warfarin to target the 1.7 and 2.3. Usually, I did not in the additional aspirin because you are showing in the Japanese guideline, is additional in the aspirin is very risking the bleeding in the Asian people. So if you not in the risk factor is about in the thrombus embolism, so I'm not in the adding additionally aspirin routinely. I just keep going on just 1.7 and 2.7.
Just a simple question. How often do you follow the patient?
Oh, yes, very good question. So we are most important in just target INR. Also, it's a follow-up duration is also important to warfarin medication. In many guidelines, suggestion during the 3 months is visiting the hospital. But you know there is many Korean people is visiting Seoul in this not traffic. It's very crowded traffic. It's not difficult to in the 3 months visit my outpatient. So I usually is a follow-up just in the 5 months interval duration. But if the patient have in too high in the INR, too low INR, we are more closer in the intervention. We showed in the intervention duration just 1 and 2 months.
Just another question. Do you prefer any types of mechanical? What do you prefer? Is all the same or?
That's good questions. Especially in many study in the many evidences guideline. I prefer in the onyx valves is mechanical portion. Yes, right. No.
Why is that?
Because so that I saw that in this some graph is onyx valve in aortic valve is a low risk of thromboembolism targeting 1.5 to 2.5.
Is there any evidence because onyx is better than other types of valves?
I just showed some paper. It's not in the evidence paper. It's right.
Okay, last one.
My name is B.C. Zhang from Cha University. I'd like to compliment your excellent work. Where in 1980s and 90s, we have many thromboembolic complications and bleeding complications after my prosthetic valve with mechanical valve. We had the same results and published in the Journal of Heart Valve Disease at the time, and aortic valve target INR optimal INR was 1.8 to 2.3 or 2, and mitral valve 2.0 to 2.5. As Vinay asked for the genes, the cyclotron P23 was different with the Korean patients who had a high dose of coumadin because they have a different cytochrome P23 level of cytochrome P. So it is a great evidence for Korean people to manage the INR level with a mechanical heart valve. Thank you very much.
Thank you for comments.
Okay, thank you, Dr. Zhang. The very last speaker is Professor Hwan-Wook Kim from Seoul St. Mary's Hospital, and he will give us a talk on bioprosthetic valve degeneration, predictors, preventions, and indications for radio AVR. Please.
Thank you. I'm Dr. Hwan-Wook Kim, working in the St. Mary's Hospital in Seoul. The last talk in final session usually put less pressure to speaker, as you know, the less attention. Yeah, but now there are so many audiences making me feel nervous. Anyway, it's time to go to back to the home, so I'm gonna do a presentation real quick. Okay. The incidence of the prevalence of the heart valve disease are increasing worldwide with the aging of the population. But especially aortic stenosis is the most common valve disease, and the implantation of a first valve remains the only the available option for the treatment. But there is no perfect the prosthetic valve. So, but anyway, the age limit recommended to consider the implantation of the biostat valve is more down to 60 years in USA and in Europe, and more down to 50 years in USA. So we are going to, beat the patient with the valve destruction. Although the major determinant of a biostat valve durability is structural valve degeneration, but the exact pathophysiology is not yet fully understood. But a structural valve dysfunction must be the result of the multifactorial process. But the description is above my understanding, beyond my understanding. Anyway, the calcification is the common outcome of this process and primary cause of the bioplastic aortic valve dysfunction. So, structural valve disease have many definitions, but usually the genetically defined as permanent damage causing the hemodynamic dysfunction. To begin with, we need to focus on the term of the degeneration or dysfunction or deterioration. I googled the difference between the degeneration and dysfunction, but usually degeneration is physical deterioration of breakdown of cell. Usually this meaning is toward to the structural meaning. So I guess the dysfunction is a more correct term, I guess. I'm gonna start with the video clip. This is aortic valve disease. I refer to the prostate and aortic valve stenosis, but the aortic valve, the prostate aortic valve is normal, but the underlying the sewing link, the pannus is the circular formation of the pannus, may be causing the aortic stenosis. I'm not sure about that. This we can call this type of the valvular dysfunction is the biological functional degeneration. Because of this type of the destruction and dysfunction is caused by the pannus formation, not the structural degeneration. As you can see, you can see the patient this type of the degeneration in tissue valve, the calcification. Okay, there has been so many definitions in different papers. Classical traditional definition is permanent damage causing the hemodynamic dysfunction requiring surgical intervention. But the definition only based, but there are many patients is worsening prostate valve function is not candidate for the radio intervention owing to the high risk. So definition only based on the presence of high prostatic gradient is overestimate the incidence of structural valve dysfunction because the non-structural dysfunction causes the increased transprostatic valve gradient, such as the processes patient mismatch as pannus formation. Recently, one recommendation and two consensus statements present a standard definition of structural valve dysfunction and bioplastic valve failure. now commonly used this classification for the biostatic prostatic valve dysfunction. And first, according to this paper, we can see various modes of the bioprosthetic valve dysfunction. Biostatic valve dysfunction could be caused structural or non-structural, such as the Penn's formation and PPM. And separately, thrombosis and endocarditis are another cause for the valvular dysfunction. The main difference of these and this first two types and last two types is the thrombosis and endocarditis is sometimes reversible, some anticoagulation and antibiotics. We can characterize the extent of the biostatic valve degeneration based on the hemodynamic property. Usually moderate structural valvular degeneration is defined as the mean gradient to rest than 20 millimeter mercury, even with the evidence of morphological structural valve dysfunction. So, for example, another concept of the dysfunction of bioprocesses, that's called the bioprosthetic valve failure. Bioprosthetic valve failure is occurring in the setting of structural valve disease, but also as the consequence of the unrelated pathophysiological process unrelated to the structural degeneration, such as the thrombosis and endocarditis. So, to integrate the structural valve disease etiology with the clinical consequence and a new patient-oriented clinical endpoint named the biostatic valve failure is suggested for use in the future clinical study. Dr. DeVere proposed the structural valve dysfunction be categorized in different stages of the severity. His group think that structural valve disease is not the binary categorical parameter, but continuous variable, so taking place over years. The stage 0 is a state with hemodynamic change without the morphologic change, is a normal state. Stage 1 is the state of the without the hemodynamic sequel, even with the early morphological change. And like this. Dr. Saruan presented the summary of different classification, proposed these three documents. He put together into the one table. Anyway, the more greater than the mean pressure gradient is 20 millimeter mercury is needed to the treatment, re-intervention. More recently, Valve Academic Research Consortium 3 updated the endpoint definition of the aortic valve clinical research. On this page, they recommend the standardized definition of the bioprosthetic valve dysfunction and failure. And Jack emphasized it again in the following years. It's almost the same classification of definition as described in the previous three papers. The category is structural biological valve dysfunction and non-structural biological valve dysfunction, and separately, they separately their description of the valve thrombosis and valve endocarditis. This table shows the standard definition of the stage of the biostatic valve dysfunction. Stage 1, stage 2, stage 3. And stage 1 is the morphological valvular deterioration, but without the significant hemodynamic change. Yeah. Usually the stage 3 is most problematic to the surgeon and interventional cardiologist. Usually the clinical presentation is following like this. It's subclinical, and finally the biostatic valve failure. Usually this is the only for the term of the used in clinical paper for the clinical valvular to relate to the biological valve dysfunction and the clinical outcome. Yeah. This is the illustration in the check, the biostable valve dysfunction, how to approach the in patient with the biostable valve dysfunction or the bioprosthetic valve failure. Usually, we should differentiate the type of the valve dysfunction. So this patient is the structural valve deterioration or non-structural valve deterioration. If the patient does not have the non-structural valve dysfunction, this patient, we need to check this patient have the paravalvular leak or the PPM. So after checking the following the criteria, the most important thing is we need the hemodynamic change. Yeah, as I mentioned earlier, the mean pressure gradient is increased more than 20 millimeter mercury, and the patient have a clinical symptom. We need to redo surgery or re-intervention for the patient to relieve your patient's symptom. Yeah, this is make the table is bigger than for you to see. So then, yeah, maybe the last slide, the diagnostic and modality and marker. Yeah, usually the imaging biomarker, usually the echocardiogram most beautiful method for detection of the biological valve dysfunction. But there is MDCT is another good tool to detection of the valve thrombosis. So usually the hypoattenuated reflex thickening and the reduced reflex motion is a very pathogonomic finding to detection valve thrombosis in this finding. And surprisingly, new technique is emerging such as the PET-CT. The PET-CT is another tool for the detection for early stage of the valvular dysfunction, but there is not much study to prove this role. So we need to wait more time to get the more precise role of the PET-CT. This is usually known as the risk factor for the biological valve dysfunction. Young age, female, SHRF, smoking is also well known for initiate and precipitate the valvular dysfunction, such as the large BMI and high risk for the metabolic syndrome, and yeah, is another risk factor for the early valvular dysfunction. And valve-related factor, among the valve-related factor, the PPM is well known for the early degeneration of early degeneration for the bioprosthetic valve. Maybe this type of design of bioprosthetic valve, specific branded valve, but mostly these things are not used these days. And stented or stented valve and testiculated valve, another risk factor for the another factor for the early degeneration of biological valve. But the study result is not fully studied for the effect of the early degeneration. After preparing this paper, I found some interesting paper for the circulating biomarker for detection of valvular degeneration. But usually, this circulating biomarker is related to the calcium phosphate product, such as maybe precipitate the calcification in our body. Yeah. So anyway, this picture just showed how to manage to the in patient with the biostatic prostate valve dysfunction. Usually we check stage 1, stage 2, stage 3, and we need to check the following factor. And if the patient is in stage 3, we need to re-intervention, such as the reoperation or valve in valve, or such as interventional method. How to prevent the valve prostate dysfunction? I'm not sure about that, but this is the, maybe not related to the surgeon's care. This is maybe this role is to the company to product the bioprosthetic valve is responsible for the this topic. Yeah, this strategy. Usually the more advanced anti-calcification treatment and genetically modified low immunogenic animal tissue, and not fully guaranteed in paper, but starting on anticoagulant and matrix metalloproteinase inhibitor is maybe good to prevent the biological valve dysfunction. Yeah, that's it. Yeah.
Okay, thank you for your great lecture. So, what is the surgical indication for redo aortic valve replacement? I know that your institution have very aggressive interventional cardiologists, and they always do valve in valve. So, is there actual surgical indication for the valve degeneration?
Your inpatient with prostate valve degeneration?
Yes.
Usually, in my constitution, is very cardiology power is very strong and very well known for the TAVI center. Usually, if the patient is the age is the most important factor. Yeah, as you know, in South Korea, if the patient is over 80, the TAVI is more cheaper than surgery. Yeah, so usually, if the patient, the age of the patient is over 80, we usually recommend the TAVI procedure, valve in valve. But if the patient is under the 8 years old, I'm not sure about that, but usually the patient opinion is very important. In my center, the patient opinion is another good factor to decide the intervention, such as valve in valve or the reoperation. But our cardiologists already know about them. Many cardiac surgeons in other center in South Korea keep eye on them. So usually the cardiologist recommend to the surgeon to meet the patient to discuss the risk or the benefit or the risk factor. But maybe I guess maybe in this patient, 50% of patients want to the valve in valve. So this is another big problem in my center, but I guess yeah. Anyway, this problem is the most common problem in other centers, so I'm not sure about that. Yeah.
Okay, just one short question.
Short question?
Yeah, sure.
This can be long because there's a lot of masters here, and I want to ask a surgical tip, because removing TAVR valve, Dr. Fukura showed a perfect technique. And do you have any tips of removing the surgical valve for easily?
Surgical valve or TAVI valve?
Sometimes I remove the sutures, and then sometimes the valve comes out simply, but sometimes it's very stuck in the annulus, and it's very difficult to remove. And in that case, what do you have any tips or?
Do you mean the inpatient with the TAVI?
No.
Surgical valve?
Yes. And any other?
Usually, there is at the time of the removing the surgical surgical valve processes, we need to put the knife on the annular ring. Usually, the annular sewing ring is covered with the native tissue, so sometimes we cannot find the suture material. So we usually put the knife around the sewing ring, and then we spread the tissue using the fine mosquito fine mosquito. Then luckily we find the suture material. Then after grasping the suture material using the Kelly or Hasegawa, then cut the suture material. Usually, I'm not sure. I can't remember. This patient is so hard to remove the valve processes.
Okay, we have to finish this session. So, thank you very much for all the participants. And thank you.
Okay, this concludes our program at this forum. Finally, we have a closing remarks by Professor Kyung-Won Kim, President of Heart Valve Disease Forum.
Thank you. 슬라이드를 좀 보여주세요. First and most of all, I'd like to express my sincere gratitude to the international speakers and domestic speakers and faculty and attending medical staffs who devotedly participated in the lectures and discussions over past 2 days. Slide, please. Heartfelt look back at our heart valve event. Yesterday, the wet lab, the very enthusiastic discussions and the mentorship. And actually, many participants realized the internationally renowned speakers, they are really, really teachers. So I think you all have touched it. And this is the mentorship program, and the 6 mentor-mentee, the pairs, and gave them great instinct. And after the conference, we go to the traditional Korean the tavern. So I'm not sure the food was satisfactory, but actually we don't always eat like that. But anyways, actually one of our ideas was how about put the international speaker's photo in the logo of the soju. This is Korean traditional liquor, and with Korean character Hangul. So maybe yesterday Dr. Bowling told us you should keep the logo soju in your desk. Is that right? Please. Thank you. And this 2025 Heart Valve Disease Forum, the 339 participants from the 19 countries, domestic 272 and overseas 67. Thank you for your wonderful participation. And I'd like to thank our main sponsors, the Edwards, Diamond, Medtronic, LaFayette, Abbott, Gold, and Sangjin Medical Atricure, the Ace Korea Company, and Hansol Cardiac Care, Silver, and the Terumo MetLife, Dongha ST, and Jonggundang Bronze. Thank to our main sponsors. And next year's Heart Valve Disease Forum meeting, 2026, actually the Professor Sak Lee and Seung-hyun Lee will leading the conference program. And September 10, September 11, weekdays, not weekend, because most people do not like studying during weekend. So Thursday and Friday in downtown the Lotte Hotel, Sapphire Ballroom. So please save the date. Okay, thank you. And it's time to gather for group photo. And today is the faculty dinner. Starts at 7 o'clock in the evening. So near the maybe less than 5 minutes the taxi driving from the hotel lobby. So meet at the hotel lobby no later than 6:45. Thank you. Thank you for all participants. Thank you.